Access is intended towards future structural heart interventions, because how to safely go in and come out, this is where the gateway of structural heart intervention can be considered. So I will start with the program shortly, and to begin with, we'll start with lamp lighting and Saraswati Vandana. So may I request Dr. Prakash Hajra, Dr. Ravin Chakravarti, Dr. Aftab Khan, Dr. Kanak Mitra, and Dr. R.D. Yadav to please come for the lamp lighting. What we are going to do is to start the program. We'll start in 10 minutes, and in the meantime, we are going to do a three-dimensional analysis of a tower patient. Akash Purohit is there on Zoom. He will be doing an analysis in 10 minutes, and we'll have some questions, and then we'll formally start our first session. Arindam, yeah.
Hello.
Akash, are you there?
Yes, sir, I'm there. Yeah. Good morning,
So
sir.
we can't see you on the screen.
My camera is loading, sir. Just a second.
So we are about to begin our formal program from 10 o'clock. So we wanted to start at 9:45 with you. Maybe there was some communication gap. So I will be giving you 10 minutes to go through
Sure,
the analysis. And 2-3 minutes, there will be questions from here, and then we'll go with the today's agenda.
Sure, sir. Yeah. So my screen is visible, sir? Yeah.
No, we can't see your screen.
Screen can see. Okay.
So this is a patient who is 68 years with severe shortness of breath. He doesn't have any comorbidity as such, but he is very scared of any surgery being done on him. And he was counseled for surgical aortic valve by many cardiac surgeons, but he is preferring tower. So he approached us, and this is his three-dimensional analysis. This is important because this patient has 2 or 3 characteristics which goes, against tower also. So whether we should be going for tower procedure in this patient or not, we'll be having discussion. So Akash, you can go ahead.
Yes. Yes, sir. So now my screen is visible to you?
Yeah, we can see your screen. Yeah.
Yes. So here I have selected a random patient with a tricuspid aortic valve over here. So to visualize this.
This is Jadunandan, na? Jadunandan Yadav.
No, sir. This is the random patient. Which
Random patient. Okay, go ahead.
Yeah,
Go ahead.
yes. Because the scan is very clear, so it will be good for audience. Yes.
Yeah, please go ahead.
Yes. Yeah. So by clicking on automatic, this is a three-dimensional software. So here we will place the 3 nadirs over here. So nadir are the lowest most, middlemost point of each cusp. So this is the one of the cusp. This is right coronary cusp, left coronary cusp, and the non-coronary cusp. So what we will do, this is the cross-sectional image. So I am centralizing the cross-sectional image. The left coronary cusp, the coronal section shows me the lowest most point of the cusp. So I will place a dot. This dot we call as a nadir. So nadir is the lowest most, middlemost point of the cusp. Then I will central on the right coronary cusp. Similarly, I will place the dot. Then I will central on the non-coronary cusp. and I will place the dot. So once we place all the 3 dots, so this is called our annulus plane. So based on annulus plane, we decide the valve sizing, the coronary heights, the LVOT area, everything. So this is the first step for our analysis, tower analysis. So once we get the annulus, we confirm. And here are different measurement tools. I select the polygon and we'll measure the outer perimeter of the contrast-related part seen in the anatomy. So once we measure this, the software gives us the minimum diameter, maximum diameter, area derived, perimeter derived, area and the perimeter. So this is a stretch vessel. The software is done easy for us by doing a stretch vessel down. The anatomy can be seen in one straight line. So annulus, below annulus, approximately 3 mm, we measure the LVOT. So depending on the type of technology we use, the balloon expandable technology, the 3 mm LVOT is enough. For the self-expandable technology, you need to check 4 mm, 5 mm as well. So this is how we measure the LVOT. The technique of the measurement is same. Then we will see the widest motion of the sinuses. So I will check where my sinuses are the most widest. I will take a simple ruler and I will measure from the middle of the cusp to the opposite commissure. Same goes for the other two. So this is SOV diameters. The significance of SOV diameters are there should be enough roomy to occupy the native leaflet while we inflate the valve. So how we calculate these sinuses are enough? So we see area derived is 20.2. So we take a simple calculator. So we will multiply 20.2 multiplied by 1.2. Answer is 24.24. We will check. All the 3 are bigger than 24. So our SOV diameter should be at least 1.2 times bigger than the annulus area derived.
So, Akash,
Yes.
I think the audience here, they are quite acquainted with Tremencio software, and we just 2-3 minutes would like to discuss with you what are the fallacies. I tell you, yesterday only we analyzed a CT in our lab when the CT was done, and exactly same measurements came in Tremencio. The coronary heights left we measured 10.2, and 2 companies they gave the left coronary height 10.4, 10.5. Last patient, Dr. Rabin's patient, and the right coronary we measured 12. It was again 12.5. So and the annulus was also I think 1 or 2 millimeter difference. What are the kind of differences as per the observer who is looking at the Tremencio? Finer points like see a femoral CFA measurement will be equal by anyone.
Yeah.
And the difference is how you measure your annulus, exactly where you measure, and also the coronary height. So which part of the coronary you take? You see the
Sir, I always select
this is the only 2 points we want to discuss with you, and then we'll go with our agenda. We had 15 minutes time, so now we are encroaching in our main agenda time, so I don't want to take it, longer.
Sure, I will answer it shortly. So we always select the lowest portion of the coronary height, the lowest ostium over here. So I always use a small technique. This can be used by anyone. So while measuring the left coronary height, please remember you have to go from top to bottom, and you have to see a small gap in the cross-sectional image seen over here. As you can see, this black shadow, small gap. So that is exactly the lowest ostium of the left coronary height. So if I go a little bit up and down, obviously the measurement may differ. And for the right coronary height, I follow this rule. I will go from bottom to top, and I will keep an eye on the right coronary cusp on the cross-sectional image, and I will see a small peak coming over here. You notice this, sir?
Yeah.
A small peak, yeah. So that is exactly the lowest point of right coronary height. So in our report, we always measure the lowest ostium of the coronary heights, not the middle or not the top.
Yeah.
So that's why some differences may be there. Secondly, while measuring the annulus, as you mentioned, so we always double check the annulus by going, reselecting the dot again, and by Slowly we will come down and we will see the sinuses end, and that point we go in. Same we repeat for other two. So in our lab we repeat this activity at least 3 to 4 times. So we make sure that we are on accurate. This is how we get the accurate annulus. And also while measuring this, we sometimes over measure it or under measure it. So as we can see, there are some black shadows seen over here. So that can give some rod prediction. So we always make sure to be on the part of the contrast a little.
Great.
Yes, sir.
Thank you.
Yes.
Yeah. So thank you, Akash. I think these are important points. We have to take the coronary height at the lowest point of the ostium, not the middle one, which we generally do mistake. And second is when we define annulus, especially in calcified valve, we have to omit the hazy perimeter and the kind of surroundings. We have to take 2-3 measurements to make sure that we are right, because these 2-3 measurements take a toll on your procedure if it goes wrong. So with this, I again thank Akash to be there with us, and may I request the chairpersons and moderators for the first session to take this session forward. May I request Dr. Kanak Mitra, Dr. Biswajit Majumdar, Dr. Alok Majumdar to chair the session, and Dr. Ashish Haldar and Dr. Devapriya Mandal to moderate the session. Sir, please. Sir.
Good evening. Good morning, everybody, distinguished audience, and many seniors faculties are present here. So this is a very interesting workshop, I think, and very focused and very important, which Dilip and Dr. Hajraj arranged. And I think this will be very helpful for the juniors also, because coming days structural heart disease intervention and many large seeds are using, so it is a very important topic to discuss the various issues of large bore access. So today first topic is basics of vascular ultrasound, and speaker is Dr. Ijaz Ahmed Bari. I request Dr. Bari to deliver his talk.
Well, good morning everyone, and thank you the organizers, thank you my dear friend Dr. Dilip, and respected Sir Robin Chakravarti sir, and the panel out here, chairperson, and all the lovely audience. Time is less, so we'll start off with, I'll just give a basic overview about the basic part of ultrasound in terms of access. I am Dr. Ijaz and I head Department of Radiology at Medica Hospital. So without wasting time, we just go forward. So today's objective would be to evaluate and to identify the vessels. How do we go about the vasculature, preparation procedure before we go ahead, and the basic approaches, whether we go ahead with a short axis or a long axis approach, the techniques, the femoral and the peripheral ones, and if time permits, we'll definitely discuss about the recovery from failure and pitfalls and tricks. So normal ultrasound appearance, as we all know, because the blood has got fluid as a whole and it will always appear black. So this is what it is. We have the carotid artery out here and we have the internal jugular vein. We can see these appearing as black. So on ultrasound, anything fluid turns out to be black, and that is what it is represented out here. Veins should collapse when we give a compression, arteries won't. Now whenever we use an ultrasound, we better have it with Doppler. Doppler shows blood flow and it also shows the direction of the flow. Basic principle of Doppler is very simple. Anything which is flowing towards the transducer has got a red, and anything which is going away from the transducer is blue. For generalized, for more of a systemic approach, the arteries are made red and the veins blue. Apart from Doppler, we tend to have the spectral flow in Doppler, where it helps to differentiate arterial from venous flow, and we have specific waveforms for different arteries. And that is how we tend to, recognize arteries, their flow, their pattern, their velocity. So a spectral pattern of Doppler is also very useful out here. So basic principles of USG guidance is same regardless whether we are doing a peripheral line or a arterial or venous line, a central line or peripheral line. In fact, peripheral can be actually be harder rather than the central one. So the first and foremost requirement is an ultrasound machine with a high resolution linear probe. And the probe that we tend to use is of 5 to 13 megahertz. We tend to have 2 to 3 probes, a convex probe or a linear probe or a sector probe, but it all depends on the penetration. The more the frequency, the less the penetration. So we choose a probe which is close to 5 to 13 megahertz, and that is what we choose. One with color Doppler will always be useful. And the tools that we need is a sterile field with a probe cover. So, and some people can have a needle guide out here that we can see is attached to the probe, and a needle guider is used. But there are a lot of people, majority of the time we don't use a needle guider, but few people use it. In fact, needle guides have some drawbacks as well, so better we go freehand. Sterile probe sheet we tend to have, we can actually use a sterile gloves, put it in sterile gloves, and we can use a sterile jelly over the top of the glove. But as such, we can also have a sheet which can cover whole of the probe to make it more sterile, and the sterile gel also goes on top of the probe over the sheet. So why not just mark the anatomy and we go for a static guidance? No, AHRQ, the Agency for Health Research and Quality, says no, you should always use dynamic, because there is lower first pass success rate and lower overall success rate when we do a static guidance. When we mark the vessel and we go ahead, so the success rate falls down drastically. So approach to a vessel. In general, there are two approaches that we tend to go. One is a long axis along the longitudinal line of the vessel, and the other is the transverse, the short axis. The transverse gives a cross sectional, and the vessel appears as a circle out here. As it appears as, this is the internal jugular, this is the carotid, appears as a circle. And then we visualize the needle within the plane of the probe or out of it. So continuing with the transverse approach, easiest to find a vessel is the short axis. Whenever we try to access a vessel, first we try to get it on a transverse, and even the long axis approach technically starts with the vessel, which we start with the short axis, and then we turn the probe 90 degree to make it long axis. And then we scan whole of the vessel across its length, and once we have found, the important thing is the vessel should be directly in the middle of the screen of the ultrasound screen. So if we take IJ, if we are going to cannulate IJ, we ensure that the IJ is in the middle of the screen. Transverse approach, we continue with that. The line, we line the needle up directly in the center of the transducer and push the needle through the skin. I'll come to my next slides where I'm going to show how we are going to go ahead, how it does look like on a ultrasound screen. So whenever we are into the center of the probe, we put in the needle at the center of the transducer and push the needle, and we always try to locate the tip of the needle. And as we go across, we need to continuously watch the needle tip across the cross section, and slowly as the needle goes deeper and it connects to the vessel, we should be seeing it on the ultrasound. But what is important, how does it look like and how do we approach is this. So we have the probe here, and we keep the probe in the center of the vessel, and we ensure that the needle is also in the center of the probe, and we direct the needle at approximately 30 to 45 degrees angle, and we insert. As we insert, we ensure as the needle is going down deeper, we have to move the probe away from the site of insertion. This is how it will look like on an ultrasound screen. This is the vessel we are going to, needle, and this is what the needle tip will look like as it enters the skin. As we go down, we have to ensure that the probe moves away from the puncture site. As we move away, the needle tip, we can actually locate it very nicely to be lying between the skin and the vessel. So we have to ensure that the transducer is moving away from the puncture site. Again, as we go in, the needle almost reaches the vessel. My probe is also going away from the puncture site, and it's almost close to the vessel. This is what we see on the screen. And as the needle enters the vessel, we can actually see the needle tip within the vessel. So in transverse, as we move, we should be moving away from the puncture site at 90 degrees. So the needle tip is within the vessel, that is what we localize, and that is how we go ahead with a transverse approach. Now important is the short axis versus long axis approaches. There are a lot of debates going on, but people who are novices, they tend to go ahead with a short axis first, then a long axis. But as such, mean time to cannulate was less for short axis than long axis. But if we compare as a whole, the numbers of skin breaks was same for the same. The mean numbers of needle redirections were the same for SA and LA, and difficulty scores were the same for short axis approach and the long axis approach. So few pitfalls, you need to watch the needle very carefully because the transducer is in a 90-degree plane, and one of the just cannulated the carotid rather than putting across into the IJV. Very important that we always have the needle tip in our vision. Another case, needle tip loss, penetration of another vessel out here. Short axis, how sometimes we rather than cannulating the femoral artery, just went across into the femoral vein. So it's very important we use the Doppler, we use all the other modalities that we have to full utilization and go ahead with the approach. Now going ahead with a longitudinal approach, the vessel is seen as a tubular structure. As we can see out here, this is the carotid, this is the IJV. We need to angle the transducer slightly from side to side. That the short axis one, we were across 90 degree to the vessel. Here we are along the vessel. So the movement will be static on the vessel, and it will be just swaying right and left, side to side, and not to push it up the vessel. And this provides with a three-dimensional mental image so that the needle is steered into the vessel. So this is how the needle will enter into the vessel in a longitudinal axis if you try to locate it. So going from a short axis to a long axis, as we first identify the vessel in terms of short axis, then we turn the probe 90 degree and make it longitudinal. So that is how we go ahead with a long axis, but we always start with a short axis. So very important key things to remember out here in the long axis as well as the short axis is, do not move the transducer and the needle at the same time. If you are moving the needle in and we are moving the transducer at the same time in terms of long axis, then we are in trouble. So whenever we move the needle, we ensure that the transducer is frozen. And when we move the transducer, we ensure that the needle is frozen. Trying to move the two will always malalign our point of interaction into the vessel. So should we really use a long axis? Clinicians are better, I suppose everybody out here has been using, so are better at locating long axis than short axis, and they have easier time tracking the needle tip in terms of long axis than short axis. So some of the pitfalls that we had with the long axis, we penetrated the positive wall of the vessel out here, and find very important when we try to cannulate different vessels. First find the target vessel, make sure it is artery, turn long axis on, and we prepare for the cannulation. And we ensure that the needle, when we are putting it, it runs at approximately 30 to 45 degrees angle, and we also ensure that the needle is not lost, it is always seen to our eyes on the ultrasound machine. And whenever there is a needle penetration must be timed. If you are trying to cannulate a vein, so it is very important because here the veins was collapsed and the needle actually could not get into the vein. So this is also important that we time our entry into the vessel when we have the maximum distension of the veins. So this was something like trying this, cannulating this patient without ultrasound. Difficult, yes, but we did. Femoral lines can vary in their alignment. I am coming to the different axes. Make sure the vessel is patent, and we have the femoral artery and the femoral vein which is collapsed, compression, and
Dr.
then we
Jai,
go. Yes.
I think we have already 9 minutes have gone.
Yes. So I'll just make sure I'll go fast forward. we make sure the vessel is pated, we compress it, and compression should yield no collapse in terms of artery, and we can pick a different target, or occasionally the artery sits directly on top of the vein, then we choose a second target. And likewise also the radial artery, with radial artery we just need to ensure that the angulation is much more flatter, the slope is much more sloped, much more less acute, and we enter the radial artery. That is what we see in a radial artery line, that is what we go, and float guide wire accordingly. So the summary is ultrasound greatly improves first pass success and safety, and we use long axis for improved safety and precision. And if you see the needle and vein, we can cannulate almost anything, almost no limits anymore. And think peripheral when you just need good access, not the central. So ultrasound guidance, as with much of point of care, ultrasound can make a drastic impact on your patient care, and it is a weapon against complications, vascular access troubles and care delays. Any questions?
Yes, thank you, Dr. Barik, for your nice overview of the basic of vascular ultrasound, which is a very important primary step for any percutaneous intervention. Just I like to add one comment that before identifying the vessel by color, that is red or blue, we used another parameter, that is the flow pattern. In the artery, we get a triphasic flow pattern, and in the venous, it is a monophasic. So this is very important in delineating prior hand any obstruction in the vessel which is going to be accessed. This is the flow pattern.
Yeah,
the triphasic flow pattern in the artery and the monophasic. This is one of the important differentiating point between the vein and the artery. Besides, sometimes we have to modify our puncture, that is antegrade puncture, retrograde puncture. That technique also we have to adopt from this ultrasound guided. So that in way, it is a very good approach from your side, and we also learn very much thing. Thank you. And over to other.
Just one question. Suppose a patient is obese, 120 kg body weight. You are trying ultrasound guided femoral puncture. So where exactly your ultrasound probe will be something transverse. It will be totally straight up. How proximal you will take the needle to go in, because you need to see the tip, not the shaft. And if you are very close to probe, you will be maybe hitting the vessel beyond what you are looking at. So how to measure that distance in the obese patients, how you do ultrasound guide puncture?
I agree. When we started off doing the Dopplers and all, we always used to have difficulties, dealing with patients who were obese. So we started off, leaving that linear probe and starting off with a convex probe which had, lower frequencies. Now the ultrasound machines have come with a lot of variable frequencies. First and foremost, what we do, sir, is we decrease the frequency of the linear probe if you are using, and identify the vessel and view the vessel. Now, as we view the vessel, what is important, as we all have discussed, we have to measure the depth. We have to measure the depth of the skin to the vessel, and accordingly, if we take that as to be the center in terms of longitudinal axis, from that center, that much depth has to be, suppose the depth is approximately 5 centimeter. Suppose the depth is 5 centimeter, so we have to puncture the skin 5 centimeter proximal to the center of transducer, because our approach is exactly at 45 degrees. We will try to take our needle at 45 degrees. So if we take at 45 degrees, so the distance covered will be equal to the depth of the vessel from the skin. So that is what the approach should be.
That's very important.
Yes.
In obese patients, the depth should be the number
equal to
where you have to come proximal. Yeah.
Agree, sir.
Thank you.
Thank you. Anything else that I can answer?
Thank you, Dr. Bari, for a nice
Thank you. Thank you. Pleasure is all mine.
Next topic is.
May I request Dr. Ranjan Sharma to join on the podium?
Next topic is very important, relevant femoral anatomy with variation. And speaker is Dr. P.K. Hazra. I requesting Dr. Hazra to deliver his talk.
Can I have my slide? Right, thank you, Dilip. I think this is very important to get into the heart. So, week back, I had a patient, first slide, when there was a patient, the aorta was completely occluded. Both subclavian were completely occluded. I tried the middle meningeal artery, which is now is a target for subdural hematoma, and the left carotid was occluded. So what do? You do nothing. You can't do anything because he's dependent on the right carotid, and I never wanted to do anything from the right carotid if he has compromised left system. So there are 3 levels of femoral head: top, middle, and the bottom. The ideal one is the middle one, middle third. So if there is a 3, that must be 4th and 5th and 6th. In obese patients, sometimes you go to the top level, that is the above the head, and never ever try to put any large bore device at level which is below the bifurcation. We have 7 arteries, and all arteries are very important in the large bore access, because if you puncture inadvertently, by the time you remove your large sheath, start bleeding because there is no more tamponade. So there are certain bony markers. It's a myth that we compress the femoral artery against the femoral head. It's a myth. You never ever can have that happen until unless you have kyphoscoliosis. It's always compress the artery against some bony points, that is symphysis pubis. If you do the angiogram, you always definitely will see the femoral head lying on the lateral side of the femoral artery, and sometimes the inferior epigastric artery is arising below ideal position or above. Once it is arising from the top level, it's not an issue, but the top level there is always a tendency for micropuncture wear to get into that small inferior epigastric artery, and if you're pushing the sheath, it can rupture, and even that polymer wear, a terum wear, if it is entering the inferior epigastric artery, it can perforate. So always use the stiffer non-polymer jacketed wear, and there are variations in the femoral artery. Most of the time, if you see this color picture, 55% below inferior border of the femoral head. So if you have replaced femoral head, like you have a TKR, you always go for road maps. You have one more femoral head from the left side, go to the right side, take the road map if you do not have any femoral head left because the surgeon has removed the femoral head or a fractured femoral head. So there is comfort zone, that is the middle third. Still possible to do angiogram through the superficial femoral artery, arteria profunda femoris. Never ever try to repeat the same access if you are converting into impella or ECMO. So there is always a hand-held method. You can burn your finger. Now there are radio protection gloves are available, and if you're compressing this against the pubis after proglide or mantra, etc., there is less chance of bleeding into the groin, also less chance of complications, pseudoaneurysms. So your nurses and the juniors must be very much trained to compress these arteries after removing the large bore sheath. So there are different landmarks, and in our MD days or DM days, we learned that anterior superior iliac spine, there is a connections, but even obese patient, that doesn't give any kind of informations, the ideal puncture site. So these are basically on fluoroscopy. You must protect your body when you are having this kind of long procedures by this being rat pad, etc., newer radiation protections. These arteries can be depicted before your large bore access, that is CT angiogram. And if you really want to have good access without complication, you should also know the diameter. So there are different levels and different techniques. Most of the time, me and Dilip, we adopted one thing, that we will puncture on ultrasound for all rota, large bore coronaries, large bore ECMO, etc. on ultrasound. So that is our dictum in East, and maybe many people are following it. So there are many legends here, Dr. Vivek and other people, they also follow the same thing. Then maybe tortuosity, once you put a steep wire, the tortuous become very the accordion effect. And you must respect that when you are removing this large bore device, if there is a resistance, you should have a protection balloon, like a big balloon in the aorta. And obese patients, as we are discussing, the degrees are important. If you have 45 degrees, actually that leg 5 centimeter, 4 centimeter when you go vertical. So you have to know the depth, because on 45 degree, that 5 centimeter is actually away from the puncture side. So perhaps you have to move the skin crease from the inguinal ligament, and you can access this very nicely either on the road map or on ultrasound. So this is very important to understand that an obese patient can give a lot of challenges, but in large size patient there's only advantage that you have a large size of the arteries. Very thin cachectic patient, you can access the femoral arteries, but the arteries are also very atrophic. So these are already been discussed. We must have a protections. Sometimes you hit the pigtail and through the pigtail. Now, if something is caught, like if you are putting a percloser device, anything from the other side, if the wire is caught, you have a hell of a job. So be careful to remove those things from the other side, whether any wire or any pigtail or anything, before you deploy your percloser. So ultrasound he has already discussed. If you really want to make the size of the artery very big, give vasodilator. If you want to make a vein bigger, give lot of fluid and ask them to hold their breath, or you do something, some maneuver during constipations. So you learn it from the varicose vein, that vein can be punctured. It's very difficult to go for a venous puncture if you are not having large vein, because it has a tendency to collapse. If you hydrate them, it is much easier. There is a calcification, you must avoid those things. There is always a, this is hemi-neglect. So if you have one of your brain infarcted, you always see only one side of the human being. So most of the time we are actually having a left neglect. If you have left neglect, then you don't see left side of your, any story is a right sided story. That if you put your hammer on the left, you will not see any hammer in the left, because your brain is programmed to the left sided or right sided story. So most of the time we forget that there is also other axis on the left side. So don't believe your hemi-neglect story. If you have a difficulty right, go to the lab. So always looking into the things in a different perspective, it can deceive you. So always remove the parallax. The needle in obese patients or any arterial forceps can give rise to a false entry in obese patients. So remove the parallax. Now, so this is the part closer in a dead body, and you really know that that anything can be closed, a large device up to 22 French by newer part closer device or a surgical means. So these part closer device, when you are entering through calcified lesions, very difficult to close that puncture. And maybe if you have the ultrasound in your mind, you can go a little bit above the calcification, so go the lateral to the puncture, but you should avoid if you're really having a large area of calcifications. So you go to the other side. If both are calcified, like my case, you can go directly to the aorta. So once you are deploying this percloser, which is routinely done in hundreds of cases in my hospital, sometimes it snaps, it fails. So you can have two as a protection. And in life, always that the most of the complication can be dealt by the operator himself. And never ever try to bring your friends to help you, because friends, by the time the friends come, patient may have bled a lot of blood. He can go into hypotension. So my earnest request is a very basic thing, whether you are doing angioplasty by rota, ECMO, ECPELA, IMPELA, a large bore device, whether you are doing mitral clip, all is very simple when things are going in a simple way, easy way, but things can be devastating. So before calling your friend, try to learn the tips and tricks of handling the complications, and most of the time you'll be able to close that gaps or the complications on the table. So it is my earnest request that all the juniors who are we are aiming to become intervention cardiologists in the field of structural heart disease. Know your anatomy first, spend some time on the puncture, know how to do ultrasound guided puncture of the femoral arteries, the venous systems, the subclavian vein during your difficult pacemaker, or any radial artery puncture. Radial artery can be done without any ultrasound. So thank you very much. I think I will end it here. That large femoral access, large bore access. There are many new devices in the field of heart failure. That ECPs has become 9 French. In the future, the TAVR will be 9 French. But for the timing, be happy with the large bore device for TAVR and other mechanical circulatory device. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Hajra, for your excellent deliberation. This is a very important access for femoral artery and vein. I fully agree that you have described that the fluoroscopic guided using the femoral head puncture of the femoral artery is a very good alternative, especially among the obese patient where ultrasound access is also not very good and the pulsation is also not very good. I personally had a good experience with using this femoral head in fluoroscopy and puncture the femoral artery. That is almost a constant anatomy if the anatomy of femoral artery is assumed to be normal. Okay. So especially among the osteoarthritis and obese patient.
Right.
So any other comment from?
Thank you, sir, for your excellent deliberation. So in our time during training, we were always taught about thinking about retroperitoneal hematoma and pseudoaneurysm. But as because the technology is moving towards micropuncture, so we two things got to be, I think, remembered too much, which are often neglected. One is the deep circumflex artery and the inferior epigastric arteries, because these arteries are prone to have substantial retroperitoneal abdominal hematoma, and that might require blood transfusion as well. So this during micropuncture, the 018 wire often goes into these vessels. So we have to have an idea about the fluoroscopic trajectory of these two vessels. Right. So this is one of the very important concerns, because these vessels are often punctured and this might lead to problems.
Yes, I agree that inferior epigastric artery is the most vulnerable artery to produce the retroperitoneal hematoma. And
Dr. Arijit has raised a very good point. Actually, it should be multimodality. USG guided puncture, then you confirm by fluoro. If anything seems to be discordant, you have to rethink before introducing seat. It is not a blind that I have punctured through ultrasound guide, I will not see the fluoro where it is going. You have to cross check it by all multimodality imaging. That will reduce the complication.
Right. Thank you.
Thank you, Dr. Hajra, for nice talk.
May I request Dr. Sanjeev Mukherjee, Dr. Abhishek Roy to join on the dais.
So now we have a very interesting topic, excess combination in TAVR.
Chairperson and moderators to please stay back there. Please stay back there, sir.
Yes. So
this is going to be a very interesting talk, next one, because there are a lot of heterogeneity and variations in how people do TAVR.
So your femoral arteries and the iliacs can be very tortuous, and you need a very support devices for travel this thing. Introducing a large bore access. Dr. Aftab Khan has got vast experience in all types of cardiac interventions, and we'll learn a lot from him. Dr. Khan, please.
Yeah, thank you, Dilip. I think Dilip gave me a topic which was quite surprising. I mean, not surprising, I said it was quite ambiguous, and I really did not know what to talk about it. And then I spoke to him, and he gave me a brief idea what exactly he had in his mind. So what we all understand is that there are various access combinations that we can do in TAVR. And the usual accesses that people or we have been doing, again, let me be a disclaimer, I'm really not a high volume TAVR, but I'm fortunate enough to have Dr. Shumato Mukhopadhyay, who's one of the persons who's trained well in TAVR abroad, and he is with us, and he's probably in the country, has the maximum amount of experience, and he probably is traveling. I don't know if he's, oh, there he's from, he's just landed just now from probably doing 2 towers yesterday in Bangalore and in Delhi. So there are 2 approaches, or many approaches that people do, and the usual approaches are bifemoral. You take 2 accesses. You can do a femoral and a right radial, you can do a femoral and a left radial. There have been case reports of you can do an ipsilateral. So you put in 1 axis and then you do a protection from the same side for protection and bailout. So you keep a wire in the same ipsilateral groin. And I'm not going to be talking about alternate access. So I'm not going to be talking about subclavian, axillary, left carotid. There is transcaval access also that's available for patients who don't have arterial accesses. So you can go into the IVC and then puncture into the aorta and then get an access there. And of course, there are the surgical aspects, which are the transapical or the direct aortic. So we're going to be restricting our talk basically to the arterial access that we talk about. And what we know is that there are 2 accesses that you take. One is the primary access, from where you're going to put in your 14 French sheath and deliver your device. And there's the other access that you use for your pigtail to give you an idea about the non-coronary cusps, and also for a bailout for your primary site. So if you put in your Perclose devices or your other angiocelia, whatever that you've been using, and you still have a leak there or you have a stenosis there, you need to have a bailout access that you use to get your balloons there, or to use your self-expandable stents there, or your covered stents there. And that's the secondary site, which usually is a 6 French when you're going femoral. When you do a both femoral, there are certain pros and cons. The pros are that you can use your pigtail for marking the contrast injection to delineate the femoral artery for the puncture site of the primary site. So when you make if your access site for your delivery of your TAVR is going to be from your right, you take a pigtail from the left and you can use that to let you know where your right-sided puncture is going to be. And you can also keep a retrograde wire from the left side to the right side to a balloon occlude in case there's a catastrophe, which is known as a dry seal. And that gives you time to take out, put a stent from the other side also, as I said, for your covered stents. Now, the problem is that we all know that from our various data that we have earlier, femoral accesses are always bad as compared to radial accesses. You have more hematomas, you have more vascular complications than the radial aspect. And what has happened is that despite using the primary puncture where we use the 14 French, we are all very careful that we use micro punctures. But the other groin is often done blindly on the fluoro, and therefore these complications are sometimes more. So you often end up problems relating to the other side rather than the side from where you put your TAVR. So this is a small thing that we used to do earlier, and you put in your pigtail from the images. Okay, so you put in a pigtail there, you know where your CFA is, common femoral artery is, and then you use your needle, Then you use your needle there to puncture, and you can get your wire up there. And this is the method that you do, and at the end of the procedure, you can see that your access is clean. The other thing is that it can be used as a bailout. So the same thing here, we've had a wire there, and you've seen post-TAVR that despite the closure, there is still some leak on the DSA. And then you can put in a covered stent there and get your stuff. So that's the covered stent that is going there, and you've sealed off your leak there. So this is the procedure that was commonly followed. The other access that is often done is a minimalistic approach, where you use the right femoral approach for your device and you use a right radial approach. Now the advantage is that the right radial approach is preferred because it's something that we are all comfortable with, and the fact that you started using micropuncture or you started using ultrasound guided puncture for your right femoral access. So this makes it easier. You don't need a pigtail to give you an idea about where your catheter is. And an ultrasound guided micropuncture is something that's pretty safe, and this is something that has brought down vascular access complications to a very, very great extent. You can also know where your calcium is in the anterior wall and make a puncture appropriately. And you use your right radial for your pigtail and for a bailout if needed. The only con for this is that because of the fact that you're using a 6 French, or maximum you can upgrade to a 7 French slender sheath, sometimes you may not be able to use certain bailout procedures. For example, if you're you may be able to use a balloon to do a dry seal, but if you have put in a covered stent, anything beyond 8 millimeters will not go through a 7 French sheath, and you will need to probably use an 8 French sheath. So you may be able to use a balloon to get your time, and then you'll have to use a puncture from the opposite groin to get in your bailout in case there is a problem. So up to an 8 millimeter stent, you can probably get in through a radial, but beyond an 8 millimeter, you will probably need a femoral access. The other approach is femoral and a left radial. Well, this you can use if there is a vascular loop, subclavian loops that are there, and you get an easier access to the descending aorta. And if you're using a sentinel system, which is a cerebral protection device, the sentinel always has to be from the right side. So it's a right radial or a right brachial approach. And in this case, you can use your left side for your pigtail in case you're using the radial approach. The cons is that, well, supposing you're standing on the right side, sometimes it's difficult to reach out from the left side. And the bailout issues are the same from a vascular access from the top. As I said, 8 French sheath will be difficult for you to use. There have been papers which have been talked about ipsilateral protection and bailout. For example, if you have very tortuous aortas where you cannot approach it from the contralateral groin and it's difficult for you to access it, there have been reports where people have taken an ipsilateral puncture as a wire that is kept under the primary wire. So you use your perclose, you use your 6 French sheath there, and then take a puncture around 3 millimeters below your primary site and leave a wire there, and that can use as a protection and a bailout in case of complications. The brief about hardware that we are available there, you see this is the balloon that we have. So we have these long balloons which are there. These have lengths of 135 up to 135 centimeters that can be used. The Armada balloon of Abbott is one such balloon, and all of these are usually 7 French compatible. So your radial access can help you to bail out in terms of a dry seal in case there is a problem. But when it comes to stents, there is a problem now. Now there are 2 stents, the Gore Y-band stent and the Bentley B graft stent. So the first one is a self-expandable stent, and the next one is a balloon expandable stent. Now these are not stents which are available with us in India. We usually end up using the Bard Fluency Plus stent. The advantage of the Gore Y-band stent was the fact that you could use an 018 wire, or you can often use an 035 wire. But as I said, an 8 millimeter stent can go through a 7 French sheath. So you can use a radial stent, a radial access to bail out up to an 8 millimeter stent graft. And beyond 8 millimeters, you would have to use an 8 French device. So that's the only other thing. The B graft, this is a balloon expandable. So you cannot use it in the CFA, but if you have it in an external iliac, then you can still end up using this graft. And the advantage is, as you can see, that it is a 7 French, and you can use up to a 10 millimeter graft also through a 7 French system. But as I said, we usually end up using a Fluency Plus. The Fluency Plus also needs, unfortunately, an 8 French system, so it cannot be used from a radial system. The 5, 6, and 7 grafts would go through an 8 French. Anything beyond 8 millimeters would require a 9 French system. So this is something that's available with us, and usually it is an 0135 wire compatible system, and you'd have to use it from the groin. I'll just end by using something about pacing. So venous access is also, we have moved away from the conventional RV pacing that was done, and now you pace over the LV wire. There was the easy TAVR trial which talked about pacing over the wires, and this was found to be equally good. So you use an alligator crib, you have the grounding which is done through a skin directly. So the black one goes to your wire tip which is outside the catheter, and your red crocodile clip will go onto the skin or to a needle. The cons are that you can get some twitching there, or if you put in a needle, you can get an inadvertent puncture injury to the operator itself. And the thing is that if you have a high-grade TAVR, AV block post TAVR, you can use this wire to pace till you get a next temporary venous wire in. People have also done it, so the anode can be used in different other places also. Rather than using the skill, people have used it through a sentinet, and they've called it a sentinet pace approach, or they've done it through a pigtail, and you call it the pig pacing approach. But these are various approaches that can be done. And finally, there's a wire that has been also looked at, the Savvy wire, which has a dual advantage. You can use it for pacing, as well as there's a sensor at the tip, and you can use it for measuring the gradients across the aortic valve. Again, this is not something that's available with us, but these are the different approaches that are now possible there. Thank you for your kind stance.
Sometimes you have a lot of tortuosity in the femoral and iliac, and now you're traversing a 14 French sheath. Before that, you will need a dilator or some other maneuvers to, how do you go about that?
Yeah, so I think what you need to understand is that all these diagnoses or your attempts have to be made after a good evaluation of your CT images. And I think that's what is most important, spending adequate time before.
Still the patient will complain of a lot of pain once you are.
Yeah, so it is always a serial dilatation. So you use serial dilatation that you make. And most of the time, because using a stiff wire, you need to use a super stiff wire. So it has to be an Amplatzer super stiff that is used. And again, I agree with you, if you have too much of tortuosity, then you end up causing, even with the straightening of the wire, it sometimes can be an issue. So you have to be more gentle, make sure that you're using a graded dilatation and use a superstiff wire to help you do this.
It should be fluoroscopy guidance.
Yeah, it should be,
up
yes,
to the
of course,
aorta,
you
yes.
do that, yes, sir.
Yeah, suppose a patient is having maybe a 5.5 and lesser, diameter of CFA, and it's calcified, and the available diameter is maybe 4.95. So going with this right femoral TAVI, would you be comfortable enough to go only with radial approach there as just a pigtail and just a marker, or you take a safety left femoral so that anything happens there you can quickly go and do that?
So I had a discussion with Sumant, I think if you can be there also. So Sumant was of the opinion that he has done cases where he's used only one axis. So only one axis, and you used a pigtail to use the marker as the RCC, and then finish the procedure, and then come back with the thing. Sumant, it may be nice to have your ideas there. So again, the thing has been done also in patients with CKD. So patients with renal compromise, that's another thing, using a single axis for using the pigtail, and then take out the pigtail and deploy the valve there.
No, thank you, sir. So I think even if it's 5.5 or even like up till 5, I will be comfortable. In case where I am thinking that definitely I'm going to land in trouble, maybe I will go with a contralateral femoral axis. But these cases are usually pretty low, because the thing is, if it's very calcified and less than 5, and you definitely think you can't go through it, then I would think about an alternative axis rather than trying to go through that femoral, rupture that, and then try and stent it. So looking at the CT is very important, and once we look at the CT, we think we can go femoral, then I will be pretty comfortable to go through radial and femoral, because I can think of just putting that balloon to give me time to then evaluate. Because what happens in most of the times when we have a very bad calcific iliofemoral disease, usually there's a lot of tortuosity, and contralateral coming and getting into it is also difficult. The next thing is, we never used to leave the wires right from the start. The reason, because you already have a calcific artery, there's a lot of resistance. Putting extra stiff wire would increase your resistance, and you try against it, that wire itself can cause to dissections. So this practice of leaving the wire was done when TAVI was started with. But now most of the advanced centers, they've stopped putting a wire in right from the start, just to give you more lumen, less resistance, and less chances of causing that wire impinging on the calcific artery and causing dissections. Yeah, safety wire, I think we can put in a wire at the end of the procedure just before pulling the sheath out, rather than just leaving the wire from the beginning and doing the functions.
Dr. Khan, so do you come across any significant dissection, especially in the tortuous artery or calcified artery, which has led you to think otherwise of the procedure or postpone dissection? How you come across with dissection?
So I think it's, again, as I said, it's the planning of the procedure prior to that, and I think it's being gentle, so selecting your sites properly. So rather than dissection, it's, fortunately have not had any complications related to dissections as such. Yeah.
During the procedure?
Yeah, no, we have been lucky not to have any dissections during the procedure. Yeah.
Thank you, Dr. Khan. Now we are inviting Dr. Jadhav. He'll be talking about axillary access. We are not accustomed to it, and we'll learn from Dr. Jadhav. We might have done some cases from axillary access.
So we will showing many cases where we had peripheral complications and how we have dealt with that. So coming from dissections to perforations and occlusions of femoral arteries.
So, respected chairperson, dear friends, my topic is relevant anatomy of the axillary artery. We goes back to your first MBBS to learn this. So, around 1/3 of the patient with severe aortic stenosis or cardiogenic shock, femoral artery may not be the suitable access for TAVI and MCS due to smaller size, peripheral arterial disease or severe tortuosity. Axillary artery access needed for MCS and TAVI in these cases other than femoral route. So, if you see in the 35% of the patient with severe aortic stenosis, the evaluated TAVR, the anatomy of the transfemoral is not good enough because there is a small minimal luminal diameter of the femoral artery, severe angulation of the iliac arteries, and severe circumferential calcification of the femoral arteries. And this type of blocks in the severe peripheral vascular disease and tortuosity occurs. If you see the TAVR non-femoral access, in 30% in partner 1, the femoral access was not suitable, and in partner 2A 24% not suitable. In TVT registry 2015, 12.9% were not suitable, and UK TAVI registry 2016, 10.5% of femoral artery was not suitable. So you needed other than femoral artery is the best is the axillary artery. So need for non-femoral access is falling but remains more than 10%, and non-femoral TAVI cohort tends towards a higher burden of comorbidity and frailty. The advantage of axillary artery is that 6 millimeter in diameter, which is most of the devices can be taken care of with this access, easy to insert, faster insertion time, lower bleeding risk, easy ambulation, and emergent procedure can be done. Percutaneous solution to complications can be easily obtained by dry seal by using inflating the balloon or even putting the covered stent depending on the need. Easy to teach technically and not challenging. And you can compress against the scapula and the subscapularis to the humerus artery. The cons is that lack of dedicated equipment for the axillary artery. The equipment which used for femoral artery is used here. Lack of familiarity with the anatomy of the most interventional cardiologist. Difficult room setup, and cannot use Impella 5.0 liter without surgical cut down. Another beauty of the subclavian or axillary artery is that they contain more elasticity than the femoral artery. So they can be more stretchable. Even the size is 1 millimeter less, but they can be more stretchable. Axillary artery is divided, it is the continuation of the subclavian artery beyond the first rib, beyond the outer border of the first rib. It is divided by pectoralis minor muscle into 3 parts. Proximal to that is segment 1. In the middle of that is the pectoralis minor, segment 2, and beyond that is segment 3, and it extends up to the teres major muscles, lower border of the teres major muscles. So this is the muscle pectoralis minor, which divides into 3, and here most of the access, you do not need access here because you can puncture the intercostal space and you can cause pneumothorax. So you puncture between the thoracoacromial artery, lateral thoracic artery, and between the subscapular artery. These areas are suitable for the puncturing of the axillary artery, which will show how to puncture also. So you have to know the branches and nerve, the brachial plexus relationship. The branches are superior thoracic artery from the first part, second part acromiothoracic artery and lateral thoracic artery, and from the third part subscapular artery, anterior circumflex humeral artery, and posterior circumflex humeral artery. Go to your basics, and so this is the area, this thoracoacromial, beyond thoracoacromial and lateral thoracic artery and subscapular artery. Before that you can puncture between the two area, and very safe here. These are the superior thoracic artery branches which supply the major pectoralis major and minor muscles and wall of the thorax, and the acromiothoracic artery has 4 branches. It supplies the pectoral muscles, deltoid muscles, acromial anastomosis across the acromion process, clavicular supplies the sternoclavicular joint and subclavius muscle. Lateral thoracic artery given at the lower border of the pectoralis minor, below that you have to puncture, and anterior axillary lymph node lies along it, larger in female, supplies the breast tissue. And subscapular artery is the largest artery and your puncture should be beyond subscapular, before superior to the subscapular artery. Anterior circumflex and humeral artery and posterior circumflex humeral artery surrounds the humerus and supplies the head of the humerus. Relation of the first part, skin, superficial fascia, deep fossa, clavicular part of the pectoralis major, clavipectoral fascia with cephalic vein, lateral pectoral nerve and thoracoacromial vessels. This is the first part. You cannot puncture anteriorly. You have a lot of branches as well as the nerves surrounding branches of the lateral cord, posterior cord, medial cord and medial pectoral nerve, and this is the axillary vein. So first part you cannot puncture. So posteriorly, as I told you, these are the intercostal space and intercostal muscles, first and second digitation of the serratus anterior muscles and nerve of the serratus anterior and medial cord of the brachial plexus, which are already shown here. Laterally, you have a lateral and posterior cord of the brachial plexus, medially axillary vein and axillary sheath around the axillary artery comes along with the brachial plexus nerves. Second part, here second part again, this is the second part beyond the thoracoacromial artery and lateral thoracic artery you puncture, where you are safe to puncture anteriorly without any problem damaging the nerve of the brachial plexus. So this is the relation, posterior cord of the brachial plexus, subscapular area, scapular area and subscapular muscle you can trace if required. Relation of the third part is skin, superficial fossa, deep fossa. In the upper part there are pectoralis major and medial root of the median nerve. Below posteriorly, this part you avoid because you see medial cord of the median nerve is there and lateral cord of the median, so you cannot puncture here also. So third part, upper part, third part you cannot puncture. You have to puncture beyond, superior to that. Same thing, lower part you cannot, lower part you can puncture but with care. So better to puncture above the subscapular artery, below the acromiothoracic artery and the lateral thoracic artery. So this is the, and axillary artery as I told you is 6 millimeter into 1.1 millimeter plus minus. Iliofemoral artery 6.6, so just 0.6, but is more stretchable. It contains more elastic tissue and hardly any atherosclerosis in the axillary artery. So axillary artery is safe to put the devices, large bore devices without any problem. And the anatomical landmark, as I told you, you have to puncture this area, beyond the lateral thoracic artery and subscapular artery, this area. And where there is a behind, you can compress at the humeral body. So how to puncture? You give the angiogram from the femoral artery and puncture by seeing the angio. By seeing the angio, you puncture at this is thoracoacromial branch and lateral thoracic branch and subscapular. Between these two, you puncture the site. And it is safe, it's absolutely safe. And here, I think this is here is the site where there is a subscapular artery, is easily compressible, far from brachial plexus and lower risk of pneumothorax because you are outside the thoracic cavity. First part you are not puncturing, so you are outside the thoracic cavity. So using the wire as a fluoroscopic landmark for direct angiographic visualization, and depending on the condition, you puncture the artery here between the branches. Same thing, multiple times, and you put the ProGlide, Perclose ProGlide device, and you can put the impella seat, everything you can do with this. Even you can put the ECMO, 15 French cannula you can put with this, and you can put the venous from the femoral root. So ECMO you can do with this. And if you have put the impella, you can prevent the distal ischemia of the forearm by putting a sheath in the brachial artery or putting a sheath inside the radial artery and combining the sheath together, connecting the sheath together. So it's a axillary-radial bypass you can do, and so that ischemia of the forearm will not occur. So this is the way you can do, and you can compress very easily on the lateral wall of the axilla. Thank you.
Great talk, Dr. Yadave. One thing, can we expose the axillary and then do a puncture rather than doing it blind? Because will it improve the chances of, reduce the chances of brachial injury?
No, you can use ultrasound. There is no need to expose anymore unless you are putting your large Impella 5 French. Only then you need to expose, otherwise there is no need to.
I think it
you
was,
can
it
use
was a very,
ultrasound.
it was very important question asked by Dr. Sanjeev. This is the only situation where a surgical cut down gives you more complication than percutaneous. Raj Tayal series there, and they have clearly shown that the chances of vascular injury, nerve injury,
because
is significantly higher in surgical open approach rather than percutaneous.
Yeah. So safe.
Thank you, doctor, for giving this new horizon light into this. But one question, what should be the position of the arm?
Arm
during
should
the
be
puncture?
extended like this.
It should be extended.
Yes.
And number
So
two,
you have to be used to handling the axillary artery. Only then you can, if it is extended, and then you can scapula, in front of the scapula you puncture the artery by seeing the angio.
and number two is, as compared to radial artery and femoral artery hemostasis, we get a direct bony support.
Yeah, there is a bony
But
support,
in
subscapula is
axillary-
muscle and scapula, and you compress
here-
laterally on the humeral.
But here probably we do not get that bony support what we get in radial and femoral.
No, here you can use dry seal by using balloon inflation. You seal with the perclose proglide, and if using comes, you inflate balloon, 6 millimeter balloon from inside.
So we have to use some device.
Yes, or if aneurysm develops or even say a rupture occurs, you can put the covered stent. Covered stent should be again behind the subscapular artery.
Unlike femoral, here a safety wire is must.
Must.
Because you can't compress it. So
Yes.
it has to be a safety wire, you can do a dry
That
seal.
will be from which?
Safety wire from femoral artery you
From
can
radial or
But
brachial.
if your
yeah.
femoral access is really bad, you cannot go from there. Then
Radial you can get, sir.
It can be from the other side, left radial.
Left radial, yeah. Left radial you can.
Yeah.
You have to-
Yeah, you can do either of the way. Thank you. Thank you.
So, can we have Dr. Subhash Chandra for the next talk? Fluoro assistance in TAVR access.
Thanks, Mr. Chairpersons. I must thank Dr. Dilip to invited us on this very unique theme of large bore access, which is truly very relevant in the modern times when TAVR is going through the roof, and of course Impella, EVARs and various other modalities, all of them need the large bore access. And my previous speakers have dwelled upon a lot of aspects of how one should access the large bore. My talk is maybe a few repetition here, but I'll just, since the last talk in the first session, I'll just precisely tell you the crux of what all has been discussed. Okay. So, we are trained femoralist, the old age interventionalist. The new generation is largely on the radials, and we also trying to learn radial today. As a result, almost 90% of my PCIs are happening through radial. So, but for large bore, we must be very confident about the fluoro guidance on TAVR. The worst feared complications are that there should not be an intrapelvic bleed, which is the worst thing, and we should be able to compress it or manually press the site after we have finished with the intervention. And as Dr. Hazra also told you, we are not pressing at the femoral head, we are actually pressing at the brim of the acetabulum, which fits into the femoral head. But the message is that one should be very confident about the ultrasound guidance, as was talked by our radiologist colleague in the very first talk, that we must master ultrasound. However, this trial which just came in December 23 has a comparison of ultrasound versus fluoro guidance, and surprisingly it goes out to show that in confident hands the complication rate of both the techniques are almost same. but one has to be really confident about the fluoroscopic guidance of these punctures. So there could be some repetition here. Anatomy is very important, and Dr. Hazra alluded to the various areas of femoral artery, but the bottom line is that puncture has to be outside the femoral ligament. And the landmark for that area is the inferior margin of the inferior epigastric artery, which arises from above the ligament, but it curls up at the level of the ligament. So your entry site has to be under that area where the inferior epigastric artery is seen winding around the ligament. But the true zone is very limited, it's very narrow compared to the conventional zone, which is seen between the profunda bifurcation and on the top, the inferior margin of the inferior epigastric artery. This is what is shown. The inferior border of the inferior epigastric artery is the area below which you have to enter into the femoral artery. And of course, if you happen to have high bifurcation of profunda, you should be very, very cautious, and that is captured by doing an angiogram from the contralateral groin. So conventionally we go back, and the micropuncture needle is a must, because that is very forgiving. Even if you goof up, the blood loss or the complications or dissections are very minimalistic compared to an 18 French needle which we conventionally use for PCIs. So micropuncture needle should be the first thing to go. And the contralateral injection from the contralateral groin, taking an IMA catheter and passing a Terumo wire, and then parking your catheter there, and then taking a good shot, and then maybe with a artery forceps or any metallic object, you can just identify the puncture site at the femoral artery, and don't move your table thereafter once you are done with this. So DSS are taken to identify both the inferior epigastric artery lower margin and the bifurcation of profunda, and that gives you the exact zone. Nevertheless, the CT analysis is very important so as to see the bifurcation point, the presence of calcium, and you must avoid the calcific part because your proglide will not hold on the calcified part of the vessel. And this is how one has to see. Fortunately today, majority of TAVR devices are done by 14 French sheath, or sometimes 16 French if we need pre-dilatation or a bigger size valve. So that's a big relief. But you got to be very, very cautious about the closer aspect after the access. So the closer is very, very important. So the access has to be very, very safe when you go inside. So this is how we do. And these are some of the angiographic videos which are shown here, and to identify the bifurcation. So if you see in this particular case, the first one, the bifurcation is high, the inferior epigastric is seen here, the lower margin. So you're left with a very, very narrow zone here. And these are the cases which truly call for a supplemented ultrasound guidance also before you enter these arteries. Again, as you see here, so for fluoro guidance, it is a must to have a contralateral groin shot or a radial shot on a long catheter, and then proceed further with a micropuncture needle as much as possible, entering below the lower margin of the inferior epigastric artery. So these are some of the cases which I have captured from my recent cases, that the micropuncture needle and then passing in a fine wire, and then of course taking a shoot also once you are inside the artery before you proceed further and park your proglides here. And today the norm for proglides is just a single proglide at 12 o'clock position, and followed by an 8 French angioseal for the closure, successful closure of these cases. So these are classic cases where the artery forceps gives you the entry point, and then you cross check by a fine sheath into the artery, and then you proceed further. So these are some of the shots which I have captured. But the entry point has to be somewhere at the upper half of the femoral head in the fluoroscopic guidance. So these are the successful sheath withdrawal procedure, where the previous speakers told you that if you have any doubts, it's worthwhile parking a 0.018 guide wire after you have parked your proglide all the way into the primary groin from the other groin, and that goes a long way in bailout situation to have a dry seal, or at least inflate a balloon in the vessel and then compress it from outside. And in my own experience, in some of these cases, it has worked wonders once you neutralize your heparin and do a dry seal and put a compression. Majority of cases will be forgiving, but at the access site, you got to be very, very careful not to enter the intrapelvic course of the common femoral artery. These are some of the cases which were seen sometimes when we're using true proglites. There was cinching of the site, and one has to use a balloon in these cases, and eventually you can ensure that the flow to the limb is preserved. Hyperfication, as I showed in this case, I took ultrasound guidance also in this particular case using a micropuncture needle, and then eventually this case I faced problems because there was a very, very short zone to enter the site, and so here we ended up having the perforation here. In spite of putting the single proglide, there was a leak here, and mind you, sometimes this leaks on DSA would give an impression as if you have had a fistula to the vein, but that's not the case. Actually, the blood seeping out goes all along the sheath of the vein, and that gives you an impression as if the vein is also punctured. So not to worry. And then we did a dry seal here by crossover groin and then inflating a balloon at the groin, and that balloon was inflated exactly at the site of puncture. Once that was done and a manual compression was done after neutralizing heparin, in this frail lady we could achieve a fantastic closure in the end. So those are the case, and this is the norm in my practice: single proglide and 8 French angioseal, and rarely a dry seal by balloon and manual compression, and extremely rarely a covered stent. But the bottom line is that you should not mess up with the groin. It is said that TAVR is all about planning 50% and groin management 50%. Rest of the skills are very simple. Any one of us can do, and push a valve and place it across the annulus. So with that, I will come to the end of my presentation. So pre-TAVR screening of CT scan usually provides an upstream thorough exploration of femoral artery, allowing the operator to be prepared. The key to an uncomplicated femoral puncture for primary access in TAVR is the direct visualization of femoral artery and its differentiation from the superficial femoral profondi bifurcation. Femoral contralateral angio-guided approach or from the radial approach, anatomical landmarks and pulse palpation, all of them can help you have the TAVR access, and the value of experience appears obvious, so operators should use the method they master best. However, ultrasound guidance must be learned more and more, and the whole world is gradually moving to the ultrasound guided puncture because they have perhaps the least complication of the groin. Thank you so much.
Great talk, sir. Do you take single view in fluoro, or you suggest taking multiple views, one? And two, when you said the inferior epigastric artery is very low, use ultrasound. How does it help you in actually getting the lumen?
So very good question. So besides taking an AP view, I normally try to separate out the profunda, which is done in the slight medial rotation of the tube. You can do the other way also, and that gives you fair guidance as to how much is the zone of safety where you have to operate. Regarding the ultrasound, my practice is that I start with a longitudinal view, especially if I'm facing a high profunda bifurcation, as was in this case, and then quickly turn my transducer by 90 degree, and after the eye view of the owl, going all the way up, but making precaution that I have to stay far below the inferior epigastric artery, the lower border. So I in tandem take help of both fluoroscopic as well as ultrasound guidance. That's my practice. So hybrid approach really is extremely safe. Yes, sir.
So you have mentioned about fluoroscopic guidance by an artery forceps.
Yeah.
So do you puncture at the spot of the artery forceps, or do you go below?
I puncture at the tip of the artery forceps, which I have kept at the upper half of the femoral head and below the lower margin of the inferior epigastric artery.
So what should be a landmark regarding the skin?
The skin entry point should be about a centimeter or two, making a 45-degree angle below the tip of the artery forceps. That's it. So you should not bother with the crease, because that usually misguides you. Stop looking at the inguinal crease. Invariably, your entry side also would be above the inguinal crease, so as to reach the point of entrance where you've kept the artery forceps.
Have you
And in obese,
any idea about our operators ipsilateral safety wire, or maybe ipsilateral access to have a kind of keeping a wire there, and where exactly we puncture? Sometimes in the sweet spot you may not have that space where you have a normal large bore access as well as a smaller lower down safety kind of puncture. So where exactly we puncture in this?
It was pointed out by one of the speakers that you could go about a centimeter or two below the puncture site, the internal point of the puncture site, so that you are still above the profunda bifurcation and you have a wire. I have never tried it. In my practice, I always go from the contralateral side to park a wire. In obese patients, there is a special challenge. The very obese or very thin or the CKD patients are the worst patients. So in obese patient, you must keep your track very fine by artery forceps and so that your proglide knot goes nicely at the surface of the artery. So those are the real challenges. One should never compromise there for proglide closure.
So, Dr. Chandra, if I can make a point that, in fluoroscopy guided puncture, there is a, interventional cardiologists don't use that cath lab's software that effectively. So now when you are doing fluoroscopy guided, you have to just under fluoro, you give an injection, and that can be road map, and you can see the whole artery under the fluoroscope. You will see the branches also, so you don't have to keep any landmark there. You can, in real life, you don't move the table, you can see that, and it's like a real life during injection, you are puncturing the artery. So
so that's worth learning from our IR colleagues who largely work on road maps. So that's worth learning,
Another important landmark for skin puncture, apart from the skin crease, we have, which has many fallacies, that is the line joining between the anterior superior iliac spine to the pubic tubercle. That is a very good
that's
marker.
little above the crease, It
is out the, sometimes go there, and 2 centimeter below this line. Within this 2 centimeter below this line should be the ideal as far as the skin puncture is concerned.
True. Thank you.
Thank you, Dr. Subhash Chandra.
Thanks.
And thanks all chairpersons and moderators. It was a wonderful first session of today's program, and now we'll proceed for the second session. And may I invite the chairpersons and moderators for the session number 2, Dr. Pramod Kumar, Dr. Dipankar Mukherjee, Dr. Anjanal Datta, Dr. Sunandan Sikdar, Dr. Mayank Agrawal, Dr. Dipankar Das, Dr. Purnendu Das, Dr. Aditya Verma, Colonel Monga, and Dr. Neeraj Kumar Jha.
So, good morning everyone. The second session starts with Dr. Viveka from Max, Delhi, ultrasound guided puncture. So we are from the era of Scholl's procedure, where we used to really sit on the groin for hours to close it. A lot of water has flown down the river Ganges, and so we have the newer techniques available. Let's hear from Dr. Viveka.
Well, so good morning, friends. At the outset, let me thank Dr. Can I have my slides? Dr. Dilip for inviting me, and it's really very good thought. In today's world, we went from femoral till, Dr. Pramod, who is a hardcore radialist, and then we are coming back to femoral, and, so a lot of people had forgotten how to manage femoral and puncture even. So safety is most important thing, and you need to see if the data of, good outcome or decreased mortality when you compare SAVA versus TAVR, that is mainly that femoral TAVR is lower risk than the surgical TAVR. So if you are doing from femoral access, so it sums up that we need to have a very, very good safety profile as far as the access is concerned. So if you look at the data, that clearly shows that if you do an ultrasound guided access, the side complications after, of the lower extremities are significantly lesser. So this is again Journal of Vascular Surgery data, and that clearly shows you that the complications like pseudoaneurysm, thrombosis, vessel occlusor, all of them are significantly lesser, to the tune of almost 50% lesser complications. So using fluoroscopy guidance, as Dr. Subhash Chandra elegantly showed in his last lecture, is associated with double the rate of vascular complication. But when you use the combination of fluoroscopy guidance with the newer software of road mapping, with the vessel seeing with the table locked on the same position, and when you concomitantly use ultrasound, then the complication rate becomes even lesser. So it means that you need to have a combination of everything, and never forget that all the information which we have from the CT analysis, that is also very, very important. So you need to keep that also in the mind. And as he showed that sometimes you'll have a very high bifurcations. There the problems are much more, because despite your best effort, sometimes either you are into one of the branches or at the web of the bifurcation, or sometimes you are into the pelvic thing, and then the complication rates are significantly higher. So despite the growing evidence that suggests the advantage of ultrasound guided access, it is still infrequently used in cardiac catheterization lab. And in fact, I know at least a few operators in US who are doing more than 400, 500 towers, and they say that they don't believe in ultrasound guided because they are not doing it. So the thing which you are comfortable with, that is also, you should adhere to that. But when the data is so compelling, we should do an ultrasound guided puncture and access. So what are the barriers? So if the results are so good, I don't think it's a rocket technology, and in the first lecture also it was shown that it is very easily delineable. You can see where the artery is, and one of the biggest advantage of ultrasound guided puncture is that you are not only in the correct position, but you have an anterior puncture. So if you see, the maximum complication of vascular closure devices are that when you are hitting or deploying the vascular closure devices from the side. So if the entry is from the side of the artery, then the complications are much more. And other thing is that when you are, as Dr. Subhas has also shown, that if you are using multiple, proglides, more than one, then the complication rates are also higher. So it has shown that the ultrasound guided access reduces the time to obtain access, and reduces the risk of puncturing at the wrong vessel, and reduces the vascular complications as well. And then, so this is what the cartoon shows, that you do, as it was elegantly shown in previous lecture, also in first lecture rather, that you hit at the, either you puncture in, short axis or long axis, but you need to, use both of them. So you delineate the artery, go above the branch, and access the needle artery should always be 30 to 45 degree angle, and this is how the images should look. And once it becomes routine, then the time consumed in puncturing is also significantly lesser. So a step to ultrasound guidance is something like this, that we go from the bifurcation point, enter further in the common femoral artery. Here it shows that we have entered the common femoral artery, you compress with the probe, collapse in the femoral vein, but not in the common femoral artery, collapse will not be there. And then once you have confirmed it, you can sometimes put a color also, and then puncture it. So this is again a repetition, but I think this is very, very important, that we need to be very mindful of this fact of this anatomy, that the puncture site and also all the structure here should be well remembered, and we should puncture in the sweet spot right here. So large bore access closure is again important. Once you have gone in, because once you have deployed the valve, everything is okay, but your jaw is robbed of a valve implantation by a groin complication, because that was the easier thing you thought, but that is proving to be Achilles heel. So you need to be very comfortable with the closure devices, and we have got access to not far too many, but we have largely access to ProGlide and the AngioSeal. So now, as Subhas has also said, that we are using combination of both of them. So one of the, so even in 70% of the cases, we are getting away with single ProGlide with 12 o'clock position puncture. So if you look at the strategy, what we should do an ultrasound guided puncture, and rightly said that micro puncture is again very handy. Once you have taken a shoot with micro puncture, and once you are sure, then put a wire and then enlarge the sheath, and then you can go with the 8 French sheath and do your perclose there, and then you can start dilating the groin artery and then go with the 14 French or 16 French, whatever the size of the tower device is. So each perclose, so this is where the era of 2 perclose was there, but obviously some of the operators started with 2 perclose on the main working site and 2 on the left side of the groin. So we need to again once we are securing and we are 100% sure that this is the position is there. Sometimes if the artery is quite large or there is some dissection and the bore has become really big, sometimes we have to close with the 3rd perclose also in these situations. So I'll show a couple of videos that how to go with the tower step by step. So this is what Dr. Subhash was saying, that you need a fluoroscopy landmark, but now I have said that the newer software clearly shows artery lying here. I think I have got one of the videos of that. Then you need to very well do a lignocale infiltration there. So once it is well anesthetized, it will be very soft and it will not impinge on muscle contraction and all will not be there. And then we use the ultrasound probe there, and with the ultrasound probe, same short axis and then go into the long axis, and then under that guidance, this is how the needle is going. So you puncture it, and then once this is the micropuncture needle and the wire, through that you have gone into the main vessel, and once you are sure that things are pretty good, and you do take a shoot also there, and after the shoot you see that you need to make a good, so your closure will be very good if you have created good space, and make sure that it is not a zigzag puncture. It should be straight track so that the proglide does not get entangled into the soft tissues. And then this is the deployment of the proglide, so you can do 2 or 1 as per your choice and comfort level. And then micropuncture sheath this is the one, and access. So this is so this software gives us a clear roadmap like this. So here you can do a direct puncture also. This is what I was mentioning about. And then the 2 perclose technique, obviously we do in 10 o'clock, and other one in the 3 o'clock position or 2 o'clock position we can do. So this is the 2nd perclose at 2 o'clock position. And once the hemostasis and things are done, then you start and proceed with the after dilatation, put the 14 French sheath, take your valve, do the procedure, and then again while you are closing it, you need to again do the local and well dilatation, and keep the thread of the perclose wet, because if you have not done, it might get cut, and then your knot pusher may not get into the right place, so it will not go too far deep in. So this is how both the groins would look like. And once that is done, then 14 French sheath, you can take it through the device. And the post closure, again you need to take a shoot, and after the whatever device you are doing, tower or TEVAR or Impella devices, you can large bore access can be closed, and post this thing you can close the access site. So you need to be in right position, give good anesthesia, give a good cut into the superficial tissues and up to the artery, so that your this is the knot pusher that should go right deep into there in that space. So when we are withdrawing the sheath of the large bore, we need to pull both if we have got 2 sutures, then we need to pull both the sutures directly, and one of your associate operators should, while he is pulling out the sheath, then give a tug and hold it for some time, that with the knot pusher we push the knot right up to the artery, and once you are 100% sure, then you can close it. And if it is still not closed with 1 suture, you can, through the same wire, you can put one angioseal and close the whole access site. Sometimes, if it is oozing, a lot of people don't like to give Vicryl, especially if you have done, PCI also in the same sitting, then you can put a Vicryl and close it there. And this is how it will look nice and clean. And with the virtue of this, we have now gone into what we call daycare tower. So we are discharging our patient, after the 12 hours if there is no groin complications. So the key to success and early mobilization is again a very neat and clean groin access. So thank you very much for your kind attention.
So I have one or two questions. Number one, how many times you have used one ProGlide, and in that case the suture has broken, and how you have managed that? Second is, what are the reasons of this suture getting snapped off? First is calcified artery. If you don't have a proper clean segment, then calcium is there, your suture may get cut and it can break. Second is the angle at which you are going to give a plunger. The noodle is going to capture the sutures. And third could be the device malfunction, because many times we have seen the device Pro style is better than the ProGlides. So how you deal with these situations?
So I think that's a brilliant question. So if you look at the complication, as you rightly said, the heavily calcified artery would be the commonest cause where so I had a couple of cases where we had to do whole artery was calcified, and we had to do lithotripsy peripheral, and then we deployed. We had we had to put 4 ProGlides. So remember, your wire has to be in there. If you are using one ProGlide technique, then wire still you cut the ProGlide on wire, and if it is not giving adequate result, you can put another ProGlide, or when you took a contralateral shoot, you can see whether angioseal be good enough or not. Sometimes, so in this case, we had 2 ProGlides failed because they got cut through with the heavy calcium at the origin, and there was no area which was calcium free at all. So that was a main problem. But I think fairly, if you have a safety wire, then you are in much better position, but that would be a luxury in a smaller artery. But with bigger artery, that is something which is very, very handy, and sometimes we do covered stent and all in these situations. But of late, we have been seeing that even for TEVAR, also for thoracic, which is 22 French, we have got away with 1 ProGlide and 1 angioseal.
Your wire is there, your ProGlide didn't catch it, it has got broken off. So you can't put the ProGlide after that, because there was a 14 French sheath, the hole is a lot larger. And the second, you have now on the wire which is there, you are taking a fresh ProGlide after that.
No, so at what level because when you have already put in the ProGlide, and then you
final position, once you are coming out, you see the wire has got broken and it is not holding. Now you are left over with only wire. There is no pre-close.
So obviously, so on that also you can, do the second one ProGlide you can give in. You can still do because the first deployment of the ProGlide which you have done, the knot is still in there. And when you are pulling it out, because you need to have you can proceed only when you have a satisfactory deployment of at least 1 ProGlide. So I don't know, if the first ProGlide has not held, you can't really, proceed with this thing. You need to put another ProGlide in that.
I'm taking a little time. I'm talking about a different situation. You have done a pre-close, your ProGlide wire is there, you have done the procedure. Now you are coming out, expecting that this ProGlide is going to work. Now we are tightening the suture and it is not working, it has got broken now. After the procedure. Then you are left over with only 1 wire there, and the only option is probably a covered stent.
Sir, may I answer this one? So I am a big proponent of always using 1 ProGlide. So in case if the first ProGlide doesn't work and your wire is there, you got a 14 French hole. So the biggest challenge is to assess the depth of the where you're going to deploy your next ProGlide. But obviously we will many times do post-closure. So pre-close works best and is advised as per IFU to pre-close. But if it doesn't work, then you can definitely do it. The important things to do is always take a normal wire, or a stiffer wire is also good. And then what I would say is, when you go in with the ProGlide, don't take the wire out at the level when the skin marker is there. Go deeper in, and then someone has to put a very gentle pressure. So the pressure has to be so gentle that you are reducing the puncture point just to the size of the ProGlide. You don't want to close it completely. Let a little bit ooze come, but not gushing. And that way you have to go in. Once you see a pulsatile flow, then you come out. You lose the pulsatile flow on the ProGlide, and then again you go just in when you get the pulsatile flow and deploy your foot plate and pull. And keep your left hand very stiff. It is difficult,
that's where,
but
it
asking, works.
In a 14 French rent which you have created, whether foot plate is going to hold or not.
Yes,
no, so
it will. It will.
Is very important.
It will. Most of the times it will. And the second thing is, what I would say is, always when you put single ProGlide, try to put it as 12 o'clock. The second proglide when you're putting, just don't go to 10 or 2, but just a little torsion, maybe 12:30 or kind of 11:30. So just a little bit torsion, and that proglide foot plate will hold, because foot plate dimensions are much bigger than the 10 French hole. So if you see, ideally a proglide which is used for 10 French closing, one proglide can close a hole of 10 French. That's what is the IFU of the device. But it is good enough to close a 14 French most of the times.
So as long as the wire is there, you have to first thing try is to put in another proglide and see whether it works or not. Then, obviously the other technique of crossover and balloon tamponading and, deploying on the balloon. So other technique is that you partially inflate the balloon and deploy the second one on the partially inflated balloon, so that, the chance of holding is much better. But of course, in 100% of the cases, one technique does not work.
Yeah, I think that's a very good technique. The only drawback of that is sometimes if we inflate to 2 atmospheres and we have taken 1:1 artery ratio, what happens is it becomes difficult to, get the depth of, because you're not having a pulsatile flow. And I think getting the depth is very important, because if you're too far into a branch and you having a flow pulsatile, but you deployed a suture, it's just going to cinch your artery, not control the bleeding. Whereas if you're too far back, then you're going to deploy the whole suture in the subcutaneous tissue.
Vivek, another important complication of the puncture, particularly if okay, I mean to say, there's a complication of the puncture, that the particularly higher up puncture causing for the retroperitoneal hemorrhage and perforation. In my 40 years experience, I've not got any experience. But how? Very difficult management strategy. What are the risk factor for perforation?
Yeah, so I think unless if it has to be recognized well in advance, and that is why the adequate size of balloons. So peripheral intervention techniques would work. So immediately you need to balloon tamponade, and covered stent is the best strategy in that case. So sometimes people suffer. In fact, in one of the cases I had gone to Proctor, they did not have the covered stent, so we had to keep tamponading it for almost 45 minutes to 1 hour till the covered stent came, and then we had to deploy. So I think we need to be mindful of these complications and not only get the toolkit for tower, but also for peripheral intervention ready in the lab.
You have to do the retrograde way, because
from the left side, from the opposite side.
Can we have the next speaker? Can we have the next speaker now? We are running late by almost 30 minutes. So we'll request Dr. Sumanto to speak about ultrasound guided puncture of axillary and venous.
I totally go along with Dr. Suman's view that we can still attempt the second proglide with gentle pressure before we take the covered stent, because it is one trial, and again if there is a minimal leak you can always use additional angio-seal and close.
I think desktop, if you go on the desktop and there is a presentation. LBA. Thank you. मेरे पास पॉइंटर है क्या ये वाला और स्लाइड्स के लिए
I think during our DM training we must have these, the ultrasound techniques of puncture must be a part of that. Unfortunately it is still not.
Thank you for inviting me to speak on the large bore axis. These are my disclosures. So my job has been made pretty easy because previously the anatomy has also been discussed about, ultrasound puncture techniques have been discussed about. So just as we know, the most common site and the safest site for a large bore axis is the femoral artery. Whatever be the complications and whatever it is, still it is the safest site available. Now, transfemoral access is limited in around 13 to 20% of patients, depending on different literatures that are available. This is due to previous prior surgical intervention, severe aortoiliac disease or iliofemoral atherosclerotic disease, tortuosity and calcification. So whenever there is no transfemoral access, then we think of various alternative access like transcaval, transaxillary, transcarotid, transapical. Of these all, the two that has gained most interest is the transaxillary and the transcaval. Now, transaxillary access, when can we consider a transaxillary access? So we definitely need to have a good quality multi-slice CT scan prior to the procedure if possible. And what we need to look at is the diameter of the axillary or subclavian artery, which should be again 6 millimeters or more. Absence of heavy calcification, excessive kinking or severe tortuosity of the access vessel, which cannot particularly be treated by a simple balloon angioplasty. Or if a patient has got a patent Lima graft and the vessel diameter is less than 7 to 8 millimeters, because when you put the sheath across, the amount of time the sheath is going to be in, you're going to cause an ischemia in the Lima territory. Whereas by contrast, having an ipsilateral pacemaker is not a contraindication. So what are the pros and cons? So particularly axillary artery diameter is around 6 to 7 millimeters on most of the anatomical studies that we have, which corresponds to a French size of 15 to 24, allowing us to put all the large bores instruments through it, like the TAVIs, Impellas, even EVARs and TVARs, like if you need to. And also axillary artery is very infrequently affected by atherosclerosis. Cons is that it runs as an intrathoracic. It goes intrathoracic, which is called the subclavian artery. The brachial plexus is in close proximity, which was previously very well shown in the lecture. And it also slightly differs in anatomy from the femoral artery. So what difference is that? This is the picture of a subclavian axillary artery and a femoral artery in a 75-year-old. As we can see that there are multiple layers of elastic fibers in this tissue, and the media is mostly elastic rather than muscular type, and the external elastic lamina is not there. Whereas the femoral artery, there is an external elastic lamina, and mostly this is smooth muscle cells. Thus, it has got a much more resilience when we are doing a compression or putting any per-close devices, particularly the ones that is suture based. And this was the axillary artery anatomy. I won't go, this is shown very well in detail. So it has got three main segments, 1, 2, 3. So as soon as it comes out of under the clavicle, in the first, under the clavicle, subclavian artery turns into axillary artery. The second part is which lies behind the teres minor muscle. So anything proximal to that is segment 1, proximal to that is segment 3. Now important part on this thing is we need to see that there is a thoracoacromial artery, the branch, and then on the first part and on the third part you have the subscapular, and thereafter you have anterior and posterior circumflex humeral. So this is the part which is free of any branches. So this second part is the best part to puncture, because when you're deploying your ProGlide or your angioseal, there is nothing that will cause your foot plate to get caught and you do not get a good seal. And as previously described, that a good seal will depend upon a good puncture. So this is what I said, first segment, there is no major branches apart from that one, but there is a risk of pneumo or hemothorax, supposedly if your needle trajectory goes beyond where you want to puncture. The second segment is the best part because it can be compressed, it is extrathoracic, and it's preferred, but you need to avoid the vein which could be on top and the brachial plexus is in the lateral. This is where the ultrasound comes into play, because on the angiogram you cannot see the brachial plexus, you cannot see the the axillary vein. So, and if you go through vein to artery, you're definitely going to cause a fistula or a big shunt there. The third segment is also safe, but you need to be puncturing before the subscapular artery, and you can go in through the axilla. So in total, I would say you have to carefully select your site based on ultrasound and the CT scan, because on the CT scan you can know where the branches are. On ultrasound you can avoid your brachial plexus and your vein and get the right puncture. So this is how an ultrasound looks like. That's the pectoralis major. This is the first segment of the artery, and then pectoralis major, pectoralis minor, axillary artery and vein. So this is where you would ideally want to puncture, And on the third part, you can see that again artery goes more deeper side to side vein, and there is the brachial plexus nerve. So this rightly shows nicely a little more distal if you go, the nerve lies on top of the artery, and there's a very high chances if you go puncture there, you will have injury to the brachial plexus. So now coming to the compression, the biggest thing that earlier when you used to do axillary access, we'd always get a femoral access, put a rail with an 018 wire from the femoral axis all the way into the radial, left radial, snare it from there, and then do all the exchanges or closures with the help of a balloon, because we used to think that axillary artery is completely non-compressible, and this used to complicate the procedure. Just getting the access before even you go on to put your impella or your TAVI valve would take an hour or so with all this. But now what we have moved on is to just do a proper puncture in the second part, get just the left radial axis, a wire through there, have a 7 French glide sheath for bailout in the left radial, no femoral access, because many of these patients who go for a axillary access, they have vessels very, very small. And if you can put an, like, 10 French sheath through the femoral, then why not do just IVL and put a 14 French sheath? So most of the when we go for a transaxillary is when there is no femoral access. So we would just take a left radial, and this clearly demonstrates that the axillary artery, if punctured at the right place, can be compressed against the rib cage. And this has also been surgically also documented in one of the papers. I haven't put that. They could compress just the axillary artery. So in the access combinations, as I was saying, could be transaxillary. Usually always left is preferred than right, just because of the angulation of delivery. You can have a right femoral or a left femoral access for railing, whereas preferred for us is a left femoral with a 7 French glide sheath for bailout, and right radial for aortogram if you are doing a TAVI. Closure techniques, again 2 ProGlides is most commonly used, but right now most of the centers have moved on to 1 ProGlide and 8 French angioseal, just like the femorals. You got Manta, and you also, some centers use ProStar. The only thing I would say is ProStar versus ProGlide was head-to-head studied, and the failure was much more in the ProStar, whereas ProGlide had 100% success. These 2 ProGlides were used in this study. The main reason, again, as I told, was the elastic type of axillary artery. So ProStar has got 4 needles, so it damages the vessel more, whereas ProGlide has only 2 needles, so it's better in terms of less damage caused. Tips for the puncture, I would say arm abduction 45 to 60 degrees so that your axillary artery is straightened out. Shallow angle of puncture, so 25 to 30 degrees maximum for axillary artery puncture as compared to femoral where you go around 45 to 60. And shallow angle of entry and deployment of the ProGlide, and be very gentle on the ProGlide. So one of the reasons why ProGlide sutures break is because we are too tight, we press too hard. And here the ProGlide will also break and your axillary artery will also perforate. So you have to be very gentle. There is no need of any pressure. It is just that you have to slide the knot down to the top of the vessel wall. Pulling hard occludes the artery, cinches the artery, does not close the hole. That's for sure. So this is one of the axillary arteries that we did with single axis. You can see right radial pigtail coming up, and all the bailout and pictures are done from the left radial with, I don't know, the slides are not playing properly, but it's just one single axis. So bailout, we have long shaft balloons which was shown, 135 stents, all this. Secondary RA, if you are using, the important thing is to have wire band stents, and these can be delivered through that 7 French glide sheath which you can put in the left radial. And I think this a very quick word about the venous access large bore. I would say it's similar to getting any other access, same as a femoral arterial access. It's mainly used for all these procedures, which could be around somewhere from 20 French to 29 French. You again have an ultrasound. Just important is you have to come medially and find a place where the vein is lying side by side to the artery, not behind the artery. And closure techniques, you can again use 2 proglides. A figure of 8 stitch works very good, and a figure of 8 with a 3-way tap is the best way because you can reduce the compression gradually and then the closure helps. So LBA success, I would say, depends on pre-procedural planning. Competence in interpreting CT scan and doing an ultrasound is mandatory for safe patient outcomes. I would say all the procedures, we should keep it simple rather than being a superhero. This was what my mentor told me during my fellowship. And proper bailout armamentarium and plan should be in place prior to the start of the case. Thank you.
Do we allow questions or should we proceed?
Yeah.
If there are questions, please, 1 or 2.
I think when axillary access started, it was basically fluoro guided. You get the roadmap, injection, and then map the subscapular artery and lateral thoracic, and then puncture in the middle. But I think ultrasound guided has really complemented well, and especially brachial plexus, it looks like bunch of grapes, and it's very starkly visible there. You can't just miss out brachial plexus and then safely choose the position where you want to puncture. It has made the procedure much safer.
Yes, absolutely. Because even like with the brachial plexus sheath also injury, sometimes hematomas were causing brachial plexus injury. Not only direct needle injury. But now with us moving on the ultrasound, moving away from the brachial plexus, going more towards the second, it has like almost we're not seeing any significant brachial plexus injury.
Thank you, Dr. Sumanto.
Thank you, thank you.
So we move on to the next speaker, which is one of the most challenging, way to do TAVI. That is the transcaval TAVI, when and how, by Dr. Safiq Mattumal. Do we have any statistics from India of how many transcaval TAVI have been done?
Only reports, I think. We have seen Gopal posting 1 or 2 cases. Safiq, have you done? One.
While he is setting up, can I ask Dr. Sumanto, when you do the axillary puncture, you always do an axillary angiogram from the same side or from the same side? Yeah.
Where we will park our balloon. So it is mainly for a bailout rather than versus too much, because just delineating the branches, we get it from the CT, and we actually, when we reconstruct the CT, we kind of outstretch the vessel.
Yeah.
And we look at where the branches are. So we know where we are going to puncture. It's mostly for parking the balloon and also sizing about the stent, if in later case, if we need one.
Okay, all right, thank you.
Good morning, everyone. Thank you, Dr. Dilip, for inviting me for this wonderful educational event. I must congratulate the whole team that this is, I would say, the first of its kind large bore access in the country, access meeting in the country, and it's definitely an academic boost to the structural enthusiast. So, coming to the transcaval, which is always, ever since the first case report, it has been very exciting for each and every of us who want to, go through difficult routes and create impressive images in a cath lab. So here the principle is actually go through the vein, femoral vein, go to an inferior vena cava, find a place where it is closest to the aorta, find a calcium-free spot in the aorta, make a puncture through the vein aided by the electrocautery, enter the aorta, and then serially upgrade the dilators. And once you put a large O35 based catheter, then the stiff wire goes in, and then you finish the TAVI just like any other TAVI, and you come back and close the arterial aortic end of the hole that we created with a nitinol based device. So this is the principle. TAVI in general is more or less the same, and the preparation time and everything is mainly concentrated on the entry to the aorta and the exit from the vein. So in principle, we actually close the aortic end. Here you can see that once we take out the sheath, we put a device here. We don't actually close the IVC hole, and we don't intend to, because it's a low pressure system. The retroperitoneal pressures are high. If at all some blood extravasation occurs, we want it to go through the hole, and eventually it heals. So it is patent hole in the IVC is not pathological. It's kind of ideal to decompress the retroperitoneal system. So when the caval route was introduced, almost 20% of TAVI was not possible through femoral artery. So they had to, at that time, the thought about alternate access was so much. But now, as the technology improves, the size of the access demanding for the latest devices are coming down day by day, and we have femoral arteries that are smaller or calcific, which we pre-treat by balloon or IBL, lithotripsy, and crash the calcium, and then so practically we are doing more and more TAVI through femoral only. So the roughly only 10% of patients who are evaluated for TAVI would require alternate access assessment. So those who have diseases affecting the pelvis and heavily calcific aorta and iliac artery, so these are the cases where we consider caval. Transcaval access can also be considered for thoracic endovascular aneurysm repair, and after the abdominal type 2, especially the type 2 endoleak for therapy. So here the approach, as in any structural, it has to be multidisciplinary. We need to rely heavily on the pre-procedures contrast enhanced CT scan, and we need to find a puncture area which should be calcium free in the aortic end. It should be at least safely away from the renal artery, the renal vein, and sufficiently above the aortoiliac bifurcation in case if we need a bailout stent graft to be put in the aorta. So roughly this is after the CT on table, what we do is we find out via 2 simultaneous pigtail injection in the cava and the aorta, and preferably in a RAO 20 or 30 projection, and identify and mark the vertebral body there. Then the idea is to put a large snare in the aorta, find the position of puncture here in the IVC, make sure you use a guide catheter with a right angle tip so that you enter almost horizontally. You have methods to position the snare. Then with the help of the electrocautery, you puncture the inferior vena cava aorta in one puncture, enter and make sure it goes through the snare, and once it is snared, the caught wire is pulled up, and this whole apparatus is taken, and from one O14 system you convert it to an O35 compatible microcatheter, and then once your Lundercust wire is inside, it is the TAVI is as simple as any other TAVI. So how do you set up you need to have a proper electrocautery grounding. The cautery pencil is the routine cautery pencil that we use. We use the cutting mode with typically 50 watt. Initially, the operators used to do it in GA, but now many centers do in conscious sedation as well. They just don't give GA just for the sake of caval entry. And always take another femoral artery, preferably the left one, for guidance, pigtail, and continuous angiographic monitoring, and also for bailout stent graft. So we have to have an access according to that, everything in mind. Venous access is almost always the right femoral vein, and many centers do with the 2 proglides with a pre-close technique, or since it is a vein, to manual compression or a figure of 8 is also okay. So you do full heparinization after your system is in the vena cava and just before puncture. So here the snare that we use is typically a large one. It ideally should be at least 3-4 centimeter larger than the diameter of the aorta. Now, how do we cross? We need to make a system which is coaxial and which is graded. So this is the principle. Now, this is a 4-step system. This is an 014 guide wire. Typically, we use one of the CTO wire either for coronary or peripheral. You need something in between a 035 and an 014. So this is a piggyback, which is a graded dimension to 035. Or you can do a simple fine cross catheter as well. Then this is something like a Navi cross, or this is a 035 compatible micro catheter, and 7 French guiding catheter, usually the either short JR and or a renal curve, renal guiding catheter. So basically this will be the longest, this is shorter, even shorter, and this is the shortest. So you make a system and you go in one shot. The wire, the distal proximal wire is not shaped; it is straight, and the distal tip is cut. The covering is removed, and you attach the cautery with the arterial forceps, and make sure you don't have any forceps. So the principle is to puncture horizontally. So if you have an angulation here, it's likely that it can create a tunnel in the aorta. So here the first operator keeps the position. The position is in the center of the snare. So this is RA 20. You can always confirm in LAO 70. So here position the snare in such a way that it is overlapping in the RA 20 and it is end phase in the LAO 70. And try to aim the tip of the guiding catheter precisely in the center, maybe slightly directed towards the posterior in the LAO, because anteriorly the bowel can be there. And the primary operator hold the wire and the guide catheter, and when the secondary operator press the cut button of the cautery just for 1 second, and the primary operator pushes in one shot. Now you can see that how it enters the snare. If it is a biplane cath lab, it's easier. And once it is entered and the wire hits the aortic wall on the left side and it starts buckling, which is good. And then you snare the wire and then you lift it up. Lift the 014 wire all the way to thoracic aorta near subclavian. And over that you advance the fine cross microcatheter, and over that the piggyback and the Navi cross is the 035. Once the 035 microcatheter is in the thoracic aorta, we can actually unsnare and then remove the wire, the fine cross, and then put our Lundercast or whatever TAVI wire or a straight wire. And once it is done, it is just a matter of proceeding with the TAVI. You can always keep a pigtail and confirm the position. You can see once the sheath is inside, finish the TAVI fast, and we don't want to spend much time across the cava. And once we have done, assemble the equipments for closure. So we can actually, once we take the device, usually it is closed with a ADO1, ambulatory ductal occluder 1, or sometimes muscular VSD device also can be used. It is loaded in a catheter which is steerable, where because we want to deploy the aortic disc at 90-degree angle. Once it is in the aorta, you can pull back the delivery cable of the TAVR access, and then you bend it. Along with the device, it is a good idea to keep a double-length coronary wire for a backup in case if there is if you need to access this place. Then you can just like we do in the PDA, you make sure that it is coming at 90-degree and you are completely at the aortic hole that we created. Forget about what is opacifying the IVC, because once we deploy the device, most of the time after 5 to 10 minutes it thromboses. All right. So once we deploy this device, we can wait for some time, and all this time you have to do angiographic as well as hemodynamic monitoring, how the patient is behaving. Not always you get a beautiful picture as this. Here it is completely occluded. These are the patterns that we see after a post-device closure angiogram. One is completely occluded, and if you have something like an extravasation, you are in a little trouble. But most of the time, if the entry and exit are good, then it is usually safe, and a little extravasation into that retroperitoneal area is okay, because and make sure you pull the TAVI sheath not across the IVC, because we want the cavil hole wide open, so pull it into the vein, and you maintain the volume, maintain the hemodynamics, and volume can be given liberally. There is no need to panic and do the CT immediately, but a post-procedure CT can be done after a few days pre-discharge, and even a non-contrast CT would see and quantify about the retroperitoneal area. So to conclude, the transcaval access definitely is an alternative access in those who have difficult femoral artery. The closure is obtained in most of the time, and the data in the meta-analysis have seen it is as safe, at least as safe as a femoral intervention, definitely safer than transapical intervention. Many a time we can bail out if there is a complication happens through either by a balloon or tamponade or covered stent implantation. And this is definitely a reserve procedure for those patients who are at very high risk of TAVI in terms of disease. For the structural enthusiasts, we are conducting a structural heart congress in Cochin in April 2021. So all who are interested, please can contact me and register for that. Thank you so much for your patient listening. Thank you.
We have a piggyback catheter available in India?
No, we used a fine cross.
Fine cross. And then glide catheter can be put over fine cross. I think glide catheter can also work, isn't it?
Yeah, that also can be used.
You can use a fine cross and then a glide cath 4 French on it, but if a navicross is there, it's very good. It gives a very nice seal for the Lundaquist.
Sometimes there will be difficult entry of this O35 based this thing, then you have to take out that O35 system over the wire and put a 1.52 millimeter coronary balloon and give some dilatation in the aorta and come back again with the system and enter with the nav.
That is required. Quite a times we have seen that and we have done that. And also sometimes what I found was useful is maybe, always we snare and take the wire up. But at times I could not go while I snared it up. So snaring it in the iliac, left iliac. So you snare it down. That gives a good rail for things to just go in. Once it crosses into aorta, then you can take it up, because just because of the angulation. If particularly when you're using a RDC curve catheter to puncture from the cable.
Yeah.
So instead of snaring it up, snaring it down, get your fine cross and navicross across, and then pull the whole system up with your snare helps quite a lot.
If you take the snare in a stiffer catheter, it may be easier to pull up, push up. Yeah.
Would you recommend keeping these CODA balloon or the covered grafts in your, when you're doing this procedure?
Absolutely, absolutely. That's one thing that will save us, because we cannot take a chance with aortic. If there can be troubleshooting at each step of exit as well as entry as well as exit from aorta. So we need to have correct sized the device, stent graft, and our puncture location is precisely according to the device that is available on the shelf. So we have to calculate and predefine the distance from the iliac bifurcation and from the left renal artery, lowest renal artery.
If the puncture site closer, if a double disc device, second device is in the IDC, will it not give some advantage?
Yeah, that was the physiology of what happens to those blood that leaks during the procedure. So many propose that keep the IVC hole a little there. You don't close it completely, because that's what might prevent rising tension in the retroperitoneal, because retroperitoneal is a high pressure area than IVC. So it will always tend to decompress into the IVC. So if you close the venous end as well, there is high risk of increasing retroperitoneal pressure.
Yes. And also I think this is a very important point that you mentioned, that we need to put the sheath all the way back into the vena cava. Because if you pull it outside the aorta and you're occluding still the vena cava, you're going to be in big trouble. But if you have your venous system open, it just will bleed from aorta into the retroperitoneum and then into the vein. So it just creates a aortocaval shunt as compared to a retroperitoneal hematoma, which is much more safer and easier to deal with.
Another thing is a very similar way, below the knee, peripheral artery, veno-arterial electrosurgical connection, also same way we do the peripheral basal, also same principles.
For critical limb ischemia,
that's right.
very refractory critical limb
and the
ischemia.
refractory cases, a distal vessel, below the knee even.
Thank you, Dr. Shafiq.
Thank you
for the nice presentation. We'll go on to the next speaker. The topic is surgical cut down as routine in TAVR, Dr. Anjan Siotia.
So when Dr. Kumar rang me a few weeks back and asked me to do a presentation here, I asked him why me. I am neither an expert in TAVR, I'm not an expert in large bore access, and I do most of my cases these days with surgical cut down. And he said, okay, you can come and share your experience. So I said, fine, I'll do that, and this is what I will do for the next 8 minutes or so, talk about my TAVR journey. So I started doing TAVR 6-7 years ago in 2017, December, I think it was my first case. Initially my numbers were very, very low, 1 to 2 cases per year, and it was always with a proctor. And initially when I started doing it, it was surgical cut down, that too under general anesthesia. And then gradually I moved on to doing the procedure under local anesthesia and conscious sedation, again always with a proctor. And then I was doing percutaneous approach. We were not doing surgical cut down anymore. So my case numbers still remained very low for the first couple of years, although in the last year or two it has increased. And then last year my practice changed, and it changed because I attended a TAVR workshop. I was invited by one of the TAVR companies to attend a workshop in Astana in Kazakhstan. I had never heard of this place or this center or even this city actually by that time. National Research Cardiac Surgery Center. It is supposedly the biggest cardiac center in the whole of Central Asia, in Kazakhstan, and they get patients from all over Kazakhstan and nearby countries, Kyrgyzstan, Uzbekistan, etc. And this is the doctor I went and worked with for 3-4 days, Dr. Abdul Rashid. He does about 500 TAVRs in a year. They're a big center, very impressive. They do about 100 LVADs every year. And this center with such a huge experience, I was really surprised to see that they do all their TAVR cases with local anesthesia and conscious sedation with surgical cut down. So that was an eye-opener for me, and I asked him, you do so many cases, huge experience, when the entire world is doing TAVR percutaneously, why are you doing surgical cut down? And he said that, look, when we started doing it, our numbers were not as big, and all the complications or most of the complications we had were the access site complications, and we lost quite a few patients. And when that happened, that's not only very, very upsetting for the patient and family, but also very, very demoralizing. And you lose your confidence as a cardiologist. So we started doing the procedure with surgical cut down, and after we have changed our strategy and now doing it surgically, the complications rates have gone down very significantly, and we hardly have any complications. And there I saw how efficient they were. So a surgeon would come, he would make a very small incision under local anesthesia, this big, that's it, and expose the femoral artery, and then his fellow would go and put a tube in the radial artery for access, and then he would go and finish the entire procedure in 30 minutes. So this is something that I saw there, and then I came back to India, and then I started implementing it in my practice. And when he told me about all this, I also went back and looked at the vascular complication rate of TAVR, and I'll show some slides. Depending upon the various definition applied about vascular complication, the complication rate of TAVR range from 5 to 50%. And this is the definition, VARC, Valve Academic Research Consortium definition. Major vascular complications involve serious injury to ventricle, aorta or peripheral vessels, such as rupture, perforation or dissection, resulting in compromised flow or blood loss of 4 units or more, requiring surgical or interventional repair. And minor complications is less serious complication. And in partner 1 trial, the major complication rate was more than 15% and minor complication almost 12%. Recently, the complication rates have gone down, but it is still around 5% mark. So when the complication rates are still significant, I think in my opinion, for someone like me who doesn't do hundreds of procedures every year, my numbers are still very, very small, 1 to 2 cases a month. I think surgical cut down does make a lot of sense. It gives me a lot of security. I don't have to worry about the peripheral, access or any complication. The TAVI becomes a much less stressful and simpler procedure. The surgeon comes and under local anesthesia and conscious sedation, they open the femoral artery. I go and then do the TAVI, and then they take the sheath out and close the hole. And believe me, the procedure is very, very simple, very, very stress-free. The complications rate, so far, touch wood, I have not had any. Procedure is quicker, radiation dose is less, dye is less, and most important, after I came back from Kazakhstan, prior to that I was doing procedures with a proctor, and now with a surgical cut down, I am doing it without a proctor single-handedly. So yes, I agree, surgical cut down has its disadvantages. It is not cool to start with, you have to get a surgeon in the team, and it kind of not very good for your ego, and it leaves a small scar. But the scar is small, patients can walk in 2 days' time, and they go home 2 to 3 days later. Thank you. So just one point I will add is, for any of the audience, anybody who is still doing TAVI but the numbers are small and they are doing it with a proctor, if you switch on to surgical cut down, you can start doing the procedure without a proctor on your own single-handedly. For those who are doing big numbers and already trained in the use of groin closure device and expert in managing those complications when it happens, they don't need to go on to surgical closure. Thank you.
Very provocative statements from Dr. Anjan. So let's hear from the experts.
Okay, another question. Anjan, I am here. Nice to listen to your lecture. I'm Dr. Das Biswas.
Yes, I can see you, sir.
So it's a good experience. But is the literature survey, is there any head-to-head comparison between the two types of access, surgical versus interventional?
Not that I am aware of. Most of the time these procedures are done by percutaneous access only, and the literature I have shown you, there is a complication rate 3 to 5% I think still in the modern era of TAVR. With percutaneous, the complication rates are almost zero.
Yeah, I think
with surgical cut down, it's almost.
I think a very thought-provoking lecture, but one or two facts are there. PROTECT 2 trial, the results, the benefits were neutralized by the vascular complications. But as the kind of familiarity with the vascular closure devices, how to do it safely, came up, PROTECT 3 it just went, on a better note. The success result was much higher, and PROTECT 4 it is even better. The interim results. So similarly in TAVR, when the groin access started with per closure devices and all, so many nuances we came to know, and finally, if we keep on doing with per closure devices, also it looks very kind of safe, just like endovascular. You do an endovascular, EVAR, a surgeon will give you a cut down, you just go and place a EVAR. Similarly, we can do a TAVR, but still with the familiarity and the kind of devices which we are having now per close, you are familiar with the devices. Probably now if we go head-on-head comparison, it won't be much different.
I agree with you. I fully agree with you. It's just a matter of, to become an expert in any procedure, you have to do more and more of it. The problem with TAVR is the case numbers are not that many. I don't know how many you have done or how many you do in your centers, but our numbers are still very, very small. If somebody is a proctor and going around doing hundreds of TAVI, then they get experience, and more important than doing the procedure safely is to manage the complications when they happen. When your numbers are very small, then you don't have that confidence that if something goes wrong, you'll be able to manage it appropriately. And you don't want to lose a patient on the table after a successful TAVI just because you have a groin complication. So that's why when Dr. Abdul Rashid told me what he told me, I thought it made sense. And even, that center which does 500 TAVRs in a year, they are doing it for safety concern. And also another point he jokingly said was, and it is cheaper as well because we don't have to use 2 proglides. It's cheaper to get a surgeon there and that's probably true for India as well. It's probably, it will save you a lot of money if you don't use 2 proglide and get a surgeon to do the cut down. So you save money as well, it's safer, and a lot of peace of mind for a low volume operator like me. I know there are people who are very, very experts here in this audience who have done hundreds. For them it doesn't make sense, but for low volume operator, I think it's a perfectly reasonable and safe alternative.
I think I take your point, but I tell you how we have grown, although our numbers are also not very huge. But for last 2.5 years, all our femoral PTCAs, we are closing by either angioseal or by proglide. So this is how we have got familiarity with these devices. And if you're not doing TAVR, but if you're doing a kind of 100 proglides or 100 angioseals, you are as good as an effective operator in vascular closure devices, as a very kind of prolific TAVR operator.
You are perfectly correct, particularly in cases of endovascular treatment or treatment of aneurysm, thoracic or abdominal aorta. We routinely used to do the transfemoral dissection by the surgeon. There are no problem. We are accustomed to do it also.
Thank you.
So the last talk of this session is anesthesia support in access and TAVR procedure by Dr. Somnath Dey.
Thank you all. Now I am starting the lecture about the anesthesia support in access and TAVR. Cardiac anesthesiologists have a pivotal role in the structural heart disease in interventional cardiology in the last era. And now I am coming to the evolution of the anesthesia in TAVR. It is also the plan of the anesthesia also changes from the earlier days when in 2002 when the TAVR started in America, and then it is almost 4 lakh cases around the world. So the evolution in the anesthesia in case of TAVR, the patient have severe calcific native valve aortic stenosis there is mainly, they thought there is a surgical closure, there is the SAVR, aortic valve replacement, and then it comes to the changes, the evolution of the changes to the TAVR. And now in almost SAVR is downgrading, and the TAVR is upcoming in these topics. In the TAVR approved in the late 2011 in extremely high risk group is subsequently approved for high risk 2012 and intermediate 2016 and low risk 2019 patient as per STS from classification. In 2019, TAVR procedure surpassed the SAVR procedure. The approach of anesthesia for this procedure has also evolved. Initially, general anesthesia was preferred. Now, currently, almost all cases, there is conscious sedation with monitor anesthesia support is required. Now, is the current trend of TAVR is the wide monitoring with the minimalist approach for this TAVR. TAVR minimalist. The primary advantage of TAVR has always been its less invasive nature as compared with the surgical aortic valve replacement, and it comes from general anesthesia to conscious sedation. Experience in our center, we have done almost 30 cases, and out of which only 3 cases we done through this general anesthesia support. And in these cases, I will show you one cases in general anesthesia support with LMCA stenting with TAVR later on. And in this case, most of the cases performed under conscious sedation. Only arterial line and JVP through the jugular venous sheath or any femoral sheath, venous sheath. And the sedation is almost given by the dexmedetomidine or midazolam, fentanyl or propofol, plus minus propofol support. Why anesthesiologists prefer general anesthesia? This is the old era practice. Because they are more familiar with the conscious, more familiar than the conscious sedation, and easy to control ventilation, airway support, and more invasive monitoring and information from the gate from general anesthesia. If complication happen, then there is almost all line is there, so they are more confident about treat the patient if there is any mishap occurs during these cases. Now it is why now it is changes to conscious sedation to avoid the hemodynamic instability associated with the intubation and extubation support, and continuous neurological monitoring we can do, and rapid recovery and improve patient safety. And it becomes a TAVR procedure, it is like a daycare basis also. We can discharge the patient next day usually, and next coming years it can be procedure of the daycare basis. In general anesthesia, this is the one article in 2014 in circulation. There is a clinical outcome and safety of the transfemoral aortic valve implantation under general anesthesia versus local anesthesia. Now there is a global trend. The types of anesthesia changes through the years. Now earlier it is the support of general anesthesia. This is the general anesthesia. Trend is slightly decreasing from the years, and this is the conscious sedation, it is up. And there is another slide, there is the changes of the propensity of matching of analysis of 30 days survival is almost same in 2 graphs. Now another article, this is just currently published in last month, the optimizing anesthetic selection of and in TAVR cases, striking a delicate balance between the efficacy and minimal intervention. It is published from Texas University Hospital, Fada et al. They shows the difference. In multi-center TAVR, the plan of anesthesia is almost changing, and the sedation, conscious sedation is likely up. and the general anesthesia goes down. It is also the meta-analysis, this group of studies from the 2011 to 2020, says that the hemodynamic instability is almost same, and the outcome is there is no difference of the general anesthesia and the conscious sedation. So all studies is showing the same result. These are the current studies, and this is also 2021 USA study. This is also says that all are same. And now the anesthetic support. In the anesthetic support, there is a difference of the hospital stay is also, and the 30 days outcome is almost same, and the cost benefit also in case of conscious sedation than the anesthetic support. When should we consider the general anesthesia? General anesthesia usually consider about the certain factors. Including the patient factor, there is a positioning. If patient cannot sit down like that, is a cardiopulmonary comorbidities, if there is airway issues, and if patient is not cooperative, and there is also some factors, there is a procedure factor, surgical approach should required, mechanical ventilatory support required, movement or breath holding required, or using long process of the TE support is required, then we will changes to the general anesthesia. In our center, general anesthesia required is if need of surgical approach like femoral access, if required surgical exploration, intubated, if intubated already patient is intubated state, severe cognitive impairment, if there is severe pulmonary decompensation, and heart tip once there is if necessary for the general anesthesia. General anesthesia cases over the monitor anesthesia care in our center, only I already told there is only 3 cases out of 30 cases. If I want to show you a case of the LMCA plasty with TAVR, this case was done under anesthesia, general anesthesia support. The 69-year-old male with CKD on maintenance hemodialysis, post PPI, BVI, and there is severe calcific AS. Gradient is 112 and 67 mean gradient. Patient waiting for the TAVR for last 20 days, and during that period it becomes a drop is positive, and the ejection fraction is deteriorates from the 55 to 30%, and there is a hospital stay for 2 weeks, and the pulmonary edema develops with the hypotension. CT aortogram done, protocol as per this, show this CT, and after showing this we can see there is a left main disease, huge calcification. This is the left main disease we can see. So we change our plan to do the left main angioplasty with TAVR in same setting. This is the CT of the peripheral vessels is also disease in this femoral site, the left interiliac. And now this is, we start, there is a left main angiogram during the day of TAVR in intubated state. This is the left main disease by bifurcation and RCA. Now we see this is the axis, right axis from taken, and after accessing, get the check this, and now the supporter is given the balloon through the left main, inflated, then left main. After inflation, then it is stented. Now we do the TAVR procedure start. This is my valve. Now, and the patient extubated on the next day, discharged after 3 days, doing well, and now gradient is almost 8 millimeter, and ejection fraction is also improved. Now, in summary, there is a anesthesia role in the access is USG guided vascular access. It is an very access is supported by also the anesthesia support, and TE support required if jugular venous sheath or temporary for pacing, or also we can use this the inotropic support through this same sheath. And minimalist TAVR strategy has been more adopting, and performing a TAVR under conscious sedation is at least as safe as general anesthesia. Hospital stay and post anesthetic complication reduces dramatically, and we should rethink for conscious sedation in patient with several comorbidities. Now the take home message is evolution of the anesthetic technique for the TAVR procedure has shifted from general anesthesia towards the conscious sedation over the last decade, and non-invasive techniques such as anesthesia monitor care and the supraglottic airway device and minimalist approach has been shown to have the favorable short-term outcome with safer profile, similar efficacy compared to general anesthesia. Conscious sedation preferred over the general anesthesia for TAVR due to its advantage in terms of reduced morbidity and mortality. A multidisciplinary approach to be considered when selecting the appropriate anesthetic form for patient with severe comorbidities and increased risk of complications. Thank you, sir. And last of all, you have the confident cardiac anesthesiologist. You do not worry about the procedure, just do your job. They will do their own and make your patient safe.
Dr. Somnath is our cardiac anesthetist, he is a DM cardiac anesthesia, and he is the support we all enjoy, and we rest assured that things will be fine. Thank you so much, Somnath, and I thank chairperson and moderators.
Just one comment I would like to add, that I'm sure that like STEMI, primary angioplasty, one day is going to come very soon, that primary TAVR. Patient comes with acute pulmonary edema and emergency because of severe aortic stenosis, intubate, take the patient to Cath lab, deploy the valve. In some centers are actually doing it in the world.
So, thank you, sir. And so we can move on with the next session. Thanks, chairperson, moderators. Dr. Safiq, you can make a comment.
Yeah, just about the primary TAVR, because that's one thing that will come, you know, when the dry tissue valve technology comes and you have preset sizes of valves on desk, just like our stents, where you don't need a company guy to come and prepare for you, load your valve. Exactly. And there is a wire recently which has come, Savvy wire, which has a distal pressure sensor as well. So it is just like one wire, one balloon, one valve, and closure like a large bore access and come out. So, yeah.
Thank you. So we move on to the next session. Since the tea is rolling tea, so we are not going for a tea break. We can, may I invite Dr. Mantosh Panja sir, Dr. Kajal Ganguly, Dr. Suvaran Rai, Dr. Biswakesh Majumdar, Dr. Arup Das Viswa sir to kindly chair the session, and Dr. Kuntal Bhattacharya, Dr. Gopal Ghosh, Dr. Sankalan Saha, Dr. Karak, and Dr. Madhubati Panja to be on the dais for moderating the session.
Thank you, Dilip, for organizing meeting. I encourage you. So, very important. Please come. Therefore, now I'm going to start very important things, the closer devices. Dr. Dilip Kumar will present his experience along with the whole technique, complication, procedures, this thing. You know, the particular arterial closure, particularly compression, there is very important. By the hand compression is the gold standard, you see. Now, because this create the problem, because procedure time and the immediate, that is the patient discomfort and immediate closure not possible, many cases take more time, 45 minutes, 1 hour, so that is disadvantage. Therefore, what the alternatively, which is most scientific, the device closure, now Dr. Dilip Kumar going to give the lecture on that point so that we have greater knowledge. Dr. Dilip Kumar, please.
So, yeah, thank you, sir.
One moment, Dilip.
Yes.
Just an accolade, don't take it seriously. Dr. Panja has already covered the topic. I am going to cover Dr. Dilip Kumar himself. We have seen him in FSCAI as a nicely going boy, dynamic, but very sober. It is nice to see him now at this stature. I know him to be grown up enough to be a big interventional cardiologist in our city. So a big clap for him. He has organized this conference also. Thank you. Dilip.
Thank you, sir. Thank you. It's great to have our teachers there, and and I'm beginning my lecture. So whole talk and idea was how to go safe and how to come out, and that is where a very thought-provoking lecture came out. That why not to get surgeons in our lab, let them give you a kind of good hole and a sheath, and then you go and do a tower, just like a wire. So we can do things, but if we start something more less invasive, we take some time to master this procedure and to avoid complications, and that's what I'm going to deal in next couple of minutes. Vascular closure devices, how we pre-close and how we come out. So right since 1953, when we got Seldinger technique, this is the method of choice, and femoral access and other access through this technique is the preferred ones. And although we can see complications, but complications rate are coming down as we are moving towards more precise punctures and more precise bailout techniques, and how we come out from going in and safely coming out. But still there are some patients where risks can be higher, like female patients, obese patients, elderly patients, patients with on oral anticoagulants, peripheral vascular disease. In these patients still these are challenge, but we have a goal to minimize these complications and reduce the time of hemostasis to ambulation, and giving less of saving nursing time, and patient needs to go home quickly. So right from days of manual compression, we have now come to vascular closure devices, and essentially we have two kinds of closure devices. One is active approximators like ProGlide and a ProStar, but ProStar is out of question. In India it's not available, number one, and in all the trials ProGlide has fared better, and complications rate with ProStar is higher. The needle was much larger and the complications rate were higher. So ProGlides are the method of choice for active approximators, and the passive approximators are like AngioSeal and Manta device. Manta device is going to be available in India very soon. It will be marketed by Teleflex, and I asked them to come and do it free demonstration here, and we will not charge anything. They have got some clearance and compliance issues. DCG has still not given them clearance, so Manta is not available as of now, but soon I think they will get it clearance and Manta can be available to us. These are basically collagen and gel based devices. So with AngioSeal we can manage 7 to 9 French holes, ProGlide 6 to 21 French depending on how many ProGlides you are taking, and Manta device 12 to 25 French. And this is the AngioSeal, very easy three-step deployment, and I will just take you all through that. There is a distal anchor which is bioabsorbable. In 90 days it totally gets absorbed. Then there is a collagen plug, there is a suture, and then there is a carrier tube, and finally device sleeve and device cap. So they have got dual security. One is anchor and then is a plug. So from both sides it is closing the arterotomy side. So I will take you through this. Can we have the sounds for this? So you can see here, this is the wire, which is a little long wire. Is this audible to everyone? Is it audible to everyone? Yeah. So once we are coming out, then we take this wire in, and sheath comes out, and over this wire we take the kind of AngioSeal. This is the vessel locator, arteriotomy locator. So once you go in, start going in, you can see the blood coming out. We are going in, and you can see here now the blood comes out. Yeah. So it means you have just entered the vessel. Then you come little out, and then you will see the blood getting stopped. So this is the site of arteriotomy, where your needle has punctured the vessel, and just when your blood comes up, starts coming out, this is the place where you take out the wire and take the collagen plug inside. You see, and the logo should be up. This is the logo up. It has to be maintained, and once you go in, there will be a click sound comes when the plug gets attached to the anchor, and then you remove the assembly, and this inner tube has to be pressed towards the skin so that the collagen plug and the anchor gets attached over the anterior arterial surface. And then you cut, and remove this tube. Finally, you cut this small wire also, and the vascular closure is done. So this is angioseal. It's very easy, device, and we have angioseals available here for all those who are new. They can try their hands and get a hands-on experience. Now coming to angioseal has got little kind of storage requirements, and it should be stored following the recommendations given, and it's totally absorbed in 90 days time. Coming to proglides, basically you can pre-close and as well as post-close the holes, and this is very important. To begin with the ultrasound guide puncture, this marker of the ultrasound probe is one has to be oriented with. The marker corresponds with the P, which is their marker, so that you can make out lateral medial correlation. And I will just quickly go through the proglide steps, not the entire ultrasound guide puncture which has been covered. So once again, the wire is in, and then the access site, the kind of track has to be well prepared, because once your the proglide, the suture has to go in, it should not be trapped inside the tract. So you have to gently and very clearly give a stab, and then you have to open the tract with a artery forceps, and the artery forceps should be curved up, should not be injuring the vessel, and then you take your proglide, and the angle should be 45 degree. This is very important. The angle should be 45 degree or even less. Once you go high, the chances of wire breaking out is very common. There are 2-3 common reasons where why the sutures they snaps off. One is the kind of more pressure on the plunger. Second is the angulation, and third is the calcium in the vessel. So once you see the blood is coming, you put this foot plate up, make a gentle pull, and then you put the plungers down, so the needle will catch the sutures, and then you have to just push it little bit, put the foot plate down again. See, once you are taking this out, you have to cut the sutures. So once the suture is cut, you have to take it down little bit and put the foot plate down. Yeah. And then you have to come out and retrieve and harvest the sutures. So the sutures will be there between the wire exit ports, and these two sutures, one is a white end tip suture and one is the longer one. The relationship of these two sutures should not be messed up in the beginning, because there the knot can be made there, and the place where we want to get the knot will not happen. So this two sutures which you harvest has to be held tight with artery forceps, and the relationship should be maintained there. And then you can see here two white markers. These are the wire exit ports, and you put your wire down and you can give your second proglide here. Or if you are going to do procedure on one proglide, you can do over this. So this is how basically we do pre-close, and finally when we do procedure coming out, then you take this knot pusher in, and hold the longer wire. Over the longer wire, this knot pusher goes in till it reaches the anterior arterial wall, and then tighten with the other suture, which has a white end, and that's how the suture gets totally, it catches the anterior wall of the artery, the arteriotome and arteriotomy site, and the vessel is closed. And then you cut with this cutter. So this is how vascular closure devices are done. The videos are available on YouTube. The angioseal and proglides are available here. Those who can try their hands, they can do that. And you please do in all your femoral cases, angioplasty cases, so that you won't be having problem when you are going for a TAVR procedures. I tell you, when I did first Impella, I did not ask for a proctor, because I was pretty sure how I am going to close this vascular access of 12 French Impella device. So this is how we grow. We have to do the things repeatedly again and again. So with this I end here. Manta device will be dealt by Dr. Vikas Majumdar. He has some experience in UK, and will be showing how Manta device is being done, and it will be soon available to us in next couple of months. Thank you so much for the patient hearing.
So thank you, Dr. Dilip Kumar, for a nice elaboration of the part closure device. So I have a few questions, and you can guide the newer one who are not comfortable with the application of this device. So suppose a puncture site is 9 French or 8 French, what device you will use? And if it is 14 French, then how many devices, and whether it is in combination of 2 ProGlide or 1 angioseal, 1 ProGlide, and the angle of application, at which o'clock it should be deployed with 2 devices.
So I think we have discussed it, in the morning. Till 14 French, like TAVR procedure, we go with 1 ProGlide, 12 o'clock position, and once the wire is there and you have given a knot in the suture, still it's bleeding, then we add on with an angioseal. So 1 ProGlide, and additionally required, if it is required, 1 angioseal is done. For 7 to 9 French, I think angioseal is better. You can, over the wire, you can go and fix it with an angioseal. And less than 7-8 French, I don't see any value in going for ProGlides. Angioseal is good enough.
I think we can discuss Manta later on.
Yes.
But the single Manta will close a large bore.
Yes, sir. Yes. The same, the concept is similar as of angioseal is a collagen plug device, but it takes care of the larger, accesses. More than 12 French, 13 French, 14 French, up to 19 French.
Sir, after angioseal, how early you can reuse the site, access
Yes,
site?
so angioseal takes 90 days to totally dissolve. Okay, so you can use other access, or you can use same access, 2 to 3, centimeter proximal or distal. You can use that.
Same site we cannot puncture.
Same place you can't puncture, but ultrasound you can see the angioseal, and you can go above, and then you can puncture.
Particularly during the part closure, as the leg should be abducted at 70 degree away.
Yes.
It is convenient for this puncture altogether. Any question from?
My question was already asked. If you do collagen-based closure, the risk of doing a re-intervention or bringing the patient again, if you need to, before the stipulated period, becomes a complication or a risk.
Yeah.
So, ProGlide or pre-close is much better in such cases where you think the patient will need re-intervention.
Definitely. And this is also important. If you put an angioseal, you can't be pressing it very hard. Sometimes these angioseals can dislodge, go down, and can occlude the artery. So it has to be gentle pressure. In suture-based devices, you don't require any pressure, but sometimes in angioseal you require little pressure, but little gentle pressure. Dr. Sandeep, you are asking something.
Sir, nice presentation. Thank you. I am from cardiac surgery, different specialty. So what I want to know, in our peripheral access, our cannula size is around 16 or 18 French. So for 18 French, what do you suggest?
2 ProGlides.
2 ProGlides. Okay, thank you.
But if you are going for ECMOs ECMO, so ECMO stays for many days, and there pre-close may not be a good option because your sutures can be can be cut, and you can't just rely on that. So after 10 days, 11 days, these 2 sutures are being placed there, can also cause infection of that site. But still some centers are doing. But Impella, it is commonly used, and this is the commonest way.
Surgical cases, 2 proglides are fine. Okay, thank you, sir.
Okay, Dilip, I am very proud of you. You worked with me 3 years during the DM course.
Thank you, sir.
That's but he is very energetic, but sometimes very sentimental. He decided to leave the DM cardiology course. When I sometime one day review, you can remember. Okay, Dilip, thank you once again.
Okay, let's call in another very dynamic and sentimental person, Dr. Robin Chakraborty. He is a very good speaker, very good worker, and another hidden treasure in him I have observed is a very good orator also.
Oh, Robin.
Dr. Bhattacharya will present after Dr. Robin Chakraborty, sir.
Now, Dr. Bhattacharya also, both electrophysiologist and as well as the interventional cardiologist, and Dr. Chakraborty really enough experience in this field of intervention both abroad, USA and in our country as well. So he is my bosom friend. Dr. Chakraborty now present the new generation devices, both TAVI as well as the femoral. Dr.
Thank you, Professor Panjas, for the nice word, and Professor Dasvisas, thank you very much for the nice word. So my talk is a new generation of TAVI devices, and I think this is very pertinent to talk about such topic this afternoon. And clearly we can see that the TAVR is moving fast, and I'm really surprised if you look at the history, sometimes 20, 30 years ago, or maybe 40 years ago, the TAVR was conceptualized by Professor Alan Crevier, and it's very unfortunate that he is no more. He was with us a few months ago in Kolkata. But from those 1985 till today, there's a huge development in the TAVR technology, including its application, the size, the design, and architect, everything. And from there onward, if you look at this slide, it can see clearly that from core valve to sapien, that is a self-expandable valve, to balloon expandable valve, down the line today, we are actually going up to something new, something accurate, or even Merrill's My valve, or even Sajanand's Hydra. So there's huge development. And this is the kind of number of valves that are available at the moment in the world market. And if you look at India, even Indian companies are preparing some very nice, good quality valves like Merrill My valve, which is a balloon expandable valve, and Sajanand Hydra, which is self-expandable valve. So we are no way behind these other companies in this world. But so this is the kind of valves which are available today in the market, and you can have an option to choose depending upon your priority, depending upon the patient's need, and depending upon the patient's condition, and your familiarity and your personal experience. But the question remains that why we need to have new generation. The reason why you need to have new generation, because the first and foremost is there should be an adequate safety. The valve should be better durable. There should be less paravalvular leak. There should be large bore access should progressively be minimized. Therefore, the bleeding complication will be less. And the valve migration, we are aware that even, I still remember that in the first time when the TAVR was shown in TCT, and the first time I was so excited, and I was so surprised, and the next year in the same meeting, they actually showed some of the complications of those cases which we had done previous year, and some of those valves actually migrated. That was disturbing. Furthermore, there's something like coronary access, a better coronary access, and we are all aware that many of these patients after TAVR do require permanent pacemaker implantation. So now they have shown that if you can change the design, you can have better sort of stability so that it doesn't hit the AV node, there could be reduction in permanent pacemaker implantation. And finally, the higher device success. That is important. So why new generation? This is the slide which clearly shows that yes, if you can enhance the anti-calcification technology with a kind of a special valve. So how it can be done? It can be done by changing the strut, by changing the design, moving the base, and the leaflets. For example, if you can have a better quality of leaflet, something like Resilia, then probably the Resilia tissue platform can be a better option as compared to the previous one. So from Sapien 3 Ultra to Sapien X4, it has been shown that for novel frame design, providing adjustable sizing, low frame height so that you can access the coronary in a better way, and larger cells, which are again very important, and enhanced PET outer skirts. So, and furthermore, in addition to that, the delivery system also has to improve. So these are the new technologies which has been incorporated in the developmental process of TAVR. There's another example from Evolute Pro Plus to Evolute FX. Evolute FX, again, a latest iteration of the Evolute catheter heart valve. It is a 4th generation Evolute FX, which of Medtronic, which has entered in the market sometimes 2 years ago. And it has been shown the nitinol delivery catheter is capsule that allows the recapturing of the valve. One of the issues always remains that once you deploy, and if you deploy in a wrong manner, I actually see it myself, one valve has gone in, it didn't fit well, so you have to put another valve to prevent the paravalvular leak or even the proper sort of stability at the across the aortic valve. So these are the issues which has been taken care of by this new generation example. There are other features, for example, single spine versus 2 spines to improve the delivery flexibility and trackability, improved nose cone design for smoother femoral artery insertion. So if you got a nose cone, your access through the vessel is smooth, and that prevents the bleeding complications of the valve. Enhanced visualization during deployment. So the radio-opaque marker has to be designed in such a manner when you deploy the valve, you are quite happy and satisfied with the position of the valve. And finally, an optimized stability layer for more predictable valve deployment. And this is extremely important for this TAVR technology. So therefore, the new engineering thoughts came up. And that could be in Portico and Portico Navitor is an example where a large cell designed to minimize the coronary obstruction and improve the coronary access. Therefore, dedicated inner and outer Navisteel fabric cuffs which actively synchronize the cardiac cycle in order to fill the calcification related gaps between the transcatheter heart valve and with the virtual basal ring. Induction of 14 French low profile flex nav delivery system, again with improved deliverability and feasibility in patients with small peripheral access is important. And furthermore, the accurate NEO2 transcatheter heart valve and the accurate NE2. This is another valve which is again a further development in the TAVR application technology. So, and then again coming back to the balloon expandable valve, there is a further development in Sapien, Sapien 3, Navitor, My valve, Indian technology is a phenomenal valve, particularly if you have a good sort of coronary artery, then this access problem, then this valve situation can be considered. Even the Medtronic has come up with a newer technology. And Hydra, again an Indian product with high flexibility, easy coronary access, optimized hemodynamics, and reduced conduction abnormality. That is what is being prediction. So this is what is being in the market. Now coming back, and I think finally, we also need to talk about a little bit, we are all talking about TAVR in aortic stenosis. Now people are thinking of TAVR even in aortic regurgitation. There are situations when you got aortic stenosis and aortic regurgitation together. So whether TAVR can be done. Yes, new generation of valves are there for TAVR. And this is an example where it's called GenaValve triology. The phenomenal trial is going on. There's a publication in JACC recently where they are thinking of using even TAVR in severe aortic regurgitation. GenaValve probably is one of those. Now let us look at the data. The data shows, the early data, sometimes in 2018, showed that in a propensity score matched analysis, we observed comparable VRC2 early safety composite outcome in patients treated with an early as compared to newer generation transcatheter heart valve devices. The newer generation transcatheter heart valve devices showed a significant reduction in terms of moderate to severe your paravalvular leak for 30 days with a lower rate of transheart valve migration and bleeding complication. However, there is no difference has been found between the occurrence of complete heart block in these two groups. There's another paper, publication, this is called REST paper study. This group has shown the 1 month follow-up, and their data shows the transcatheter aortic valve implantation for aortic stenosis is beneficial in inoperable high-risk patients. The new generation TAVI devices have been recently introduced, but comparative analysis are lacking. So in their paper, it has been shown, this is the data which has clearly shown that with the newer generation, if you look at the position of the valve, the paravalvular leak, the bleeding complications, and the pacemaker deployment rate, there is significant difference from reduction of paravalvular leak, the better durability, the less complications, and of course the valve migration and the other complications like bleeding. However, they could not as yet establish the occurrence of complete heart blocks, particularly the permanent pacemaker implantation in between these two groups. So clearly, there are certain other conditions may be associated: calcification, pre-existing AV node disease, pre-existing conduction system disturbances like complete left bundle block. These could be an associate. This could be a reason why there may not be some difference. However, people are working on that, and they think that there are certain valves which probably can reduce the pacemaker implantation. So this is the Kaplan-Meier failure curve. Again, is not difference, and this is the valve which I have shown. And finally, to conclude my talk, I say that the new generation transcatheter heart valve, aortic valve, is still evolving. We haven't come to the conclusion. We are probably right now at the 4th generation of the valve, but we need to evolve. We may have to wait for some more time for an ideal valve for TAVI or even transcatheter valve deployment. Eventually, probably most of the patients of severe aortic valve disease, both aortic stenosis and aortic regurgitation, will be benefited with TAVI, with simple vascular access, with the least valve-related complication, with the least bleeding, without much requirement for permanent pacemaker implantation, and finally, the long-term durability of the valve. Thank you very much.
Thank you, Dr. Chakraborty. Excellent presentation. What is the current situation and the new valve is the Basilica?
Sorry, sir, say it again.
The current situation, a current result of the newer valve Basilica.
Right. I think the current situation at the moment is the bleeding complication certainly has been minimized. The paravalvular leakage has significantly come down. I'm not quite sure whether the complete pacemaker permanent pacemaker implantation rate has significantly gone down, but maybe in an isolated manner, an independent operator wise, probably it is less, it is much less. And people are actually trying, even in India, in certain centers, doing TAVR in aortic regurgitation as well. I'm not quite sure what is the experience overall in our country.
Robin, you have nicely summarized. It's a large topic to discuss all the valves. But given the choice, if you have given all the valves, which one would you choose? Would you go by your choice of the valve blindly, or you will look into the aorta, coronary anatomy and other things before going into the choice?
I think very, very well said. I think this is a very pertinent question. I think not only me, I think all the operators, in every center, they would consider the patient's condition, that what is the background, how significant is the aortic stenosis, what is the degree of calcification, is it bicuspid valve or tricuspid valve. In addition to that, the distance from the bottom of the aortic root to the coronary sinus, that is an important composition. Whether or not patient has associated coronary artery disease, whether you may have to do both angioplasty and valve deployment at the same seating. The femoral artery diameter is an important consideration to decide the size, to decide the valve. That is an important component. So there are various parameters one has to look into to choose that which valve would be the right kind of valve for that patient at that point of time. And of course, the operator's personal experience is equally important.
Thank you, Robin.
Thank you.
Very excellent presentations. You rightly mentioned that the indication of a TAV is increasing in different clinical situations, like the bicuspid valve as well as the isolated aortic regurgitation even. In spite of some, similarly the complication gradually declining. Thank you very much indeed for your presentations. Next.
May I invite our next speaker, Dr. Devdatta Bhattacharya, who is a very senior consultant and Cath Lab director at Narayana Health Rabindranath Tagore, and he is experienced in at least 15 to 20 TAVR cases per year, and he's the master in handling all complication in our cath lab. And whenever we junior and fellow colleagues feels trouble, coronary perforation, or whether it is a retroperitoneal hematoma, he is the first person to call upon. So, sir, the stage is over to you. We'll learn the complications and bail out.
Can I have my presentation? Pointer ache? Yeah, it's almost there. Page. Okay, thank you. Thank you, Kuntal. Thank you, Dilip, for asking me to give this presentation, and congratulations for arranging this conference. I'm sure that we are all learning from each other. We have done some transcatheter aortic valve implantations, and I'll talk to you mainly about my experience with vascular complications. So we have been moving away from femoral artery towards the radial artery over the last several years, and we have been cultivating the idea that smaller is better, less complications and less hematomas, less false aneurysms. But the advent of structural heart disease has caused us to take a fresh look at the femoral approach. And you have been listening to how to perform safe femoral punctures and how to avoid complications. However, in our country, unlike Westerners, our arteries are a little smaller. And as a result of that, we have a little more complications, and we need to be aware of these complications, why they occur, how to avoid it, and what to do when they actually occur. So this is what we have been talking about, and large bore access has become a necessity. And femoral access is the commonest access. 95% of all these transcatheter aortic valve implantations, or even more, are done through the femoral artery, and that is what we are experienced in, so I'll talk only about the femoral artery. There are other approaches, maybe in another conference, or more skilled operators can tell you about them, but I don't have experience about these approaches yet. So this is what we have been talking about while we have been going downwards in in coronary interventions. In structural interventions, we have to use large bore access. So this is the usual femoral and other related arteries that we traverse through during TAVI. These are the dimensions, and you can see that this is a Western data. And if you look at the common femoral artery, it is usually 7 to 9 millimeters in Westerners. Then as you progress upwards, it becomes 8 to 10, external iliac, common iliac 10 to 12, and aorta 17 to 20. But however, in a large portion of our patients, we find that the femoral artery is much smaller. And often we find that along the course of the femoral external common iliac artery, there are segments of the arterial, the vascular system, where it is like 6 or 5.5, 5, or even less than that. And that is a problem because the devices need a certain caliber of the femoral artery for it to be safe. And this is in general, these measurements you need to remember, these are the smallest. So if you are using self-expanding valves, 5 to 5.5 millimeters, for various sizes of the devices, and this is the smallest diameter. Beyond, if you are less than this, then you are going to be in trouble. And for balloon expandable valves, 5.5 to 6. These are the two figures that you should remember, because if it is below this, then you can anticipate trouble, vascular damage, as I'm going to show you one case. And what are the common factors that complicate peripheral access? These are, as I had just said, small sized vessels, tortuosity, and calcification. And all these things you can assess from the CT angiogram. And you need to look at the CT angiogram very carefully so that you can anticipate problems. So detailed peripheral analysis of the detailed analysis of the peripheral access throughout the length. Look at calcium and avoid puncturing at the site where there is calcium in and around it, and taking precautions during the puncture procedure. So we are all familiar with this. You get a diagram like this, and they give you the dimensions of the vessel. Here you can see that the vessel dimensions are quite nice, and really we don't need to worry a lot. However, this is what you need to look at. Even if they have given you the three-dimensional analysis, you should be able to analyze the CT yourself and do a millimeter by millimeter analysis and look at the vessels yourself and measure them. It is not very difficult. You can take the help of your radiologist colleague, and it is not difficult. You can measure the internal lumens, you measure it in 2 diameters, and then you take an average of it, and be aware of how the cuts are. Sometimes they are a little oval than circular. And then what you should be looking at is, where is there calcium there? Because if there is calcium, then the vessel does not expand as well. So vessels, arteries, you know, as they are elastic structures. So they expand and they contract. And if there is no calcium, as you are taking a device, you can expect the artery to expand. However, if there is calcium, and if there is concentric calcium, then it becomes very difficult. It obstructs the passage of the hardware, and it doesn't want to expand. So this is a demonstration of where the calcium is in the vessel. You can take a look at it, and then you can decide over where you are likely to face difficulty. In this case, the calcium is very minimal. And this is a stretched out view. And this is the snake view, and here you can see that there is a marker going all around, and you can interrogate the artery at each of these points, and you can measure it for yourself, and you can be very certain whether you are going to experience any difficulty or not by what the dimensions of the vessel are. And I have already told you that what is the minimum that it should be for a safe passage of your device. So I will conclude with a case example. So what are the complications? You can have dissections because you are taking large, where there is a tortuosity, and you are forcing a large device through it. Although you have a very stiff wire, you can still have dissections. Dissections are easy to manage. You put stents there. We do coronary dissections, so we put stents there. But something worse can happen, and I'm going to show you this example, which is one of our cases. A very frail lady who came in with cardiogenic shock with a very severe aortic stenosis. She improved, and then we took her up for TAVI. I'll take 2 minutes. So this is this picture was playing. Ekhane play korche na keno? When we checked it there, it was playing on your computer there. Okay, yeah, there we are. So you must have seen this by now. So we are, can you play that again? Yeah, so we have gone in through the other femoral artery, we are taking a scout film and we are trying to puncture it, and this is a micropuncture kit, and you can see that what you want to do is puncture at a safe place. You have looked at the CT angio and you want to puncture above the bifurcation against the femoral head preferably, and then you want to puncture in the middle of the femoral artery. You do not want to puncture at the sides. So as you are injecting there, you can make a nice puncture, and okay, this is causing me some trouble. Anyway, so you know, we have punctured it through the middle, and I need you to, okay, so this is the proglide going in. We put in 2 proglides. I will cut short. And what happened in the end, I really need you to play this picture. This is where so you can see what has happened. So this is the end of the procedure, and you take a picture to see whether there is dissection, whether there is perforation, and these usually occur at the common or internal iliac or external iliac or at the femoral artery puncture site, and you can see it has occurred at the worst place. It has occurred at the femoral artery puncture site. And if it is in the external iliac or the common iliac, then you can go in retrogradely. Just you have the wire, you just push the wire in and you put a covered stent in. But however, this has occurred right at the puncture site. So you have to seal this, and for that you have to come retrogradely. Now usually we have a retrograde wire, V18 wire, we use it so that if this complication happens, then we can quickly stent the vessel. But in this case, in all the confusion, the V18 wire also got dislodged. So we had to go in and we had to put in another wire again while someone was pressing on this artery. And we did that. So this is the, I'm sorry, I'm just going to finish. So this is the stent. So we have crossed it, and this is the stent again. Can you play this picture? Okay, just forget it. Just play this picture for me. Play this picture, please. So we have deployed the stent, and you can see that
This is covered stent or general stent?
It is a covered stent. It is a covered stent. It's a perforation. So you have to put a covered stent. So we have covered we have sealed the perforation, and we have gone beyond it. So you have to come down below the site of the puncture for it to be sealed. If you don't do that, then what you do is you produce an open tap in the femoral artery which communicates with the exterior. So it is very important to go below it so that it is sealed. And so we have various stents available for bailout, and we have used the Fluency stent. There is also a Covera Plus stent from BART, which we have not used. And then for dissections, we used uncovered stents, self-expanding. The vascular closure strategy, as Dr. Dilip Kumar had said, was 1 proglide plus 1 angiosyl, or 2 proglides. We have now graduated to 1 proglide. This can happen if you use 2 proglides. You can see at the end of the procedure there is a narrowing of the femoral artery. This has also happened to us. And so you just put a balloon and do a gentle dilatation, and usually it goes away. So in conclusion, large bore access comes with its attendant complications. Detailed assessment of the vasculature is important in planning the procedure and to prepare for possible complications. Vascular complications will happen, and it is better to be prepared for it. And interventional skills and familiarity with hardwire is very important. These are not like coronary stents. They go over different types of wires, and prevention is better than cure. So thank you very much for your attention, and thank you.
Thank you, Dr. Chopra. Actually, what your experience of the complication, particular presence of the severe aortic calcification valve and narrow annulus and severe aortic valve calcification?
Yeah,
Your experience, I mean to say, how is the problem?
We have implanted valves. Most of our valves are in the lower size range because our patients are smaller. We have implanted a lot of bicuspid valves, so 21.5, 23, those types of valves we have implanted. If there is a lot of calcification, we do pre-dilatation, and then we implant our valves, unlike going in directly. Usually, if you size your valve well, our average gradients for the narrowest valves, the peak gradients are not more than 20, and the mean gradients are around 12 to 15. Our pacemaker rates are around 6%. And paravalvular leaks we haven't had. Significant paravalvular leaks we hadn't had.
What about the profunda in your case? Like you put a cover stent.
It was above the profunda. It was above the profunda.
Yeah, that's what I saw. The profunda patient did not have any ischemia when.
The patient did not. So there are concerns about if you put this and the profunda gets blocked, what happens? The patient didn't have any ischemia. And the other thing is, can the stent get deformed? Because these patients squat and this. So it has been around 1.5 years, and the lady still comes to the clinic and she has all sorts of other complaints, but nothing to do with the limb or with the heart. She has bowel complaints, she has this, that, but vascular complaints she didn't have.
Okay, thank you. Any question from the other moderator? Kuntal? So, okay, thank you very much indeed.
Thank you.
I think next speaker, I think Sundar, you are already come. Thank you. Congratulations for coming Calcutta. So, Kollan will speak on the life in box cases in Impala.
First of all, I'd like to, as the slides come up, I'd like to thank the organizers for having invited me here. Really appreciate it. Also, I had a talk prepared more on large 4 axis, but I did throw in a case. So I'm going to kind of skim over the access part because I think you guys have heard the same thing from a lot of people. So at a very high level, ensure that you're comfortable with everything. Okay, micropuncture, ultrasound. We just talked about fluoroscopy, ensuring going up and over all this stuff. Please do have a vascular ultrasound in your cath lab if you don't have it, because this is very crucial. Many times you will not be able to tell when the vessel actually dives in above the CFA. It's important to know that, so it's important for you to check transverse and longitudinal before you do it. This stuff, I'm just going to keep going because we already know. Just be very, very careful about how you get it. Learn micropuncture. We've talked about all this. Bleeding is bad. I think you've heard enough about per-close, pre-close. This is the key thing. Use fluoro, ultrasound, and angio. Okay. Also, sometimes, if you're not used to large 4 axis, ensure that you use stiff wires. It's one of the rookie mistakes. You take a normal 035 wire and then you take a large sheath. It can kink, especially in the obese. Just make sure you have stiff wires, whatever your choice is. Bleeding is bad. We know all the stuff, so I'm just going to cross this part. We have also talked about the two, pre-closing with 2 per-closes, or using these days I do pre-close with 1, and I use 1 angioseal. Actually works like a charm in most times. Also learn how to do a dry field closure. It's not rocket science. You just go up and over, keep a balloon there. Really just minimizes all the, the blood that comes out when you pull out these large sheets. So I'll kind of skip that part too in the interest of time. So one of the advantages in having a dry field closure is that if the per-close doesn't take, the patient is not going to exsanguinate. That's a good thing. So yeah, covered stents again was just covered. So I'm just going to skip all this stuff and take you to the to the case. Oh, and I don't know if anyone has actually covered all this stuff. you should know what to do if you have an occlusive sheaths. I'm assuming it has been covered, so, and given that it's not my topic, I'm just going to tell you, if you're going to leave the impella, take out the 14 front sheath that it comes with and put in the repositioning sheath, learn how to do that. Various techniques to bypass. I mean, if you're going to leave it on for a long time, number one, check out the distal flow up front. Number two, figure out some way so that blood will continue to flow to that limb. So I'm going to skip all this part again, given time. Okay, good. So now we go to the case. I hope I didn't, okay, I have 7 minutes. That's good enough. So we had this was a case that I actually wanted to record for the live inbox for India Live. And I did kick out the camera folks after a while because I had a complication. So it's kind of a fun case for you guys to watch. So 64-year-old guy, really, really bad LV, turned on for surgery. His uncle is a cardiac surgeon that's retired in the US. The patient adamantly said absolutely no to surgery. And he's got 2 CTOs, one of the LAD and one of the RCA. This is just basic stuff. I already talked about all this. His EF is really down the drain, less than 20%. He's got viability both in the LAD territory and in the RCA territory. In a way, I was kind of hoping it would be simple because I honestly couldn't see the LAD very well. I was like, man, am I going to go after this? Seemed like a really poor target. So yeah, I thought like if it's just the RCA, life is going to be a lot simpler, but turned out not to be. Here's the angiogram. As you can see, the LAD does fill. There's one diagonal there that's fairly sizable. There's an RCA. Circ is not terrible. RCA CTO was not too hard. And as you can see, I thought, okay, bridging collateral shouldn't be too challenging. The key here was the guy was pretty obese, and he also had subclavian stenosis. I kind of did that just to see in case the uncle actually decides to convince him, etc. These are the setup shots. These are, I just put in 2, I think 5 French catheters to take pictures, and you can kind of see it. The RCA is actually fairly large, and the LAD was really, really small. So we started with good intent. I thought, okay, I'm just going to do this live, and I don't know if this will play. We are just, okay, I don't need the sound, but like, yeah. Just access. So on the right. It's a 745 on the right. I have left radial access, and I put in the impella through the left. Always put the larger device through the straighter, larger vessel. And used a short sheath, wasn't too hard. Given that this is about access, I'll let this play. I mean, this is nothing hard. I mean, the impella went in. Just watch it when it goes up. That's all I would say. Put a pigtail in, exchange for the overnight, and then take this over the overnight.
So CP device?
Yeah.
Impella CP?
Yeah, it was an impella CP, correct. I generally don't use a lot of 2.5s, and anyway it's going away. If you need it, you really need at least 4 liters. I think they're paying enough money, might as well get money's worth. And this is like usually the same person has to control the wire on this. Don't have your assistant hold it because then it'll keep going all around. So this was in impella position. I always okay, hold on, how do I play this? Okay, good. So I usually confirm impella position. I put a pigtail through the other one, confirm that I'm good. I also confirm on echo, which I'm not showing here, but I usually do that. Make sure there's no suction, etc., etc. So the rest of this case is actually kind of interesting. So I thought, okay, LAD, not too long. Let me start off with antegrade wire escalation. Not a great target, but I thought maybe I can wire it. Didn't really see any good interventional collaterals. Just kind of a 20 plus. Initially I thought, okay, starting to wire, I think I can wire it, but I couldn't. So, kept going. So I did knuckle to resolve the ambiguity there, because I had a second wire. I still couldn't do it. I very briefly tried parallel wire, and then I moved on. And okay, one key message: please don't assume that every knuckle perfs. Doesn't happen. It's usually much safer. My suspicion is that the initial wire probably went out of the vessel architecture, and then my knuckle followed suit. But that's what I'm dealing with. That's a big perf. I don't have wire across. I don't see the distal LAD. And yeah, I'm not very happy. So that's just for effect. I'll just show you. That was a big perf. The good part was that I had an impeller up front. I wasn't frantically trying to put this in. I knew that potentially there could be trouble. EF is low. I'm going after 2 CTOs. Let me try to get everything done. You know, so that was part of the rationale for doing impeller up front. There was scoring. There's scores out there that can give you some guidance, but again, I think it has to be individualized because none of these scores are validated. So at this point, do you guys want to weigh in, or do you want me to just tell you what I did?
Yeah, what you did.
My expert.
What you did, I think we can go ahead with that.
Okay, I can just go ahead in the interest of time. So yeah, I mean, like, you know, these were the options. I did call the surgeon just because, you know, checks and balances, just make sure you do all the routine stuff. But really, wire not across is a big perf. That's not a good position. And my friend who had actually invited for the live case, he's like, dude, I have a structural case. And, you know, he had a structural conference in Japan, Tokyo Valves, I think, so he had to leave. So that's it. So what we did was we did put we did a pericardiocentesis. And the plan was to try and still salvage the LAD because, you know, in fact, I just talked to the surgeon too. I stepped out and he was like, dude, I don't see anything. So I can take him to the OR, but I'm not sure I can graft it. I'll probably put in a vein graft, and I'm just not sure how it's going to be. And with a very high peri-procedural risk. So what I did was essentially knuckled my way in. I went back further. As you saw, like what we did was try to catch a different plane, and then I basically knuckled down into the LAD. So once again, that was just the Jackie Chan is just for star. So yeah, but the key is, oh there, finally it goes in. So you are in the LAD. So the middle and the distal part I just treated with drug-coated balloons.
What was your wire, please? Interrupting. What was your wire?
Can I just finish and then go over because I'm on the clock? It was a Mongo. It was an MG14, but I'll answer all the questions in a bit. So then I ballooned the LAD, and so the first problem was kind of fixed. Okay. So at this point, you see there's a little bit of perf. I haven't still. You can see a little bit of X-ray, but I haven't still stented it. So then I put in a DES. So that perf was taken care of. Now, there is another challenge in this case, which is the RCA goes off through this very, very diseased retroflexed septal. See, the clock is ticking. Okay, so I'll be quick. This part is, I mean, it's not super hard. So what happened was I did, this was a reverse cart. So knuckle, back, antegrade knuckle. So you guys know the steps of reverse cart, but in essential, there's a guide extension catheter down there. There's a balloon antegrade ballooned up over a knuckle, retrograde microcatheter with a wire. The retrograde wire gets back into the guide extension catheter that is antegrade. Okay. So once this is done, I thought, okay, now stent, let's be done, right? But then this case was like, whatever could go wrong kind of did. You see that there's no distal flow. This was a very difficult reverse cart, incidentally. I had to use large balloons, and that is, again, since we don't have time, but that's, you know the answer to that, right? That's a hematoma. So there are solutions for that. So what I did essentially was use a cutting balloon, defenestrate it. I already have secured the PDA, so stented into the PDA, and basically here, you know, knuckled into the PL because all I needed was to resolve the hematoma. You will see that go, boom, and then in. Okay? So the rest was just, and I treated that at the DCB. I'll just show you the final pictures so that, that's the RCA. RCA was done, didn't lose any branches, that was good. And then I went back in and stented across that septal in the proximal LAD. I think that was the final flow. Okay, good, there. I did lose the diagonal, but end of the day, he was alive, and I was like, okay, I got out of Dodge. So 2 days later, I did leave the impeller in because, you know, we've done a lot of trauma to the vessels. It's been a complex procedure, way more complex than I intended it to. So 2 days later, I went back in. I don't know why this isn't playing, but both vessels are patent. I don't know why the RCA is not playing. Okay, good. Anyways, it was good. So at that point, pulled out the impeller. You guys can, I'm not sure why the videos are not playing now, but so here, this is an important thing. I really wish this video would, guys, can someone play that thing? Please? Yeah, see if you can, that's not the left one doesn't matter, that's just the impeller coming out, the one on the right. The key is always go up and over, ensure on DSA after you've closed everything. So again, this was done with this is already pre-closed. So my one pre-close and an angioseal, and then do a check shot, ensure there's no complications, no perfs, that your SFA, your profunda are all fine. So I think it is stuck. It's not moving. Guys, I have 2 more slides. Can we just go to the next ones? Okay, it's fine. Take me to my conclusion slide. Is it hanging up or something? I can't move it here. There we go. Okay, just if you can't play it, go to the last one. It doesn't matter. So the key is, I mean, you'll just see a nice external iliac, CFA, profunda, and this. Go to the next slide, please. Okay, so the key points here are as follows, right? So yes, there was a complication, but the good part, I think the one good thing that I done was to plan an upfront protected PCI strategy. Okay, so this was super important, and also once you put in the impeller, wait for about 10-15 minutes, wait for it to offload, and then start your PCI. The other point was, yes, you know, it's all been a disaster. You don't want to deal with phone calls from your CCU, but you know, you put in the device, let the patient, let it do its work. It's good for you to wait for a day or two, assess the patient daily, and then take a call on when when it should come back. Perforations, again, can and will happen if you do complex PCI. I think it's important for you to have an algorithm, and it's also important for you to trust your skill sets and should be able to bail yourself out of it when it happens. And the key thing is, this was a case where multiple things did go wrong, right? You got to take one problem at a time, figure out what's going on, and go forward. Also, don't hesitate to ask for help. I did call the surgeon, not because I felt he could do something, but number one, it was like politically correct, you want to be sure. Number two, it's always good to get more ideas at that time in case you're missing something. And this patient actually got, he was in the hospital for 5 days, so 3 days after the impeller came out. He's actually doing really well. He's actually undergoing cardiac rehab. EF has improved to about 35% at this point. Thank you.
Okay, thank you. Very exciting case. Impeller, experience in cases of the acute pulmonary edema due to ischemic background in multiple vessel disease, including the particularly CTO of the right coronary artery, and complication also developed during procedure, rightly managed. I congratulate you for these cases, but wondering that the ejection fraction 19 has improved to 35% after how many weeks later?
So I did this procedure the day before Tokyo Valves, I think February 13th or something. And when I saw him in clinic was right after India Live, so in 2-3 weeks.
Again, you removed the impeller after 24 hours or
48 hours.
48 hours.
48 hours.
So long stay.
2 days.
That is the problem.
So I left it in because I made a decision not to take it out that day, obviously. So we took out the impeller sheet, put in the repositioning sheet, ensure that happens. One key point about the repositioning sheet is that many times it will ooze around it. There are two things, because yes, it's a tapered, it goes up to 9 and the back end is supposed to be 13, but there's always that little bit of extra ooze that happens, and that can be an annoying, really troublesome ooze. So the two things I would say is like, keep it at an angle. So sometimes just rolling up some gauze and keeping it under the sheath helps. The other point is like, if you're pre-closed it, you're not going to cinch it, but the wire, the non-white wire, if you pull it a little bit and the knot pushes down, that'll be helpful too. So those are two things that you can do to like troubleshoot that.
Another important question, the impeller port trial is going on, is coming on the way. What is the particular aim and objective of the impeller port study?
So
all of the high risks.
Here's the thing. With a lot of these devices, right? I mean, we still use balloon pumps at times, although there have been multiple negative trials. I think trials are great. I think, studies are good. I'm not taking away anything from it, but like certain procedures, I mean, in this case, I know he wouldn't have made it alive without it. So I think, and in India, I think the threshold often is much higher because you do need to be super, super careful. It's an expensive device. So I think it's critical for us to assess each one of these patients. If in doubt, talk to a colleague and say, hey, here's what I'm planning. Here's the kind of protection that I think I need. What are your thoughts? Do you think I can get by? Just like your TAVRs, these PCIs, I mean, I wouldn't wait for trial results or just say, well, trial didn't show benefits, so I'm not going to do it, etc. I would say individualize it to the patient, have a discussion up front with the patient family and with a trusted colleague before you embark on these procedures, and go with a plan.
Yeah, I think the initial coverage or
it was
from the
wonderful,
personal?
wonderful case. I have two questions. The distal RCA, which was did you image that? Did you see that it was hematoma, or was it a spasm was contributing, or what exactly you did?
It was hematoma, and the reason I know it was because there was dye stain there. Like after I stented everything, I injected, and during the procedure, I kind of glossed over all that really fast, but I had to use a 4.0 NC balloon for doing the guide extension reverse cart. One of the things is when you have a small segment of CTO, it's actually harder to do any kind of reverse cart because you're not doing extended reverse cart. You want to try and do it within that segment, right? When you have a longer CTO, you have more room. So here, I did struggle to make the connection, and my antegrade wire formed a fairly big knuckle. So I knew I was going to have to deal with hematoma down the line. I also did image it, but not before I ballooned it first, because I kind of pretty much knew that. You had another question, or was it just one?
The LAD you went with the knuckle with the Mongo wire, and which wire you needed to penetrate into the main?
So I used. Okay, my initial knuckle was also a Mongo. The problem in that LAD was my target was very small. There are branches in the LAD. I mean, there's probably a small diagonal that I couldn't see. And there are septals. LAD, okay, it's straight, but it always comes with branches, right? So my initial knuckle was a Mongo, but that went outside. So once I had the perf, I took a new Mongo. I kind of retraced my path. I'd already established control, right? I have an impeller, I've done pericardiocentesis, and we were we were giving the blood back and all this stuff. So I was not in a rush. So I said, okay, let me take time. So I got my microcatheter back, picked up another plane, and traversed it beyond. And then I knew I was in the LAD. So oftentimes what happens is that initially you go through, and then you exit somewhere. Now what you have done is you have gone subintimal up front, and then you re-entered further down.
Same wire came in.
Yeah, it's the same wire.
And that's still the perforation also.
Correct. You're basically using your dissection flap. So it's a subintimal strategy that you can use for the perf. Because traditionally we think coils, fat, thrombin, covered stent, blah, blah, blah. But when this is one other option. I thought that was kind of like a good teaching thing too, because we don't typically think of it as an option.
Thank you. I think we can move on with the next presentation.
Okay.
Thank you very much indeed.
We can have it offline.
Yes.
I'll just step down.
May I invite our next speaker, Dr. Bikash Majumdar, who is a senior interventional cardiologist at Apollo Hospital, Kolkata. So please, his presentation is on Manta device, which is a new device. It is just yet to launch, and it's a closer device. So Dr. Bikash Majumdar, it is over to you.
Good afternoon, chairpersons. Good afternoon, colleagues. And thanks, Dilip, for inviting and organizing this session. I'm enjoying it since this morning. And thank you, Dilip, again for organizing this session. Now, before we start for TAVI, it's very important that we come up with a plan of vascular bailout, even before we start, if we need to. So we have to have a bailout strategy if something goes wrong. So the multi-close algorithm for vascular access closure, that is important even before we start. So what we do, we look at the CT very carefully, as Dr. Devdatta Bhattacharya already mentioned, and we try to identify the vessel size. We see where the calcium is, and try to identify where the bifurcation is, and then it is very important we do an ultrasound guided micropuncture, and when we do that ultrasound guided micropuncture, we try to puncture the artery above the bifurcation and below the inferior epigastric artery. And in the ultrasound, we identify the bifurcation, and then we take a longitudinal view and go above and see where the artery is actually dipping in the pelvis. So you don't go where the artery is dipping in the pelvis. We have to puncture before that, above the bifurcation, and that lies mostly on the top of the femoral head. So once we do the micropuncture and put a 4 French sheath, we took an angiogram, a little bit RAO in the groin, and try to identify the exact position of where we punctured, because that gives us an idea when we are closing, and if something goes wrong, where we have to put a cover stent, or whether we have to put an occlusion balloon later on or not. Then we put a Parclose device or ProGlide device, and either we are putting a single Parclose or a double ProGlide, depending upon what practice you are doing, and sometimes we put one ProGlide 10 o'clock, another ProGlide on the 2 o'clock position, and sometimes we can put one ProGlide which may be at the 12 o'clock position, and then we perform the TAVI procedure. And once we take out that ProGlide, the large bore access, after performing that TAVI procedure, we keep that 035 stiff wear, and then we try to advance the ProGlide suture. So we actually put the knot in, and then we put a small bore sheath, either a 6 French sheath or again a 4 French sheath, and take an angiogram again and see what's happening after the closure. If there is any leak, there may be no leak, you can just tighten 2 ProGlides and your procedure is finished on a very small 4 French sheath at the end. If there is a minor leak, you can put another angioseal, either a 6 French, but when how do you decide whether it is going to 6 French is going to work or an 8 French we need? You put the angioseal and see whether it is leaking by the side of the angioseal or not. And if it is the pulsatile leaking from 6 French, then you can go up to the 8 French and see whether the leak is stopped. And if leaking is more, then of course we need a bigger device. That's where the role of the Manta comes. So Manta is a device, in spite of putting, 6 French and 8 French is not closing, you have given 2 Parclose ProGlide device, but you don't put a third ProGlide because that can actually cause stenosis in the artery. So if there is a severe leaking when you take an angiogram, then this device comes. This is called Manta because it's a fish, it's a Spanish name, it's like a flat fish, Manta ray. There are 2 sizes, one is 14 French and another is 18 French. This is a biomechanical large bore vascular closing device. The 14 French device is used when the access size is between 10 to 14 French, and if access size is more than 14 French, 15 to 20, then we actually use the 18 French device. And this device has got certain components. As you see, there is a depth locator. So you have to measure how deep the puncture site is. So there is a depth locator, that is number 2. There is a introducer, and you can see number 3, that's like a sheath, and then the Manta device is number 1, and there is a dilator, it's a number 4. So Manta closure is composed of delivery handle containing absorbable collagen pad, a stainless steel locking component, absorbable polymer anchor that are connected by a non-absorbable suture, and hemostasis is achieved primarily by the mechanical means of the anchor, arteriotomy and collagen sandwich, which is supplemented by the coagulation-induced properties of the collagen. So there is a plate and there is a collagen on the top of it. They kind of sandwich with each other, and that actually causes the hemostasis. Now, how do you deploy this particular device? So first we have to insert the depth locator, and then we see when the blood comes out, and then again pull this up and see how deep is your arteriotomy site. So for example, you can, with the depth locator, you measure that from the skin point to your puncture site is actually 3 centimeter. So when you are introducing the manta sheath, you have to go a centimeter more. The second, what we do, after the depth locator, you exchange that with a manta device sheath, and you put the manta device sheath all around, all the way down, and then on the top of the manta device sheath, you put that manta device in 3. You can see that this manta device is there of the sheath, and that clicks. When it clicks, number 4 position, you can see you withdraw the manta device. And how far should we withdraw? The depth locator, say for example, if it is a 3 centimeter, you withdraw up to 4 centimeter. So then you are sure that your anchor is actually inside the vessel, and then in the number 5th step, you actually release the anchor by reflecting the plate and rotate the handle lever, and that actually release the anchor. And number 6, what we do, then we pull at the 45-degree angle to withdraw the entire system, and you see a marker here which comes out green and yellow. And by the time you know that it's actually the plate is actually against the vessel, and then you advance this portion. This is the foot plate pushing system, and keeping that backward force, just like an angiosyle, and the last step, and then that yellow green becomes purely green, and there is a click, and then actually you cut it down. So that's the way it is done. So particularly if with your proglide system there is still leaking, then this is a device which can actually bail out the situation when there is a leak, and that avoids calling a surgeon or putting a cover stent, something like that. Now there may be some problem with the manta system as well. So if your device is against the inguinal ligament, there may be some leak, and that can again fail the device. Or if the foot plate is not properly anchored, it's tilted, that can also sometimes cause failure of this device. So among in the multi-close study, so among the 630 patients who underwent that transfemoral TAVI, they achieved 98% of them achieved complete hemostasis. The vascular closure device failure occurred in 2% of the patient, and treated either with a balloon inflation, that is 1 patient, and covered stent 12 patient, and surgical repair required by only in 1 patient. And overall, this vascular closure approach resulted in a minor and major vascular complication of 2.2% and 0.6% respectively, and at 30 days only, new minor vascular complication was only 0.2%. And in hospital and 30-day all-cause mortality were 0.2 and 1% respectively. Now, recently, thank you very much. So the last year we used some of the manta devices during my visit in UK. It's still not available in India. So I thank you all for listening to this to me, and I thank my colleagues who helped me to develop the skills of TAVI over the last 1 year. Professor Dave Smith and Professor Alex Chase.
Any question, 1 or 2 questions?
I think CT assessment is very important. With CT we can know the exactly depth, and then we can plan our manta. The same depth we have to, approximately have to go in and then, deliver the device.
The thing is, the depth locator is important. So first CT you can plan that where you are going to exactly puncture, because you shouldn't be puncturing on a calcium, and if that's important. And second thing, the depth locator, that is they are available with the device. So once you go in and then come back, the blood comes, and then just like an angiosyle, and then you come back, and there is a marker there. So you can see 3 centimeter or 4 centimeter up to the skin level. So you know that the 4 centimeter below the skin is your puncture site. And then when you are putting the manta sheath, you go in and then put the manta device. Once you deploy the plate, and when you are coming back, you come back up to the 4 centimeter I mean, just 1 centimeter more than your depth, whatever the depth you have located. That's important. And then you deploy the collagen plug, and then rest is like just like an angiosil.
Thank you, sir. I think thanks to chairpersons and moderators, and we break for lunch. And it was a wonderful 3 sessions. We had a lot of exciting discussions, some thought-provoking discussions. Thank you, sir. So the lunch is now open for. We will assemble in next 25 minutes. Yeah.
Hello. Good evening, everybody. Welcome to the post-lunch session. Dr. Hajra needs no introduction in this forum. He will present a case. There is a lidless pacemaker and possible complications in that case and how to deal with that thing. Over to sir.
Thank you. First disclaimer, so far I do not have any serious complications from any of the micro pacemaker I have done here in Calcutta or as a proctor over last 3 to 4 years. But that doesn't mean that the next patient will not have complications. As you have understood that the large bore device, whether it is venous, whether it is arterial, whether you go for femoral artery, femoral vein, subclavian vein on ultrasound, carotid impella, axillary impella, anywhere it can cause serious complications if you're not handling those bigger structure where you are pushing a bigger boat to catch a bigger fish. And not only during entry, exit is also very important. So entering may be easy sometimes, but exiting the system, venous system is much more easier than the arterial system. So how do you enter into the right-sided system if you do not have IVC filter or interrupted IVC? Then the entry into the RA or RB is very easy. If you have a dialysis line, like you have some cases where you have both the femoral vein are occluded, and there the entry into the RA and RB will be very difficult, then you go jugular. Always right internal jugular vein is the best entry for your large bore device, whether it is your micra, whether it is your VSD closer, VSR closer. Large bore device can be entered into the can be introduced into the RV from the jugular. And nobody has done anything from the subclavian vein, but I have done in a 9-year-old child who had 6 infected pacemaker. Ultimately, we had to open the abdomen, the common iliac vein, and through that common iliac vein, the micra could be introduced. Perhaps this is one of the first cases in the world. Now, if you look at this tricuspid valve, if you have a device, if you have a prosthetic device sitting there or a clip sitting there, then it is much more difficult to enter into the right ventricle. And if you have a mechanical valve, then your flexion, deflections may not work. And if you have a tissue valve, you can always get inside the RV. So this is one of my complications of having a micra in the initial learning phase. We always advocate that if you are puncturing the vein anywhere, whether it is a fistula angioplasty or a varicose vein or subclavian vein during pacemaker or a femoral vein, you hydrate them. If you are doing any thrombotic lesions in the inferior vena cava or external iliac vein post-COVID, we have learned if you give a lot of fluids and if you do the Valsalva maneuver on ultrasound, the same femoral vein looks bigger. Now many centers, they are doing this micra entry on ultrasound guidance. Now this man was a post-CABG man, very elderly, thin, frail person, and when this 27 French micra was introduced, later on we realized that he developed hematoma, and we still do not know how it happened. So it may happen like if you have scratched the anterior wall or lateral wall of your femoral artery, and you have entered, it could be anterior femoral artery and posterior femoral vein, and you will be seeing venous blood. Then you introduce these dilators. Luckily, it was not like a stitch of femoral artery to the femoral vein. Maybe during the poking, it was a scratch and small dilatations, small dilator actually avulsed some portion of the femoral artery. And when you realize that, then it has to be covered. I mean, you cannot have this. You can have a covered stent, but this man developed some kind of fistula. So then we tried to occlude with a balloon, and it was still leaking. Then we had to ask my friend, a surgeon, to repair, and he required almost 6 units of blood. So the learning from this case is that when you're entering into the femoral vein, whether it is TMVR device or a micro device, once you have punctured with a 6 French, 7 French, 8 French, keep the wire, go in with the sheath, come out, and again go in. So once you have gone in and removed the sheath, which is never practiced in temporary pacing puncture, temporary pacing, job is done. Many times even it goes anterior to posterior, through and through, like a stage. Doesn't happen because it is 5 French, 6 French. So dictum is, once you go, then you come out, if you see any spot, abandon that puncture, go for a fresh puncture. So that is the only trick. Otherwise, it is very difficult to understand whether you have punctured or gone through any small arteries, which may be insignificant because it is already tamponade, but maybe later on it is significant because micro is always done with full dose of heparin. So ultrasonic guidance, as we are discussing in the morning, that always makes you happy that you have entered a structure which is collapsible. And if you have difficulty in the iliac vein, you can use a body wear. And sometimes you have to dilate the iliac vein with the body balloons. The same temporary pacemaker can be used as a piggyback to enter into the IVC, or you can shift to the left side. So another complications in micra, if you are doing, if you are facing any resistance, micra is always a fall from above. If you have, like a Hinduja hospital, yesterday I was doing a case in a 89 years female. She was kyphoscoliotic, and all the time we tried to enter the RV, it was entering into the coronary sinus. So coronary sinus, if you have this kind of picture and your things are getting kinked, come out. And if you have a temporary pacemaker as a lighthouse, as a marker, that makes your life happier. Sometimes when you're doing a concomitant procedures, like you're doing a leg closure on eyes, this is the eyes and micra, it's very tiny. And this can be confirmed on CT scan that most of the time it is the apex where the micra goes. And the first cut is the best cut in anything, whether it is angioplasty, whether it is a micra. The first position, if the threshold is good, just leave it there. Now, goosenecking can cause perforations, and there should be sufficient forward pressure, but it shouldn't be so tense and so hard that it perforates the thin RV wall. The TARC test, I have never had any embolizations. The only confirmation, not only your feel, the threshold of the pacemaker will never change. It will remain exactly same. It is 0.5. After and before the TARC test, it will always be 0.5. And one of the best innovations after 65,000 models of micra is the hooks. And when you have this kind of scenario, micra is so tiny, it can be put just next to it. Even if the first one get dislodged, it is basically embedded with the endothelium. It is not embolized because now there is a lot of mass. It is not a free floating device. So chance of embolism, but if it embolizes and it can be caught. Okay, so ladies and gentlemen, to finish that, micra is very elegant device and it is very simple. It works in most of the situations. We have now double chamber micro pacemaker, where you have one atrial from Abbott and one in the ventricle. If you have an existing lead in the atria, you must remove that lead from the atria. And micro pacemaker is the only pacemaker which can be switched off and is a very large device. The entry should be careful. And this is the only pacemaker which has worked, even which may work even in the space. And it works against the gravity. And with that, I would like to thank you for your kind attention. Thank you very much.
Sir, thank you for your excellent presentation. I would like to know that in case of microvascular or venous access, would you like to go for any device closure or the vascular access closure with any particular device, or just a fisherman's knot, conventional?
Okay, so some people, they go for ProGlide, one ProGlide or two ProGlides, because it's 27 size. The manual compression is the best one. Reversing heparin, manual compressions, figure of 8, the fisherman knot. The ProGlide actually uses a fisherman knot. So if you know the fisherman knot, usually sufficient. And then ProGlide is costly one. Your God-gifted hand is the cheapest one. Now, I mean, 99% is either figure 8, fisherman, or manual compression, because it is venous structure.
And sir, any specific tips from your end during the recapturing if the position is suboptimal?
Okay, so you can recapture as many times as you want until and unless your microsheath is kinked. Now, if you are trying to push from below, it is always kinked. It is, if you are not happy with the threshold, then the cup and this thing, that the sheath should align. If things are not aligned, then ukhad ke leke aa jao. Ukhad ke leke aa jao means just pull it out and keep it in the IVC. Once it comes in the IVC, it becomes straight line. Then you reload. And most of the time, it can be recaptured by different manipulation, flexion, deflection, anterior movement, posterior movement, rotation, clockwise, anti-clockwise. But if you have moved out from the RV system, then you have to go back with the dilator again. You have to put that black marker or the ring again in the mid-right atrium. Then you reload, then you fall from above. It's just like a dolphin, you go above and come back.
So one or two points. Like, I think ultrasound guided puncture is the way to go in these kind of very large, this is larger than many endovascular procedures. The sheath size in micra is very high, very large, 26 French. And the understanding is also changing. Previously when the micra came, it was like you have to go near apex, and then you find septum and deploy it. Now we are saying at mid septum, and that is where the concepts also hovering around in conduction system pacing. I was attending a meeting with Dr. Vijayaraman, and he showed some cases where normal basal plane where we go for conduction system pacing. There were cases of small septal arteries getting injured, and large septal hematomas were seen. So mid septum is the way to go in conduction system pacing as per the normal understanding at this moment. So as in micra. So what's your idea? Like which cases from the beginning have you changed your position of site of micra positioning?
No, it's the first cut is the best cut, whether it's in lab or in micra. First cut is the deepest cut in lab. First cut is the best cut in micra. So Michael learns to lock. Michael learns to rock. Anyway, so if your first position in the apex and threshold is good, take it. If your primary aim is to go to only mid septum or lower septum, you may face some complication, it may cause rupture. So micra knows where it has to go, because you have a definite trajectory of the micra you have created. So if you face any resistance, just lift your hand and the micra flips back and move back, then go again. If the second movement goes to the same place again, take it. If the second or third movement goes to a septum, you take it. The first position goes to septum, take it. It's just like that is the best. Now you never know the threshold you have got in the apex will be better than the threshold we will be getting in the septum. And as long as the procedure time goes, increases, and the number of capture, recapture, any device, any mechanism can fail. Right, thank you.
Thank you, sir. Next case will be presented by Dr. Anil Singhi, who will show some cases of large bore access in pediatric population.
Dr. Singhi is a pediatric cardiologist of repute in our Medica hospital, and he is also involved with the structural cardiac interventions. When we do left atrial appendage closure, he guides us and he stays with us. And in many structures like PV leak closures and all, he has a huge experience. So he will be showing some cases.
Good afternoon. Thank you, Dr. Dilip, and it's an excellent meeting because this is out of the box, first of its kind. And as a pediatric and congenital heart disease taking care of the patients from day 0 to 75 years, it is our experience to encounter diverse range of scenarios. So, though it is pediatric population, I'll just highlight the problems what we face. So, I start with a complication. A 15-year-old girl, 38 kilo, was referred inpatient from another hospital for coarctation of aorta stenting. After analyzing whatever fixed data was provided and with assessment with our echocardiogram, we planned a Zephyr 34 mm stent with a 34 mm size on a 12 millimeter bib balloon. You can appreciate the coax was very tight and very close to subclavian. The arterial size by and large reaches the adult size by 15-16 years of age, and you can see common femoral arterial size is 7 millimeter plus minus. So it almost reaches the adult size. With that notion, we planned, but the bib balloon was not available at that time in spite of best of our efforts. So we were forced to take an Admiral Extreme balloon on a 12 French sheath. The femoral artery was gradually dilated, and in vitro we tried to see the stent balloon assembly inside, but it was not going. So we were forced to increase the sheath to 14. So after 12 we again slowly dilated to 14 and put a 14 French long sheath. We could take the assembly inside and deployed the stent in the desired level on a guidance from left radial axis. The stent sat very well and the subclavian flow was preserved. But while taking out the sheath, that was the disastrous vision. We saw the right common iliac torn. We immediately took access from left side. Patient was stabilized by the anesthesia team. The whole CTVS was informed. The patient was wheeled to the CTVS, and Dr. Asutosh's team CTVS, Dr. Sarkar, and everybody helped to immediately take, graft was put, and patient was discharged on day 7, smiling kid, and now 1 year follow-up, she is doing extremely well, doing all normal activity. And we published that case. So it's a sunshine after a nightmare. This case highlights the importance of the large bore access. Anything can go wrong and how we can deal on it. All major pediatric interventions are actually large bore access, and that is a forgotten caliber when we talk about the pediatric population. I will show some examples. So at day 2 newborn, we took for balloon atrial septostomy. Then it requires a 7 French access. That catheter balloon is 5.5. So it was successfully done, but the hindsight is 7 French access in the vein, it will cause lot of venous congestion and damage to the femoral venous root. The most common intervention we do, atrial septal defect. Frequently we close large defects, and this is a 3-year-old child with a large secondum AHD. It requires 11 French sheath. Now 11 French sheath for a 3-year-old child is a very large bore access. If you compare 16, 18 for an adult large, then 11 is very large for a child. So we need to be very cautious. So this is again an example, 2-year-old child with right coronary to right ventricle fistula, and here we had to use a 5 French arterial sheath because it was so tortuous. So 5 French arterial sheath in a 2-year-old, we closed, but always we had that worry that femoral access site should be fine. In pediatric, it's not a very common practice to use this Perglide or this angioseal whatever device in a very small child. Another example is an infant, a case posterior aorta to right atrial tunnel, and it was so tortuous that it was impossible to go through the venous route. So we were forced to take an arterial route, and another arterial access was required just to demonstrate where we are standing. We closed it with a Conar device, but one size 5, one side 4, 2 accesses, and we were very gentle, stepwise, multiple precautions were taken. The patient is now 1.5 year follow-up, no vascular compromise, doing extremely well. So this is a 12-year-old child, tetralogy pulmonary atresia, had conduit, severe conduit stenosis, which was stented with a intrastent, and that patient underwent pulmonary valve replacement. Then pulmonary valve require a 19 French delivery system. So 19 French in a 13-year-old patient is an extremely large access. This case is from my MMM days. The patient did very well, so very meticulously the case was planned by all angiographic demonstration of the vessels. So how to address vascular access in pediatric population? After that index case, we have started 100% documenting our vessels. Once we take the access, it is in our hand, putting injections of both artery and vein, and we are surprised to note so many instances of local anomalies, tortuosities, and regional narrowing. We are finding it out. If we have a worry, before coming out, we again give an injection to ensure we have not done any damage to the vessel. So regarding removal of the sheath, the Cook company says any long sheath removal, even from the venous side, should be removed with a dilator in situ. 10 centimeter should be the wire tip distal to the tip of the dilator, so that even if we are doing some harm, the wire will be inside and we will be a better operator and we can salvage the condition better. Finally, I wish to say, as there was a discussion of the tower, so alternative access is very important for us also. And this is a preterm child, 1.9 kilo, very sick, severe valvar aortic stenosis with a PDA, severe pulmonary hypertension, and the patient had necrotizing enterocolitis, was on ICU, very sick, surgeons refused to operate. That patient we planned, and the problem was 4 French artery. 1.89 kilo child, 4 French artery means it will be extremely difficult if we try otherwise. It was an extremely large bore access. So we thought of antegrade crossed through the PFO. You can appreciate through the PFO where aorta and down, and then we opened with an Ty-Sac balloon. The valve opened very well. Here in the arterial side, I kept only a cannula, a small 12-2 gauge long 15 or 14 centimeter cannula, which could give a nice injection to locate the duct. Duct was closed with a 5-6 ADO2 device. Both closed well. The baby before discharge, 8.5 years of follow-up, and the child is doing extremely well, and we published this case also. So in conclusion, proper planning, imaging to best possible way, and if possible the CT angiographic images will help. Gentle to vessel, predilate sequentially, alternate venous route if it is possible, and we should not be averse to surgical cut down in a given case to be. CTVS backup, blood arrangement, detailed counseling to the family, and that helped us to save the first child, because 4 units of blood was ready, surgeons were primed, OT was earlier informed that there may be a vascular complication, and I already told the sheath removal. Figure of 8 is an routine for all our venous closures, and it is the team which works. So it's a teamwork for catheter intervention. Thank you.
In fact, when I was called in the cath lab, when the artery was avulsed out, I suggested Dr. Anil not forget patient and now focus on relatives, managing relatives rather than the patient. But I think it was, he kept on, struggling, balloon tamponaded, and surgeons did a great job. It was so quick, and we could salvage the patient.
So, Dr. Singhi, what do you think was the cause of avulsion? Did you pull it out without the dilator?
Because the artery size was not that concerned, we were very gentle, it went very smoothly. Possibly while taking off, the protocol of putting this dilator and wire was not there.
Yes.
So while coming off, the tip of the sheath is little sharp. So possibly it has cut short, and in that process it took that thought and it collapsed. See, the patient could have died on table. We were lucky that the tearing was slow somewhere and the artery got completely...
So that's what I asked you this question. The message is very, very clear, especially when you use Python sheath, which are expandable sheaths in TAVR, and they have a large, along the sheath there's a fin which gets collapsed and expanded when you put in the dilator. So the moral is that you always pull out your big sheaths with the dilator in.
With wire in situ 10 centimeter distal. This is the learning. Now we are even better. Every case teaches us, and I'm thankful to Dr. Dilip and team Medica, everybody. Dr. Asutosh is here. I saw him. He was very kind us to help on that time.
You should have a very close surgical friend,
Yeah, I think message is very clear that dilated with the wire, at least the wire would have been a savior here. And was it versus Oxford versus New York sheath?
Yes, one of the problem we cannot help in that regard because the balloon and etc. everything was little bit of...
Clear-cut answer, Oxford or...
It was Oxford. So these are the problems we face on day-to-day practice.
You are honest enough to admit that it was honest. It was. I would have said New York.
So
even
that's why my suspicion during coming out that sheath tip tore because I did not have any problem when I was taking the sheath inside. It was a gradual dilatation. More important is surgical team ready salvaging. Thank you.
Thank you for this fascinating talk.
Ashok Parida and Dr. Devargo Duha couldn't make it because of the problem of brigade. So Rana Rai is the next presenter, then Dr. Pandey.
Yeah. So our next presenter is Rana Rathore Rai, sir.
So good afternoon, and this case is about the safety related with the safety wire in TAVI, and we all know that actually we put sometimes we put safety wire on that side just to take out any complications happens, but sometimes the safety wire becomes unsafe and we have to struggle with these complications. So this case is about a 76 years old diabetic lady, and she was having shortness of breath, and on echocardiography there was severe calcific aortic stenosis and the mean gradient was 67. And her ejection fraction was 62%, and there was minor ST changes. So definitely elderly lady, diabetic with severe aortic stenosis, symptomatic. And this is about the different parameters at the aortic annulus, LVOT, and sinotubular junctions. And all these are, I'm not going with the detail, but so roughly its area derived was around the 20. So this is another regarding this lateral and AP diameters of this aortic annulus. This is the coronary ostial height. It was favorable, so nothing concerned about that. So this is the peripheral vasculature, not much problems. You can see on the right side it is above 5, and on left side is also above 5, so that was not an issue. Now coming to the case, you see nicely after this injection,
we cross the wire, we go into the LV. And then this 23 millimeter accurate neo valve was deployed. This is a self-expanding valve, we all know. And so the valve was nicely deployed. There was nothing, any concern at that time. And after that, everything was taken out. But one proglide was already there on the right side. And after that, all the story starts. So after the deployment, after taking out, when we tried to, after this proglide was there, and when we tried to tie the knot on the right side, and when we tried to, on the left side, there was a safety wire was there, and we tried to take out that wire, and that wire was not coming out. So we tried a little what we can do, and initially we thought that definitely we applying the pressures we will able to take out the wire, but actually it was not possible. Then on this fluoro you can see there was a kinking in the wire, and probably I will, what may happen is that we'll discuss. But what happened at that time is that somehow that wire was kinked and the proglide knot was there on the wire. So at that time what we can do is that we tried some other maneuvers, like we tried to pass the catheter on the wire, and that maybe with that we will able to reduce and we'll able to create some space around the wire, and probably we will take out the wire, but actually that maneuver also failed. And there was also, we tried to balloon dilate it. This is the thing where we can see. There was also balloon dilatation was done, but actually that also did not help. So ultimately there was no options left to us, and ultimately we have to call our surgeon colleague, and we have to cut down, we have to expose, and we have to cut the knot, and then after that we will be able to take out the safety wire. So probably while sheath was removed, the safety wire looped through the hole, and simultaneously the suture was tightened. Probably that was the things that happened here. So after that wire was taken out, and we took the shot, and there was nothing, any other complications in that artery, and everything went well. So thank you. Learning of this case is that I think when you are tying the knot, proglide knot, better to take the safety wire above that and bring the fluoro, and then you try the knot. That I think that is the one way you can avoid this kind of complications.
The safety wire is a metal wire?
Yeah.
Metal wire?
V18 wire, V18 wire. Left groin.
Okay. So, snaring the thing, snaring the wire couldn't be possible from, right side or left side?
No, even after the much pressure, there was nothing you can.
They stuck.
Yeah.
This was a very, I should say, unfortunate thing to happen, because this is a day in and day out thing that you do.
Yeah.
I think, I'm not sure, we are all in our early days of using proglides also, this is accepted. The proglide has got this blue ribbon and this white ribbon.
Exactly.
And what we are supposed to do is, we are tighten it a little bit, the blue ribbon not to the full extent, not pressing it like that. And no way should we be touching the white one, because white one is the ribbon, is the string which ultimately locks it. So I've gone through this by mistake pulling the white one. So maybe when that was being put in the pre-close, maybe the white was pulled, or maybe it was tightened much more than it should be. Otherwise this thing shouldn't have happened.
No.
mechanism was the proglides were done as per the normal way which it should be done. So what happened, you see, where we were taking out the 14 French sheath, and then you are with the knot pusher, you are going through the track simultaneously, and you are taking out the 14 French sheath, and there is a additional wire which is there. Now there is a friction between this 14 French sheath and that additional metallic wire, and when it was coming out, little portion of wire, that metallic V18 wire got looped out, and simultaneously we were tightening the suture, and that happened, and that got made a knot. So there was just a loop there, you can see there was a loop, and below the loop there was a suture that was tightened. That's why we were unable to pass even a smaller balloon over this. We thought that if it is something there, we can just break it with a balloon. So the balloon needs to go there, and then you will deploy, inflate at 1820 atmosphere pressure. It was not going. Then we had to resort. So when you are tightening the knot, taking it out, when the safety wire, additional hardware is there, always look in the fluoro. Fluoro we don't see in the fluoro while coming out. Yeah. So the loop, it looped, we couldn't see, and we tightened the knot.
I think since we are discussing ultrasound guided salvage or making life easier, I think this always makes sense to close the artery even on ultrasound. So there is a paper published in THT 2024, 3 days back. The people who have done ultrasound guided part closure, like now sometimes if you put 2 proglides, if you tighten it very tight, it can cause stenosis. And on retrospect, on hindsight, I think if you had ultrasound, you can see the foot paddle, the movement of the foot paddle, everything you can watch on the ultrasound. Would have made you more alert to that you are catching something. So it makes sense to see when you are coming out and going in.
With angioseals, when there is a foot, and proglides also, but because now we are left with only sutures which needs to be tightened. So in fluoro also we can see, but definitely ultrasound can also give us idea that things have looped or what is going on there. Yeah. Thank you so much. I think it was wonderful.
Now we should move towards next speaker. Our next speaker is Arindam Pandey sir.
Good afternoon, everybody. Thank you very much for the opportunity. It was a fantastic conference, very, very important one, because we are gradually trying to incorporate structural heart disease intervention in our day-to-day life. Now I'll show a case of TAVR. TAVR implantation we are doing regularly. This was a case of TAVR. Something unusual was the annulus size. So it was a very small annulus. So as you know, first the trials of TAVR started with animal trial in 1989. It took around 13 more years for the first in-man implantation by Dr. Alan Cribrier. So 2022 we celebrated 20 years of TAVR, and very unfortunately this great man expired this year only. So with that note, I'd like to come to the case. It was a 71-year-old female, diabetic, hypertensive, yes, severe calcific aortic stenosis, severe shortness of breath, angina on exertion. So this was the 3-Mencio report. You can see not very unusual kind of report. Coronary heights were 9.5 on the left side, 11, quite okay nowadays. Now aortic annulus was 18.5. That was something very unusual, because in narrow annulus, TAVR is little challenging, because I communicated with different manufacturer. The balloon expandable valves are little tricky. In fact, I was refused by 2 balloon expandable valve manufacturers. So only option was to go with a self-expanding valve. So this was the calcification pattern. You can see calcium nodule at the annulus left cusp, which was extending into the LVOT, which is a bad sign, because many a time during balloon expandable valve deployment, there can be rupture of the LVOT if there is very significant calcification. In fact, this patient, I'll show in the fluoro image and cine image, there was very significant LVOT calcification. Otherwise, the valve was the horizontal, it was not a horizontal, semi-horizontal aorta. This was all acceptable, not much of issue. Access site was also good, mild to moderate calcification in the iliac and abdominal aorta. So we go ahead. This was a fluoroscopy guided, roadmap and fluoroscopy guided retrograde puncture. We can see. Now we have also started using ultrasound guided puncture for our TAVR cases. So this is how we did in that particular case, and you can see very ideal site of puncture. The bifurcation we can see clearly below the puncture site. So that was done, not much of issue. So aortic root angiogram initially done to confirm the annulus size, calcium level. We can see the semi-horizontal aorta. The valve was crossed in usual fashion, AL with a straight tip terumo. Up to this much, it was very easy, and we can see now we are taking the valve. So in this particular case, we took a self-expanding valve known as Hydra valve. I'll come to that valve later, because very good valve. As of now, we have already used 4 Hydra valve in our hospital. I have personal experience of 2. Last case done the week, 1 week before. I'll tell you some advantage of this valve. Now with the help of extra support, extra small safari wire, the self-expandable 22 millimeter Hydra TAVR valve was deployed using 18 French delivery catheter. We can see how it is delivered. So there are 2 markers in this self-expanding valve, which is unusual because none of the other self-expanding valve have any marker. So 2 marker, I'll show you where exactly the markers are located. This will help you for exact positioning of the valve. And the very good part about the valve is you can actually recapture and open it up to 4 times. That is recommended by the manufacturer. So that gives you edge of perfect deployment site. This is how we are doing it. After a few trials and error, we deployed the valve. And you can see there is no temporary catheter, temporary pacemaker catheter. So temporary pacing was done through the safari wire. And now we have started it. In last case of mine also, I did it, and in fact, balloon expandable valve, the need of temporary pacing, I think it is little more, and in self-expanding, you don't need to go very high ventricular rate. Up to 180 beats per minute is sufficient, and we are doing it through the safari wire, so that reduces the requirement of temporary pacemaker as well as all the complications related to temporary pacemaker. Now this is how we are doing it. We can see the valve being deployed, and this is the post-valve deployment angiogram. No post-dilatation was required. So coming back to the Hydra, it has a varying radial force valve. So the outflow part has low radial force. So that outflow provides conformability and shape of the aorta. The mid frame has very high loop strength, so that helps to maintain a circular position of the valve. That is very important, and the inflow has again a very high radial force, so it helps to provide fixation of the native aortic annulus. So this is the structure. We can see it is actually a supraannular valve. So high hoop strength in the mid frame ensures circular configuration of the bioprosthetic valve, and the cell design is so you can see very large open cell. You can access up to 16 French catheter through this valve, through these cells. So coronary access after TAVR is never a big issue with this particular valve. And this is the feature of the inflow. You can see there is extending ceiling skirt which made up the single bovine pericardium located between node 0 and node 2. So that reduces the paravalvular leak. So 2 marker I already mentioned. There are 2 marker. First marker at the node 1 for precise positioning of the valve, and second marker at the node 3. So it helps in precise implantation of the valve, targeted implantation zone, and the second marker indicates where the leaflets are going to open. So you have exact knowledge of where your valve is being positioned. So as of now it has 3 different size, 22, 26 and 30, and very nice valve. I think with that note I should stop here. TAVR is one of the best innovation in valvular heart disease intervention. It is expanding its utility in difficult terrains, such as, for example, bicuspid aortic valve, low coronary height, small annulus, as in my case. So our case emphasized the meticulous planning can result in successful outcome. Balloon expandable valves have definite advantage in small annulus situation, also in post-bypass surgery situation. Thank you very much.
I think this is a situation like small annulus, where surgery results are not that good. So the best option is a self-expanding tower in these situations. Dr. Sandeep is there, he can give his comments about putting a valve here. We have got results with Notion trial where a self-expanding evolute valve has got better EOA at 5 years, and the hemodynamic performance is also better with tower valves. So it was very rightly done, a self-expanding valve in this situation, and Hydra is a very good valve, very negotiable, and very tortuous, tortuous anatomy, it can just negotiate well and go. Yeah. Dr. Sandeep, any comments on 18 mm annulus?
It's a good case, only a lifetime of TAVR management. If you have a need for a second valve in his lifetime, he's 65 or 71?
71.
71, 81, okay. So if he's Chinese, he may live up to 91. So what will be your strategy next time?
So I'll go with a balloon expandable valve next time. Next time it's easy because chances of aortic root rupture, LVOT rupture, everything comes down, and you have a very definite target where you are going to deploy your valve. So next time after 10 years I'll put a balloon expandable valve, and I think that will be sufficient for the rest of our life.
Yes, basically this I think age of the patient was 71. Yes. 71, if
not a very high, a very high surgical risk. I must
definitely, but 70 years with a small aortic root is a problematic area, sir. Because with this small aortic root, we have option of mechanical valve, and clearly that is not a good option. So in that respect, I think TAVR is a better. Yes.
But what about root enlargement?
Yes, there is a possibility. Definitely there is a possibility, but 71 years, if surgical risk is low, then root enlargement definitely possibility. But if we are thinking minimal access or catheter based, then this is a good option, definitely.
What is your comment? Because this particular lady, I don't know you noticed it or not, there was very significant LVOT calcification. It was so, in fact, the mitral annular calcification and LVOT calcification were like a little chunk. They are originating from same place, and there was very significant LVOT calcification.
Yes,
so in that case, the aortic root enlargement, is it a little difficult from surgical point of view?
No. If 71 years with lot of calcification, definitely surgically we can remove every flex of calcium.
Much easier for them to remove.
Yes.
Calcium. So Sandeep, do you think in future all the valves, surgical valves, should have root enlargement first, so that put a bigger valve, as a bigger area, lesser valve degeneration, especially applicable for bioprosthetic valve?
Definitely, sir. Definitely, because not all patient requires this bigger valve.
And in the Notion trial, all these patients were managed best with best possible options, surgical options, isn't it?
Yes.
But even then, at 5 years, EOA was better in a transcatheter valve. So in smaller annulus, TAVI gets a kind of preference over surgical outcome.
No, because you are dilating it.
So we can go ahead with the next projection.
Thank you.
Yes, thank you. Thank you.
Arindam, just one question. What was the pressure reduction after this?
She had a very high, huge, gradient. I think gradient was more than 90, and it came down to 5.
5?
Only 5.
Oh,
absolutely no gradient at all.
So next case will be presented by Dr. Devapriya Mandal.
Good afternoon, everyone. It's a wonderful opportunity here for me to present a case in front of all the respected audience. This is a case which was done in our hospital at Medica, and in very short I'll be speaking about a specific complication. I'll not describe the details of the procedure, but I will focus on the complication. It's a very common complication, but then the risk of it is we can lose a life if not dealt quickly and in time. So this was a 80-year-old lady with a challenging femoral anatomy. The size was around 5.8 millimeters and 6.2 millimeters. All the pre-measurements were done. The valve was selected, and at 21.5 millimeter my valve was deployed with good confidence. It was a successful deployment. But at the end of procedure, he started requiring a higher inotropic support. So obviously it is nothing which is greatly difficult to imagine. We have certain protocols to find out what is happening, and then I'm going to show you what exactly happened. So this is the first shot on the left hand side, the left femoral artery anatomy. As you can see that this is a small caliber vessel, and most importantly in the morning we are describing or discussing the importance of an ultrasound guided puncture, specifically more so because the bifurcation of the femoral artery is almost near the upper edge of the femoral head, and the safe zone is very less. So when you are puncturing this, the puncture site will obviously go above, mostly above the femoral head, and the size, the diameter of the vessel is also comparatively narrow. This is a standard picture. We took a standard TPI axis from the left hand side and the another arterial axis, 6 French secondary axis from the left femoral artery. The primary axis for the valve deployment was taken from the right hand side, standard picture. This was the standard valve deployment. It's not moving. But all of these procedures, there was no complication. So the valve went on smoothly. We took a normal Safari extra small wire. There was no problem in negotiating the valve. Everything went on smoothly. And this was deployed at the normal views or coplanar views. And post deployment, the pressures, the difference in the aortic and the left ventricular pressures also became near zero. There was no significant paravalvular leak. This was the angiogram where there was a good apposition of the valve. There was no further requirement for a post dilatation, and cardiac contractility was also good. There was no evidence of pericardial effusion. So what happened was, now if we see, the left femoral side, we had started developing a bit of ooze from the very mid part of the procedure, and it had started developing an hematoma. So somebody was holding the site, and when we took an injection, there was actually the flow was not there. This was a access taken from the right hand side. This was a JR 4 French JR catheter, and so most importantly what has happened was, while taking the sheath or the 6 French axis beyond the point of contact, there must have been a small dissection or there must be a small perforation. So what was done immediately, and as we can see, if you look quickly, the bladder indentation was significant. At this point of time, it was a significant hemodynamic compromise with inotropic support requirement. So immediately from the right hand side, what was done was self-expanding covered stent of 5 into 60 millimeters, 8 into 60 millimeters was deployed, which took care of the vessel. Now even after that, if we see that there is a dissection in the proximal part of the artery, the flow was established. So there was a dissection at the, there was a tortuosity or probably a calcium present at that particular edge of the artery, which got dissected, and the dissection went on downstairs. So when the stent was put, the flow was maintained, the flow was established, but still we can see that there is a probably an extraluminal cap, what we describe in a coronary artery anatomy, and an extraluminal cap like feature, probably a type F dissection, which was taken care of. And still now, most importantly, see the bladder, as we all learned during our first initial days from Grossman, the first initial sign of an impending retroperitoneal hematoma is the indentation of the bladder wall that was clearly visible. And luckily there was no complications on the right hand side. The right hand side anatomy was clean, but obviously it was not good as I described previously, but there was no complications. So what we learned was the issues and the solution. If you are dealing with a high bifurcation of the femoral artery, it is a mandatory thing to choose ultrasound guided access and probably complement with a radiologically guided anatomy and ultrasound guided access. 5.5 millimeters artery or less, probably you should be ready to consider alternate access or be ready with a covered stent. And lastly and most importantly, panic is probably the worst possible thing which happens to us in a cath lab. But the only solution is staying calm and pre-plan things. Thank you.
What Dr. Siotia was alluding today, that vascular complications are the mainstay of problems which encounter in tower. So we can see here 3-4 complications. Our 30 cases, we have encountered 4 cases vascular complications, all managed, although all managed with this one managed with a covered stent. The previous one managed with a, again by asking surgeon to come. So it's not unusual to find it, and it was had it been a little late, patient would have collapsed. You can see the bladder indentation. It was a huge amount of blood had gone to retroperitoneal space.
Thank you, sir. Thank you, everyone. Sorry, ma'am, didn't get you. So, ma'am, we observed the patient. The hemodynamics picked up. Once the stent was put, the hemodynamics picked up. He required inotropic support for 8 to 10 hours, but the urine output went up. There was no signs of shock. CT scan was done, but there was no need to intervene at that point of time.
So, Dr. Dilip, what I am finding here, the way of doing TAVI in our center is like we take care of the contractor side first, and we always put V18 wire right from the beginning till the end. So if this step you somehow, if you obviate this step, you can mesh any time in a complication because you don't have time to wire sometimes.
We had a huge discussion in the morning. V18 wire is going out of use now, and the safety wire, because safety unnecessary.
So any wire, not a V18, but any wire.
That now there is a time of a right femoral and a right radial approach. You can very easily do the procedure. But yes, like this anatomy, this patient had a right 4.2, left barely 5.5, calcified, so we chose from left, and then we went up. And this patient again, the proglide got, it broke, and we had to quickly put a cover stent there.
See, the basic gold standard point is always remains gold standard. So we are trying to avoid the contralateral side, just we are again in a learning curve, but the gold standard thing.
But you will also see next couple of cases, you will also start avoiding, because the initial proctors who came and 1 or 2 did a safety wire, but I think right femoral and right radial is a good approach when there is non-calcified 7 mm, 6.5 mm right CFA is there, absolutely no problem.
Yes, yes.
Next.
Now we are moving towards the end of the session. Our last speaker is Dr. Subradip Datto sir.
Very good afternoon. Thank you for giving me the opportunity to present here. I will be presenting one case which is done in our hospital, in Medica Super Specialty Hospital. I will show one access site complication of a TAVR procedure. So our case was 86-year-old male, diabetic. He got admitted with ADHF, and we found in echo there was a severe calcific aortic stenosis with gradient, mean gradient of 56 with mild AR, and EF was around 50 to 56%. So this was so we planned for TAVR procedure, and this was the 3 Mencio report, and this a normal kind of report, like aortic annulus average was around 21.3, and the right coronary height was around 12, which is acceptable, and left coronary height was a little bit low, 8.1. And regarding the peripheral vascular dimensions, so our femoral artery dimensions, average dimension was around 5, and here we can see there is calcification and calcific spots in the right femoral artery. And so, like convention, we have taken a catheter and we have taken the common femoral artery shoot, and after that fluoro-guided puncture we did through via micropuncture needle, and wire was passed. It was very clean puncture, and as we can see, as a conventional procedure, we passed the wire along with the L1 catheter, and valve was deployed. It was a 21.5 ml my valve, balloon expandable valve, and it was the whole procedure was very done meticulously, and it was successful. Then while coming out, the proglide suture got snapped, and we exchanged with 2 7 French sheaths, and 2 angio shields were given, and hemostasis achieved. So there was no wire, and this is what we got the femoral angiography shoot afterwards. So as we can see, previously there was a good flow, now hardly any flow from the distal after the femoral head. So we took one crossover sheath and passed one diagnostic through an O32 wire. We passed one diagnostic catheter to see whether any distal flow is there or not. So this is the shoot we got. So after that we tried, we dilated with 6x40 Mustang balloon. So after dilatation, this was the scenario. So we were in doubt whether this is any dissection or any thrombus because of the footplate of our 2 angioseals. So we tried thrombosuction also, that we have not in the slide, with the penumbra catheter also, but after thrombosuction also the thing was same. So we thought we'll stent it, and we did stenting with EPIC 18 to 60 millimeter stent, and we post dilated with 7x40 Mustang balloon, and we got finally so this was the final result we got after post dilatation and putting the stent. So the learning points from this case was that is the access site complications can happen, and always to take femoral angiography before completion, and newer generation closer device, like here we had to use 2 angioshield device for 7 French. So newer generation device which are in tire we can use to close these large bore devices, and prompt diagnosis and management is definitely of paramount importance, and sometimes we need surgical intervention in this type of cases. Thank you.
I think what I could gather from this meeting and the complications, don't take it otherwise, Dilip. Out of 30 cases you have done, you have shown 6 complications, so complication rate is 20%. And that is only peripheral. But 6 presenters. Anyway. So no, I'm not blaming it on you. I think very important to manage, because the tower valve has improved so much now, only the access side has becoming the barrier, or the I would say is a mental barrier to do more TAVR in almost in all cases. So this meeting also gives us a lot of learning that managing the access site, going in, it should not be chakrabu, you can go in but you cannot come out. So those are important Indian exit. All these things can be, the block can be seen on ultrasound. Now there is also IVUS, application of IVUS. You go, or ICE, you go through the ICE from the jugular vein. On ICE, if you implant the valve, the chance of implantation, pacemaker has gone down by 800% to less than 1%. So this imaging, not only fluoroscopy or angiography, more and more usage of ultrasound has come to a help in understanding or preventing complications. Very good learning here.
Yeah, so we beggars are not choosers. So when we get a tower patient, we have to somehow try to do it these cases, because we can't choose patients. Look, your femorals are very tortuous, it's very calcified, so let's not be in early phase, you shouldn't be doing that cases. So it doesn't happen to us, because we have to take these patients up. And now for last 7 cases we are truly and totally on ultrasound guided puncture, and we are complementing fluoroscopy over that. But all these cases which I have shown, these are genuine problems which can happen to everyone. There is a calcified femoral artery, single prochlite got, it just broke. And then everyone was totally in soup, what is to be done. And there the classic teaching is, if you have Mantha device, you deploy. Otherwise you have to go and put a cover stent. There is no other way. That's morning hours. So Muntu was telling that you can do a post closure. Post closure is difficult. It's a 14 French hole is there. And in this case we did 3 years back. Our proctor told, no, let's do 2 angioseals. Entire tract is with blood. So you can't locate the anterior vessel wall, because the tract is also oozing, anterior wall is also oozing, so you can't make a depth assessment. And then you go in and deploy the angioceal deeper. Once you deploy the angioceal deeper, it's the entire collagen plug as well as the foot plate is inside the vessel. And that is what happened in this case, because you don't have assessment of depth here. And that is where Mantha device comes, where in CT you assess the depth. You are ready with Mantha device, okay, this much I will go in and deploy and come out. But here in this angioceal, we are totally lost. All of a sudden we have got this complication. We have no other way to deal with this. And I reviewed the literature. We should not have gone with 2 angioceals. We should have gone with a cover stent, which we shown in the last case where we had a problem. We quickly went and did a cover stent. So this is how we are evolving. And touchwood, one of my senior told that this is like Abhimanyu. You went there, you did the job, but you couldn't come out. So it shouldn't happen. Touchwood, we have come across successful in all the cases, but these are where learnings, and this is how this sharing can help others as well.
I did not criticize. Without complication, you don't learn anything. Everybody has gone through the complicated with the rota. It's not a criticism. To make the things more like the end of the day, that you should learn more and more. So if you had the ultrasound on the table, do you think that could have helped you in preventing both the plaque and the collagen going inside the artery or staying outside the artery?
These all understanding which now we are getting all this understanding. So once you do a case 3 years back and now you are doing, there's a hell lot of change in your understanding, and now we can do precisely and more effectively. So thank you, Dr. Subradip, and thanks to chairpersons and moderators. Now we move to the last session of the day, and what a wonderful sessions we had, so much of discussion, so much of learning. And I invite Dr. Subhasis Roy Chaudhary, Dr. Sanjay Sengupta, Dr. Somya Patra, Dr. Samik Chaudhary, Dr. Saujata Chakrabarti, Parijat, Rohit Kumar, Somyajit Ghosh, Sandeep Sardar, Dr. Sandeep Sardar, please come on dais. Dr. Rana Sarabjit, Dr. Subrasekhar Chakrabarti. Subrasekhar, please come on the dais. And there is a change in schedule here. Dr. Kamlesh will present. He has to take a flight. Dr. Kamlesh.
Okay. Dr. Kamlesh first with short-term MCS in heart failure. The landscape. It's been a very educative session right from the morning, and I think I should be thanking the organizers for it, especially Dilip Da to be organizing such a session where we keep on focusing on newer things that we are learning.
Good evening, everyone. My name is Dr. Kamlesh Kothawade. First of all, thank you, Dr. Dilip Kumar, for giving me this opportunity to present. on Impella. I am currently the head of the medical affairs for Asia Pacific region. I am also a medical doctor and trained in cardiology. So I will just take you through the journey of the Impella, what are some of the clinical trials and our learning in last 5 years. So these are the products which are available. We have Impella CP Smart Assist. I think Dr. Arun Kalyan Sundaram has presented an excellent case of Impella CP Smart Assist today. We have Impella 5.5, which is the latest device. We have Impella RP Flex, which is yet to come in APAC region. And then for all these devices, we have one console, which is called Automated Impella Controller. So a lot of new and exciting technologies are in pipeline, as you can see, right from the heparin-free perch, which we now commonly use in patients with very high risk of bleeding, instead of using heparin in the perch. We have low profile sheath, next generation Impella, Impella ECP, which is being talked a lot in various conferences. It's already done through the first in man human trial and early feasibility study in US. And we are awaiting the US FDA approval for that. It's just a 9 French pump. So as we are getting better at large bore access management, so we are also improvising on the technology such that we are smaller bore devices which will cause lesser complications. And many other products are there. I will not cover all of them in interest of time. So this is a slide I wanted to specifically incorporate because the theme of today's program is large bore access. And as you can see that the era of protective trial, which was done in 2007 to 2010 with Impella and IBP, if you look at the difference back in 2008, the bleeding complications with Impella are way higher, almost 14.6%, whereas IBP was quite low. And from that point onward, if you look at most recent trials which were done just 2 or 3 years ago, like Restore EF or Protect 3, the bleeding complication has come down to almost 1.8. So now the bleeding complication rate is almost similar between these two devices. Why this has happened? Why it's possible? I think there are multiple reasons. It's mainly the continuous improvement innovation. We have innovative devices like Perclose, we have AngioSeal, and now the latest one, Manta devices and many other new devices. But in addition to the devices, also the operator expertise, because every time we use the large bore device, there is always some learning curve, as we have seen some beautiful cases today on the TAVR, and the best practices over the years how we adapt to. So this has brought in the complications rate quite down over the years. So this is how the Impella pumps works. Oh, it's, yeah, okay, it's running. It's very easy to deploy. It's like inserting a pigtail. It's not that difficult. The only bottleneck in our experience is managing the large bore. Once you are good at it, the rest of the steps are quite easy. This is the device that unloads your left ventricle and improves your coronary perfusion as well as end organ perfusion. It can also provide right side support for if you use device like Impella RP, and you can actually ambulate this patient. Now coming quickly to the physiology of the device. So if you look at the part, on the top there is a Impella catheter cut section. Distal end is a pigtail. So just proximal to that there is a outlet, and at the outlet, because it unload your left ventricle, it reduces your left ventricular endosystolic pressure and volume. So your wall tension, your microvascular resistance significantly goes down, and your coronary perfusion and O2 supply increases. It also reduces your mechanical work significantly, reducing your O2 demand. If you look at the outlet at the ascending aorta, it increases your flow, that is your cardiac output, as well as your mean arterial pressure. So effectively increasing your cardiac power output. Now this is the video I am going to play. This is actually a patient operated by Dr. H.K. Bali from Chandigarh, and I represent with his permission as an example. So during this particular case, we come across a classic hemodynamic phenomenon which is called ventricular arterial uncoupling. I will explain that as I play this video. So just to give a snapshot, you can see the Impella console screen. The red is the aortic pressure, the green is the motor current on the device, and the white is your LV pressures. So as you come across a situation where you inflate balloon like shockwave balloon, or even we pass multiple wires in patient with multi-vessel disease or last remaining vessel, this type of situation, you are basically temporarily you are occluding the blood flow. So because of that, there is a transient hypoperfusion and your LV contractility goes down. And as your LV contractility goes down, your LV is not able to generate enough pressure to overcome the afterload of your aorta. And that's where you see the uncoupling between aortic pressure and LV pressure happen. So I'm going to play this video. I think seeing is believing. So as the balloon is inflated, shockwave balloon, you can see there is a flat line, so aortic pressure become completely flat line. So the LV is not contracting at all during this time. But your mean artery pressure is maintained, your coronary perfusion is maintained by impella. And as the balloon is deflated, you can see the pulsatility is back now. So your aortic pressure is pulsatile, it means your LV again start contracting. So these are the critical moments during the procedure, high risk procedure, where you need impella, because in absence of that, most of the time this patient would have crashed and you would have started CPR on table. And what you see in the real patient, it is also you can see in the theory, in the textbook, it's not different, which define your ventricular arterial incomplete. And this is something we are seeing almost more than 50% of the patient whenever we do impella assisted high risk PCI patient. So I will skip these slides. So this is a device, if you do axillary, I think we have great presentation on axillary insertion. So with axillary, the biggest advantage, you can ambulate this patient, you can make them walk. This patient you can see they are actually doing cycling on impella in ICU. That's a big advantage of being axillary insertion. Although it takes pain because you need to get a surgeon and you need a lot of coordination, it also takes time. This is the patient with axillary insertion of impella 5.0, and you can see she is walking down the hallway with minimum assistance. Now coming to the main indication of the impella, there is a two main indication. One is a high risk PCI or protected PCI. These are the patients which has patient comorbidities, complex coronary anatomy and hemodynamic compromise. So your ideal patient would fall somewhere in the middle, as you can see in the yellow. The second distinct indication for impella is cardiogenic shock. Now cardiogenic shock, the timing is very, very important. If you use impella at a very late stage when the patient already had a metabolic shock with very high lactates, kidney shutdown, shock liver, shock kidney, that may be too late. You may not see the actual benefit of impella because you are already past that early opportunity of using impella when the shock is hemodynamic. So to get the best outcome, we encourage to use this device ideally in first 12 hours, if not 24, to get the best outcome in patient with cardiogenic shock. This is the consensus paper which was published a couple of years ago by the Indian cardiologist, group of Indian cardiologists alongside of chief CTO meeting in Delhi. And this was tailored by Dr. Raj Sehal and Dr. Sanjog Kalra from US. Now this is the algorithm which gives you more objective evaluation of which patient would ideal to enroll for high risk PCI. Because the earlier what you see these three circles, it's very subjective and it can vary from people to people. So to bring some objectivity to that, there is a scoring system. And this score is widely used, and we also got many patients got insurance approval after submitting this particular publication because it's published data and it's objective scoring system. And it's very easy to calculate as well. So I would encourage all you to use this particular scoring system because it's an expensive device. And as you know, in India, not many patients can afford this device. So if you are deciding to use this device, you need to make right decision for the patient. And this will help you to do that. So I think I already run my time, so I will not go into the hemodynamics. But the one thing I wanted to cover here, whenever you use impella in high risk PCI, many times you see the flat line as I explained, and that is the reason you have to always monitor the patient with mean arterial pressure, not by systolic or diastolic, whenever the patient is on impella. It maintains your tissue perfusion, it maintains your hemodynamic during such critical moments during high risk PCI. And I will just go to the last slide. This is a publication from PROTECT-2 trial comparing impella with IBP. It was a prospective randomized controlled trial. And one thing I just wanted to mention specifically here. When we started impella 5 years ago in India, one of the common critiques that we used to get by highly skilled operator or operator who has practicing since more than 2-3 decades, that they have been doing these complex cases without hemodynamic support since many decades. Why they need such an expensive device? So I will just briefly give the answer to that. When you look at the data comparing Impella with IBP, they are absolutely right. First 2 or 3 days, the mortality, the MACE rates are similar between Impella and IBP. But as the number of days passes, you can see the curve start widening up. And by 90 days, there is significant difference between the MACE rate between Impella and IBP. So if you remove the Impella most of the time immediately after the procedure, why you see the benefit in the long term? Because Impella enable you to do complete revascularization. It enable you to do the lesions which most of the time in this difficult subset of patient, most of the operator, they'll just quickly get in and get out without doing the complete revascularization in absence of hemodynamic support device. And this is the biggest advantage of using Impella for such complex patient. So I will end my discussion here. Thank you very much for the opportunity. Any question?
Thank you, Dr. Kamlesh. Excellent talk. Let's have a little bit of discussion about the bleeding complications that you alluded to. If we do have bleeding after an implant has been implanted and we need to keep it for 3 to 4 days, what all can we do practically? Keeping in mind that if you're trying to put it in that 45-degree position, there's always a chance of it getting repositioned. These patients are on heparin, so they'll have more chance of bleeding. So what do we practically do?
I think practically there are 2-3 things we have to do. Firstly, you have to keep ACT strictly between 160 to 180 as close to as possible. If your ACT is running very high, then again bleeding chances increase. The second thing, as Dr. Arun Kalan Sundar mentioned, if you give little bit of angulation, I think that reduces your vascular strain and that minimize your chances of bleeding in particularly ICU patients. The third thing you can do, if you had taken already the perclose, maybe you can just tighten the knot little bit. It sometimes helps to stop the bleeding. Try to change a little bit of angulation to the insertion. All these things, most of the time it will help to stop that oozing or bleeding. Yeah.
I think choosing segment where there is less of calcium and ultrasound guide puncture, again it's a crux here. So ongoing ooze will not be there. There will be a vessel will be, the sheath and vessel will be in harmony. Unlike where a calcified segment, there can be a ooze from the sides. And also sutures cannot stay there, sometimes it can break.
Yeah, I mean, because like any other large bore device, there are complications. This device is not without complication, but I think if you fight the right protocol and steps, I think many of these complications you can either avoid or you can take care of that. Yeah. Thank you again, everyone. Thank you.
Thank you, Dr. Kamlesh. Next we have Dr. Gautam Saru speaking on insertion monitoring of the Impella. In the meantime, maybe Dilip, you can share your comments about which Impella to use. Should we go for 2.5, 2.5 CP?
I think if you are in need of a proper support, 2.5 is not adequate support, and CP should be the way to go ahead.
All practical purposes
CP.
So if you are using a Impella with the indication of the protected PCI and you are finding that the LV function is normal, so in that indication you can use 2.5, but right now 2.5 is basically phasing out and it is all come more by the Smart Assist 3.5. So again I will thankful to Dr. Dilip Kumar for having me here all across the Lucknow. And again, I will thankful to you that you raised a very relevant topic, because now the intervention cardiology is moving towards the structural disease and the high-end devices. So without knowing these large bore access and how to bail out the complication, it is very pertinent topic that you have chosen. Congratulations to you. So my topic was given is the Impella insertion and the monitoring. So again, the discussion is going on since from the morning. We all know that the good closer have always start with the good access. So again, I will skip this thing because we all know that the fluoroscopic guidance and the ultrasonic guidance is very important for any large bore access, and the combination with these two things, again the success rate is high. So the basic idea is to mark the femoral head, always assess the ultrasound guide, and again try to bypass the common femoral artery where the roof is calcified, because most of the time we forget to analyze the ultrasound with the calcified femoral artery. We puncture that segment from the needle, and most of the time we end with the failed proglide or failed angiocele or some kind of the dissection. Simultaneously use the contralateral side first, then take a wire, always access with the wire and try to puncture out that wire so that we can give the, you can take the proper access. So what is the factors that is very important to assess prior to insertion of the impella? You can basically evaluate the LV. If there is any LV thrombus, there is a high chances of the embolization of the thrombus material ingested by the pump of the impella. Secondly, if the patient is having mechanical heart valve, it is contraindication for the impella use. Aortic stenosis and the calcification, it might inhibit to pass the impella across the valve. Tortuosity of the iliac artery, you have to be very careful, but the company is providing the long sheet for this thing. And again, the multiple access, it leads to the closure complication that I have mentioned, that you should be very careful regarding the ultrasound assessment of the common femoral artery. If there is any calcified segment, try to take puncture below and above of that calcified segment. Similarly, as Dr. Kamlesh has mentioned here, there is basically three kind of the impella existing here. 2.5 smart assist, 5.5. 5.5 is basically for the surgeon's cases. 2.5, and right now it is replacing by the smart assist device. So if you see the impella device setup, it is an impella heart pump that is pre-connected with the cable, and there is a PTF replacement guide wire 018 with the purge cassette. Purge solution is very important thing to make the impella healthy motor running. It creates less hemolysis and all these things. And again, you will get a impella assist 30 centimeter and the 25 centimeter long sheath with the 8 French, 10 French and the 12 French dilator. So the basic step of the insertion is the assess the iliofemoral site of the both side. If there is calcification, you should consider the angioplasty or IVL. Consider the alternate access site as well. You just put the ultrasound there, take a good common femoral artery access, and take the 6F introducer sheath pre-close with the proglide, and then the strip wire you should insert there. And again with the 14 French sheath you can upgrade. The target ACT is more than 250 seconds. So you can take the pigtail catheter across the LV as like the tower, and then there is a 018 guide wire inside the LV, then device insertion and optimize the position. So again, this is the procedural step of this thing. This is the diagrammatic picture of that thing. This is the impella positioning. So the impella positioning can be done under the two things. One is the fluoroscopic marker, that is a teardrop appearance, which is easily shown in the plaques view of this routine echo, and you can measure the length. It is from the aortic annulus, it should be 3.5 centimeter. This is the ideal position of the impella inside the LV if you assess this on the echo guidance. And if you see the fluoro, you can see the fluoro in the two images. One is the RAO view and second is the cranial view. Sometimes in the RAO view you can imagine that the impella is placed very perfect on the left ventricle, but in certain view you will find that it is not in that view. So you can confirm with the two views as well. I will point a single access technique of this impella. There is they have intelligently put two access site in the impella sheath. One is at the 10 o'clock and one is at the 2 o'clock. So if you are predicting that you are going to complete your procedure with the 6F guide, you can use impella and one 6F guide catheter from the other access as well. So this is the single access technique of the impella. So this is the demonstration that I have taken from my case. The assessment of the femoral artery, took the access, crossed the valve, then place the pigtail, then change with the wire of the impella, and then again the impella insertion. So this is the proper step by step the demonstration of the impella insertion. Similarly, it was the second case of mine, micropuncture set, take the shoot, then again put the pigtail, put the wire, then implant the impella. So if you finish and you are very much confident that you are in the right place, you can just start the impella button, and there are some marker on this impella controller screen. So you can verify the placement. The verification of the placement, as I have described you earlier, you can mark this thing on the fluoroscopy, and the monitor that is known as the impella monitor, that is known as the AIC. You can see there is a alarm button. If the impella is properly placed and the cardiac output is good, it will show you on the monitor. So as the previous speaker has been shown you that there is a impella controller. It shows the red graph is the LV waveform, green graph is the motor current waveform. You have to see the important parameters in the LV side, that is the cardiac power output, and the cardiac output, LV pressures and diastolic pressure, mean arterial pressure. That you have to see on the monitor for the left side impella, and you have to see the PAPI on the right side of the impella device. There is two graphical presentation of the various other things, which you can assess if your impella position is not good. It will show on the monitor in the negative deflection in the diastole of the motor current. How to wean? So there is no universal accepted any guideline for the weaning. You have to measure the cardiac output, and that is the strong predictor of the cardiac mortality of the mechanical cardiac support. Once weaning and the escalation protocol, that is, you have to consider the weaning if cardiac output is more than 6 and the SpO2 levels, lactic acid and the urine output, that it all has to be measured in the ICU if you are going to wean it. How to wean? To initiate the weaning patient, there is 4 levels, that is P8, P6, P4 and P2. You have to just decrease 2 level and keep watch the cardiac output. If there is sufficient cardiac output and the cardiac power output, you can wean from P8 to the P2 level. So you have to wait for this gradual decrease of this P8 to P2 level and reduce flow to P0 and remove the impella device. When ACT is less than 50, you can normally we pre-close this impella to the ProGlide or one ProGlide or one angioseal that has been described earlier. Monitor the hemodynamics early. If there is no inopressor or vasopressor support needed, you can your patient is ready for the weaning, you can just switch off the things. So 3 steps to guide the weaning: look for the stable MAP and the LVEDP, assess the native heart recovery, maintain the cardiac stable cardiac output and the cardiac output. Then you can reduce P level to the P0 and just turn off the impella device, disconnect the connector cable, and you can explant the impella. This is for the protected PCI and the stable patient. So if you want to continue with the impella, you can monitor the impella in the ICU as well. For this, you can have to measure the PAP method, that is preload, afterload and the positioning. That is again the separate topic and the vast discussion. I am just finishing it out. And again, the concept of the impella is to basically increase the blood flow, increase the cardiac output, increase the mean arterial pressure, decrease the LVEDP. That all parameters you can assess on the monitor as well. So the takeaway is the impella insertion is again needs meticulous planning and the assessment of the femoral vasculature with the ultrasound as well as the fluoroscopic guidance. And again, the proper positioning of the impella is very important for the appropriate function of the impella. You can assess the positioning with the echo and the fluoroscopic guidance. Again, the PAP method is basically designed for the monitor impella in the ICU, which is important to understand the pathophysiology of the shock. So thank you. Thanks for the patient listening.
Thank you, Dr. Gautam. I think one basic point that you made, that you did mention, is when we are putting in the impella, and in fact any large bowel device, it should always be on a stiff wear. We learnt it the hard way one day. My question was, keeping it there and repositioning it from time to time is something that we need to do. So what will be the red flags when we think that we need to change the settings on the output? What will be the flags when we think that this needs to be repositioned? What do we look out for?
The IBHRE screen is a very smartly designed AI-enabled tool. When the impella working is not properly functioning, the cardiac output, the cardiac power output on the screen, it shows the decreased level. Again, there is an alarm that always buzzer you when the impella positioning is basically disturbed from the ideal side. At that point of time, you can basically see on the fluoroscopy as well that you're in the beginning of this thing, you have take the cine for the proper positioning. You can relate with the positioning as well, and then you can manipulate the impella for the further things. Once you manipulate the impella for the proper positioning, that alarm automatically shut down. So you can basically, this is the AI-enabled AIC screen. It will automatically gives the buzzer.
It's not always possible. The patient is in the ward and there's an alarm going on, so there's always a doubt.
So again, that is the echocardiographical assessment that you can see. There is a teardrop sign. You can assess the aortic annulus length and the teardrop sign. It is 3.5 millimeter, and it is heading towards the apex of the left ventricle.
Yeah, so I think say pictal has come into the pump, has come into the aorta. The graphs will show us that.
Graph will, the motor current will, the graph will show that your aortic pressure is basically coming down.
So what you will do?
So that
It's a wire, it goes with the monorail wire. So you cannot put through and through. So what you will do?
Your impella is totally coming out from there.
How do you reposition? Just push it, pull it.
So
or
if you are in the left ventricle, it is very easy to manipulate the impella. But if you are coming out, probably.
The aorta, say if you are in the aorta. Kamlesh, can you tell?
Kamlesh, can you explain?
Then what will you do? You have to come out because it's a monorail over the wire. It's not through and through over the wire.
Yeah. So can you hear me? Okay. So if the question is if the impella comes out in aorta and impella is already on, what should we do? So we cannot, yes, you cannot rewire this device because it's a monorail. The only option that left with you is try to push it, and we have seen in few patients just because of the weight of the device, quite bulkier device, even without wire it will go through the aortic wall, it will pass. But in the worst of the worst, if it doesn't pass, then only option is you have to take out the impella, explant it. Yeah, you cannot reintroduce. Once the impella comes out of patient's body, you cannot reuse it. It is disabled by the system. So then you have to use another.
So again, there is a valve outside the. There is a.
That will be complementary.
Dr. Yadav, there is a valve there outside the. When you insert the impella, there is a valve on the femoral level. If you place that valve, it is highly unlikely that it will move out from the aorta.
Yeah, I mean it's.
No, well, extremely rare, but it can happen, and this is how we have to manage. Cath lab into the CCU, and while during that.
It's very rare. I mean, we seen a couple of patients. They were shifting to take for the CT scan, and somebody accidentally pulled the device. So it's very rare, but it can happen. So, but it can be fixed most of the time.
So I think the main
problem. For the sake of time,
of,
I think we can move on with next presentation.
Okay, so with
Thanks,
the next
Dr.
presentation.
Kamlesh, I think.
Thank you, Dr. Gautam. Next we'll have Dr. Dipanjan Chatterjee will be
Amit
speaking on.
Malviya has
Or we'll have
requested
Dr. Amit.
to.
Okay.
Yeah.
Okay, sure. Dr. Amit Malviya will give us the evidence base with the product trials.
So in cardiogenic shock, we don't have any positive trial as of now. So and its use is limited to mainly and they also propose that in protected PCI it should be used first. Let's hear from Dr. Amit Malviya what are the evidence Protect 1, 2, and he will also give a little brief on Protect 3 after that.
Very good afternoon. I thank Dr. Dilip for having me come here for this large bore access workshop. And the whole day you have seen many practical cases of impella, and theoretical parts also have been discussed. And just wanted to share a small anecdotal story behind this device. Actually, impella is basically got a very brilliant young American physicist, Dr. Richard. He went to Egypt with his family for a vacation. So there he saw on the fields these farmers were using a small cylindrical pump with a screw inside, which used to be run by either hand or by using cattles. So it scooped the water out, and it used to scoop very fast. And this type of pump is basically called a Archimedes screw. Archimedes was a Greek mathematician way back in 3rd BC. He designed this screw pump. So when he came back, he had this idea and he started working on this, and that's how this Impala came. And after almost 3 decades of work, it got approved by FDA in 2005. So let's go and see how it basically, the theoretical part of it. So as we all know that patients with multivessel disease, unprotected left main, and with severe depression of left ventricular function, they have markedly worse prognosis than general population undergoing PCI. And historically, bypass surgery was an option offered to them, or sometimes the surgeon also rejected them, and they had no other option but to to be kept on medical therapy. And these patients pose an enormous technical challenge as well. While doing the PCI, there were poor distal targets, severe comorbidities, issues of reoperation, advanced age, impaired renal function were usually associated. So, as it was brilliantly discussed by our Kamlesh, that VA uncoupling, and during these complex procedures, you inflate balloon many times, many devices being put in and out. It has a very negative inotropic effect. It may be tolerated very well by routine patients, but those patients who are critically ill and comorbid, they may not tolerate it well. And there is the need of this mechanical circulatory support comes. And all of us, we know that IABP has fallen out of support because of many late trials of IBP shock and all. And those subset of patients were quite different from these, non-emergent high-risk PCI patients. And that is how this Impala thing started. There have been 3 trials on Impala, Protect 1, 2 and 3. And today I'll be discussing briefly about all these 3 trials. And Protect 4 is ongoing, results will be coming very soon. So Protect 1 trial was basically a safety and feasibility trial on basically a very small sample of 20 patients, unprotected left main, and some of them were last remaining conduit. And in that Protect 1, basically they showed that it is safe and efficacious. They did not encounter any major complications, any major issues with that, and it was demonstrated very well that it has a good hemodynamic effect while doing a complex PCI. So Protect 1 basically established Impala as a safe and effective method of providing hemodynamic support during a complex PCI. And then came Protect 2, it was in 2012 it started, it's a multi-center trial, and basically the design was a randomized trial whereby Impala versus IABP in high risk PCI. And in this trial basically patients with non-emergent high risk PCI on unprotected left main, last patent conduit with ejection fraction less than 35%. And once the angiography was done, once the other parameters were assessed, and the operator has already determined the need for circulatory support, then only the patients were randomized in 1:1, either IABP or Impala support with PCI. And the primary endpoint was a combination of many intra-procedural, post-procedural events, including MI and death and hemodynamic compromise. And secondary follow-up was planned up to 90 days. So as I said, primary endpoint was a combination of so many individual endpoints like death, Q-wave MI, stroke, etc., etc. The baseline characteristic of both groups were more or less similar, except for the fact that there were more cases of with history of heart failure and previous CBG in Impala group as compared to the IABP group. The 30 days outcome were basically, before I explain this slide, I must explain what is the difference between intention to treat analysis versus per protocol analysis. Intention to treat analysis is nothing but, suppose you randomize 100 patients. So you analyze the data of that 100 patient, irrespective whether they actually received the treatment or effect which you are looking for. So for example, suppose some patient was randomized and in the middle of study he left. So this patient data will also be analyzed in the final analysis, whether he actually took the treatment or not. So that is called as intention to treat analysis. Whereas per protocol analysis is patients are analyzed only if they have undergone the treatment completely. Means whatever intended treatment was to be tested has been administered to the patient and effects are known. So that is called as per protocol analysis. So in this trial, what actually happened in the midway of this trial, after around 400 patients were included, it was seen that the event rates in both groups were almost similar. And the Data Safety and Monitoring Board, it concluded that even if the intended population that was almost nearing 1,000 patients are recruited, the results would not change. So the trial was stopped prematurely. And at that point of time, 227 patients around in each group were randomized as such. And but incidentally, what happened as they announced the stopping of this trial, it took some days for the administrative things. Meanwhile, 169 more patients were recruited at various centers who were actually administered the treatment, either IABP or this Impella. So that is why this question of per protocol versus intention to treat analysis came. Intention to treat analysis is not very reflective of the actual treatment outcomes, per protocol is. So in PROTECT 2 trial, what we find is at 30 days, the primary endpoints were more or less similar in both groups, IABP versus Impella. But if you look at the 90 days outcome, as Kamlesh was showing, the curve starts diverging, the benefits started showing. And the reasons were discussed very well, because with the support of Impella, the procedures were more complete. The more complete procedure showed their benefit only after a certain period of time. And that is why the 90 days outcomes showed a trend of benefit towards favoring Impella as compared to IABP. So these slides I will skip. Basically, what important thing came out of this trial was that the number of lesions treated in Impella group was higher than in IABP group. Number of stent per patient put was higher in Impella group as compared to IABP group. Adjunctive therapies like GP2B3 inhibitors were lesser in Impella group as compared to IABP group. Rotational atherectomy overall was more, and more runs were given, including left main, in Impella group as compared to IABP. And duration of support was less in Impella as compared to IABP. This means, what it means actually is that the operators were more confident. They were able to deliver more completely revascularization when they were doing the surgeries or the interventions on Impella as compared to IABP. And that itself explains why the 90 days outcomes are better than 30 days outcome. And of course, hemodynamic support effectiveness it's better for Impella. The maximal decrease in cardiac power output, the systemic perfusion were definitely better than on IABP support. So in summary, this PROTECT 1 and PROTECT 2 trial, most importantly what they have done is that they have changed the paradigm of treatment of such patients. Means it is possible to treat them with support. It was not a IABP versus Impella trial, but it made an impression in the mind of cardiologists that such PCIs can be done. Because if you, such a patient, suppose severe LV dysfunction, unprotected left main, such patients and a surgical reject, TVD, if this patient is only on medical therapy, the mortality rates are suppose 40%. If this patient you do Impella supported PCI, the mortality rate at 90 days may still be around 36 or 38%. But the improvement in ejection fraction, the improvement in renal function, the improvement in symptoms is much better than when that patient is only on medical therapy. So that is what this trial proved. And then came the Protect 3 trial. As you know, Protect 3 trial didn't have a control arm. The treatment patients who were enrolled in Protect 2, that were the control arms. And Protect 3 very conclusively demonstrated that there was more improvement in symptoms, there was lesser bleeding and protection of renal function in a setting of protected PCI with such complicated cases as compared to the Protect 2 this mass. I thank you very much. I think I took a little bit more time.
Yeah, I think Protect 3 was a trial where operators were more mature in handling the vascular access, so bleeding were less, and they took your sicker patients. 32 was the mean syntax score in Protect 3.
Yeah.
And that is where the complete revascularization on Impella mattered, and that the results were far better. So we are moving in correct direction. More better.
Point very well made, Amit, because look at IBP, look at Impella, it's obvious that these works on different principles. We know that Impella is effective. I mean, there's no point of comparing apples with oranges.
Yes,
just because IBP was the gold standard at that point in time, we needed to compare it with something. But this is something that is much better than IBP. We know that.
Definitely.
But here IBP used was 40 cc.
Yes, sir.
And now if you will use 50 cc IBP, it gives 1.5 liter of support. So nowadays 50 cc IBP balloon is available.
And Amit, what does
35 ml as a an average?
No, we use 50 cc now, which is 1.5 liter.
And where do we start off with Impella, Amit? Maybe we can tell sir about where we start off with Impella. What is the support that we look at with Impella?
Sir, basically, see, Impella starts with 2.5. So, and plus, individual experiences, I cannot quote it as a data. So we don't have any data about 50 ml IBP. That is what I can tell you, sir.
Bleeding and mortality is higher. If you see the meta-analysis published in JAMA, they have shown the mortality and bleeding risk is significantly higher with the Impella as compared to.
Sir, the patient population is different, sir. Please understand that Impella is cardiogenic shock group. Patient of MI who comes in cardiogenic shock, their Impella versus IBP versus a case of non-emergent, means these are not emergency cases, these are planned PCI in high-risk patients. The score Kamlesh has shown, that score is more than 5. So these are planned cases, non-emergent. There is, Impella has clearly shown its superiority over IBP, there is no confusion.
I think
in the group of cardiogenic shock, acute MI, there is still some confusion, but sir, there is no enough data to say that this 40 ml versus 50 ml controversy.
That point is very well taken, sir, that bleeding complications are higher. That's why I raised that question to him, Dr. Kamlesh. I'm sure that with time, the French will come down, there will be improvement. But look at the concept of IBP versus the concept of Impella. There's no doubt that Impella is going to come in, it's going to stay in the future, and IBP is going to go out.
Thank you. So we move to the next presentation. Thank you, Amit. I think it was a wonderful presentation. We have 2 presentations left. Quickly we'll wrap up.
So what do we have next?
Dr. Dipanjan Chatterjee will speak on ECMO. So ECMO is a device which you can use. It is always available in the hospital, unlike Impella, which you have to ask for the to the company to get it there. So let's hear from Dr. Dipanjan Chatterjee.
Thank you very much. Next few minutes, we will be going through the cannulation and its problems during ECMO. Cannulation doesn't only mean the cannulation part, it's also the decannulation and post ECMO period that we will have to check it out. I have no conflict of interest or disclosures. So basically in ECMO what we do, we have to take out blood from the patient, pass it through a centrifugal pump and then give it back to the patient after that blood is getting oxygenated and decarboxylated through a oxygenator. And this giving back blood is either in the venous system or the arterial system, depending on whether the organ that we have to support is either the heart or the lungs. So accordingly we have a veno-arterial or a veno-venous ECMO or a combination of all of them. So in VA ECMO, we will be considering more in VA ECMO. In VA ECMO what we are doing is taking out blood from the vein, that is in the IVC through the femoral vein, and giving it back into a large artery, usually the femoral artery. That is a peripheral VA ECMO. Why we take it from the IVC? Because the largest vein, usually there is a non-collapsible part in the hepatic portion. And we usually cannulate the right femoral vein because that is a direct continuation with the IVC. Coming to the arterial access. What is the problem with the arterial access? In ECMO, we are putting the ECMO in a patient who is in a cardiogenic shock, and we want to put the patient as early as possible on ECMO to have adequate tissue perfusion. So the time is very limited. Compare it with the VV ECMO where we have a little bit of time to go about the cannulation process. VA ECMO has to be done pretty quickly because most of these patients are either sinking or maybe almost arresting. So we have to choose our hardware accordingly. What cannula size we want to use, we have to choose it very cautiously. So there are arterial and venous cannulas. Arterial cannulas are usually smaller and smaller in their diameter and length. And venous cannulas are usually longer, and usually they have multiple holes at the tip, so that because it's an ECMO, it's the venous drainage is by the negative pressure of the system generated by the centrifugal pump, that the veins can collapse. So if one or two holes gets closed, then also our flow will be adequate. We have a dual lumen venous cannula, but that is mainly for the VV ECMO. So usually for VV ECMO, what we choose is either a femoral venous drainage, and return is by a jugular vein, right jugular vein. So coming to the cannulation of the veno-arterial ECMO, we have to choose the type of ECMO where we want to cannulate depending on the condition of the patient. It's either a central or a peripheral cannulation. Central cannulation that we usually do in the theaters, the cardiac surgeons do always while going on cardiopulmonary bypass, whereas the peripheral cannulation that we discussed previously is we cannulate the femoral vein and the femoral artery. What is the problem with the femoral artery? Because the femoral artery we are putting in a very large size cannula, usually a 15, 16, sometimes 18 size cannula in the femoral artery. That causes a complete blockage of the distal limb, that the femoral artery which was supplying the limb, that the blood flow stops. So we need to put in a distal perfusion cannula in these patients. And this distal perfusion cannula gets the blood from the arterial return blood. So when we cannulate both antegrade towards the heart and retrograde, that is towards the femoral artery, that towards the limb. And this is the crux of our ECMO cannulation. So usually we put a sheath, 7 French sheath in the 6 or 7 French sheath in the for the distal perfusion cannula. So you can see that more clearly the distal perfusion cannula, which is connected to the arterial return cannula. But recently, to get out of this, many a times we may not get adequate access to the distal perfusion cannula because the patients do not give us so much of time. We might not get a proper distal perfusion cannula position. So we have a biflow cannula which can give both antegrade and retrograde flows. We can also cannulate surgically. If we are not being able to do it percutaneously, surgical cannulation, the vascular surgeons or the cardiac surgeons, they very frequently do for minimal access surgeries. And if our peripheral arteries are thrombosed, if it's a smaller size, then what to do? We will not get a adequate cannula size in, so we have to cannulate the axillary artery. Either we put in a graft there, or if we directly cannulate, again we have to put in a distal perfusion cannula. And this is the central cannula. Usually in the theaters we do it, and if the patient is not coming off bypass, or in pediatric patients, we can go on pump on the ECMO support by this cannulation technique. Sometimes in patients who are on VA ECMO, they can have an upper body hypoxia, that is Harlequin syndrome can occur because the heart can recover. But if the lungs have developed a pulmonary edema or a pneumonia and it is not oxygenating properly, whatever the left ventricle is ejecting is deoxygenated blood. So the brain and the upper part of the body gets the deoxygenated blood. So where we have to act fast, unless we act fast, we will have a patient with a stroke. So we have to put in another cannula. We usually put in another return cannula in the jugular, so that part of the oxygenated blood goes through the jugular to the left heart and the upper body gets oxygenated blood. And we have to regulate how much blood we have to give through the jugular and through the arterial route. Usually we put a clamp on the jugular flow because that is a low pressure zone and the flow will be usually higher there. So we have to put a clamp. So this is the cannulation. I don't think so much of time we have for this. So what are the problems that can occur? The distal, even if you have put in a distal perfusion cannula, there can be clot or not adequate flow within the distal perfusion cannula. So we need to monitor the limbs. How we monitor? Usually clinically by the temperature, by the color, by seeing the girth of the limb, by seeing the pressure within the calf muscles. And as these limbs become ischemic, the calf muscles becomes more and more stiff and color changes starts appearing. And if suppose we have not been able to put in a distal perfusion cannula in the initial part, we usually ask the surgeons to put in a distal perfusion cannula for us little lower in than the groin, so that the limb can be salvaged. And always we check the distal flow in the limbs. Monitoring the limb is very important. Distal flow is in the limbs by doing a Doppler on the popliteal artery and seeing how is the flow, how much is the flow we are getting. Usually it's a continuous flow, it's not an arterial trace that you will get. And if we switch off the distal perfusion cannula, the three-way, then we can see that this flow stops. So that can show us that the distal perfusion cannula is giving adequate flow or not. We can also put NIRS optodes because NIRS captures the ischemia, limb ischemia very early, so that will give you an early indication of our limb ischemia. And we also put the NIRS optodes on the head, on the scalp, just to monitor the cerebral perfusion, because the cerebral perfusion usually is our target. Adequate perfusion of the tissues is our target. Once the patient's heart recovers and the patient is ready for weaning, we put in a bridge between the arterial and femoral, the femoral venous and the femoral arterial limbs, so that we can clamp the cannulas and the circulation within the circuit can continuing. And always the ECMO decannulation, the arterial part is, we are still doing the surgical exploration and we decannulate the arteries. The venous cannula can just come off and we can put in a purse string. And always assess, there is a small dead space between the femoral cannula and this distal perfusion cannula where there is no flow, that clot can form here. So what we do is we take out the femoral cannula and we open the distal perfusion cannula end to see whether there is a bleeding or not. If there is not adequate bleeding, we are not happy, then we do an embolectomy of this part. During eCPR, cannulation gets very difficult. Even with the ultrasound guidance, the CPR is going on, it is quite difficult. Sometimes we have to take the help of the surgeons to put the patient on ECMO. One last case, the patient presented in our hospital with right ventricular dysfunction with MI, and the patient was in shock. We put the patient intubated, ventilated, and then also in spite of high inotropic support, the patient was sinking. We put in initially an IABP on the left limb, and then we put the patient on ECMO through the right femoral artery, right femoral vein route, and initially the ECMO was fine, but we put the NIRS optodes on the limbs, and what we found that the left limb, that is the femoral artery where we have put the IBP, that is showing a quite low flow, that is is ischemic. So we did an embolectomy of that, took out the IBP cannula. Initially, after the clots came out, there was adequate flows, but after again a few hours, we found that the flow is again going down, the limb is getting ischemic. We did a CT and we found that the distal to the popliteal, there is blood vessels are not very good, and we continued the patient, and after around 7 to 8 days, the patient came off ECMO, was on dialysis for a few days, and then went home. So our access cannulation, the initiation of our ECMO, if it is good, then usually we can expect a better results. If we have a falter during the cannulation, we injure the blood vessels, we have a bleeding, or our distal perfusion is not adequate, then our outcomes are going to get hampered. Thank you very much.
Nice presentation, Dr. Dipanjan Chatterjee. May I know something regarding today's topic, large bore access, as you are cannulating femoral artery very frequently. So what is your opinion regarding access site closure? Will you shift to device closure or anything else?
Whether we decannulate surgically,
yes.
Surgically, or we will take the help of our ProGlide and do it. We can take the help of ProGlide, but we have to remember that there is some dead space between the femoral access and the distal perfusion access. There can be a clot. Even if you have a proper closure of the artery with the ProGlide, and you can stop bleeding from the artery. That is why we are not taking out the cannulas, arterial cannulas percutaneously before, because there is a chance of bleeding. But once the ProGlide has come, you can do it, but always remember that we need to access the distal flow even after taking out the femoral arterial cannula.
No. What I am asking in future, what is your plan? Will you go for the ProGlide or will you still continue this surgical closure?
So ProGlide gives a better closure technique now, but we have not experienced it personally. And if you ask me, I am very happy with our surgeons doing it. Okay, we can see the arteries, and we have not faced any arterial complication post decannulation till now. Our surgeons have been very excellent in it.
Yes, thank you. And last question. Do you have any experience with this new smart venous cannula?
The Biflow we have not used yet, but if we get it, we will use it definitely.
Okay, so you have plan. Okay, thank you so much.
So we have moved to the last presentation, and that is we have seen so many cases discussed in very granular manner, the access complications and how to come out. So we all want to live longer, isn't it? And when we want to live longer, we need to have support from the statins, the Rozulip, and the kind of new medicines which have come up, which can reduce your LDL drastically, and our longevity can be more. So let's look at the real situation. So even with so much of evidence, 80% of post-acute coronary syndrome patients are not on target LDL cholesterol. And when we target less than 55, it's 79%. And if it is less than 70, then 55% of the patients are still not on target. So a huge number. So we'll just go through a couple of minutes, 3-4 minutes to take the presentation. Let's look at a patient, Mr. Abhay, who's a young patient. He's hypertensive. He's a software engineer, and he has a non-STEMI.
and a stent was placed. And then since Abhay is struggling to adhere to his treatment because of his busy schedule and professional demands, he would like to have some drugs which can be less frequently used and not on a daily basis. The second is Ramesh. He's a retired banker, enjoys spending time with grandchildren. He's hypertensive with type 2 diabetes and 2 PCI in last 3 years, recurrent events. And again, he finds difficulty in adhering to treatment due to high treatment burden of existing lipid lowering therapy. So daily he has to take medicines. And Kalpana is a trained classical dancer, and she has again a multivessel disease treated, and she is concerned with the about having high risk of having another CV event, as she had undergone already a procedure. So look at the evidence and the risk stratification. They all fall in very high risk category. So when they all are in high risk category, the LDL cholesterol goal is less than 55, and what they are having is the treatment goal as per 55. They are having a LDL of 154. Ramesh has 154, the other one has 80, and Kalpana has 120 milligram per DL. So they are quite having LDL which is way above their LDL goal, and that is where the recommendations are important, which drugs to be chosen. So this is 2023 ASC guideline. If the patient is LDL NAV, statin NAV patients, and he is coming with acute coronary syndrome, you can start with a statin as well as ezetimibe, and look at 4 to 6 weeks duration, the lipid profile, and if the LDL is still not in goal, you can add PCSK9 inhibitors. But those who are on statin, on ezetimibe, they have got acute coronary syndrome, you should not be wasting time in reaching the LDL cholesterol goal of less than 55. You can quickly put on these patients on PCSK9 inhibitors. So we have newer therapies, from traditional to recent therapies. We have newer therapies like inclisiran, bempedoic acid, which can help us getting to a place where we want to, an LDL of less than 55, and this is how we achieve the kind of LDL reduction maximum with PCSK9 inhibitor plus high intensity statin plus ezetimibe up to 85%, and many of these patients will reach their goal. And this is a reflection that if you reach lower LDL, the odds for MACE will be much in favor of reduction in primary endpoints. So I will not go through these trials, which is known to everyone. EVOPAX PCSK9 trial, if you start early, then the the event rate is lesser, and early initiation of lipid lowering therapy, if we hit hard, hit early, then we have got a good outcome trial. And that is where all these three guys, Abhay, Ramesh and Kalpana, they need a drug because they haven't reached their goals, and this gap is huge. You see, someone has a 80 and 120 and 74, much more than the 50 goal, and inclisiran can fit in. This is a small interfere RNA, where it works, and the PCSK9 is not there, so LDL cholesterol receptors are more in action, and they can reduce more LDL from the circulation. So with this, we have got some trials like Orion 8, 9, 10, 11. Orion 8 is having you see there looking at the patients who were randomized with 9, 10, 11 in Orion 8, and they are pulling up data, and they are showing that the inclisiran could reduce LDL cholesterol, and in the long term, the outcome can be even better. So the first and only LDL cholesterol lowering therapy indicated for HCP administration with 6 months dosing guarantee, and it can be given twice yearly. It has ability to achieve 2023 ESC guideline LDL levels, well tolerated safety profile, and has got effective and sustained LDL cholesterol reduction. So with this, I end here with key takeaways, that especially acute coronary syndrome patients, those who are recurrent MI patients, recurrent procedure patients, we need not waste time, and achieving a cholesterol goal of less than 55 on LDL, and if the patient is already on high dose statin and ezetimibe, we should be quickly going on a drug which can give a better sustained reduction of LDL and a better life to these patients. Thank you so much for the patient hearing, and here we end today's large bore access workshop. I thank from bottom of my heart to everyone. You see, we are ending and we still have around 30 to 40 people left around and hearing and sharing their knowledge. Thank you so much.
And hope we have it again next year.
So any comments from anyone who is there? Amit, Gautam, Dr. Anil, Dr. Monga. Yeah, and we have seen how our results have improved over time. So the complications which we have shown, and which is 2-3 years old, now all the cases are going so smoothly, and thanks with it has happened because of my team effort. So everyone is contributing. So when we used to do ultrasound guided access 2 years back, in all the cases my cath lab staffs used to get pissed off. But Dr. Kumar is always telling, bring a echo machine, bring ultrasound machine, and everyone. But nowadays everyone is saying, because they are seeing the benefit. They are seeing that they don't have to press harder, longer, and these devices are working, precise puncture is happening, less of hematomas, and we could do impellas, TAVIs, and we'll take it forward. And maybe if Dr. Dipanjan gives us a little bit of place, we can go there, do some proglides in his ECMO cases as well. Yeah. Thank you. Thank you. Now I want to invite the main sponsor of this event, CIPLA. So may I invite Palash to say something? And then Gurvinder, Jayanto. So CIPLA team has really worked hard and they deserve a special kind of applaud. Please come on, dais.
Thank you very much, Dilip sir, for this platform. I think we at CIPLA has been always being very keen in terms of partnering any scientific event, and especially very happy, place like Kolkata eastern part, you are having a very specific program and a one-day program, which serves the purpose of most of the busy practitioners, and always looking forward, sir. Any good cause, CIPLA will always be forefront in partnering. Very happy to see that overall participation from the morning itself. Otherwise, today is issue scientific event. Getting attendees inside hall is very difficult.
Vipin, you will tell something?
Yeah.
Vipin has come from Patna, and it would be great hear from him. Yeah.
I want to thank you, sir, for organizing such a wonderful conference. And this is one of a unique topic, which is one of its kind. I think first time happening around this over in whole of the country. Yes. And especially this large bore access, we are beginners in this. And I've never used TAVR, but I used to put aortic graft stents, iliac stents, and all the peripheral. So in those cases, I used to call surgeons for opening, and they opened it for me, and then I used to put. Nowadays, I have started using this proglides and angiosil I was using for a long time. Like you said, I have initiated, like in all femoral cases, I have switched over to angiosil now. And proglides I have just begin to use, but for last 2 cases I have the same experience. I broke the wire. So I thought that I have done some mistake in using this or something.
These are all 3-4 factors which we discussed.
Yeah. So today's workshop was very great and such a nice experience, and learnt a lot. And I'll use now when I go back, then I'll use now ultrasound guided access.
Thank you. Thank you. Jayanto, you will tell something? Gurvinder? Diman?
First of all, I would like to thank Dilip sir from the core of my heart, as sir has given the opportunity to participate in this wonderful conference of large bore workshop, access workshop. We are really grateful to him. This is the second time we are participating with him. I would like to owe my gratitude for him. I would like to thank him, and we have to get to more and more of such participation, because Novartis is always in the dissemination of science, and we are the pharma company which we look for the science and newer innovations, innovative products in the field of cardiology. So thank you, sir. Thank you very much.
Good evening, everybody. I am Gurvinder. I work for Abbott, and from the core of my heart, I would really express my thanks to Dr. Dilip. It's really out of the box thinking, that to create a platform to discuss only access, large bore access, successful closure, because I see many expensive procedures in all the domains happening, but sometimes we get into some problems just because of the access. And it's a first of its kind program which really gives us motivation that it should become bigger with the more participants, though it was a very beautiful to see right from the even the timing of the program. People were here in the hall, and really congratulations for such a successful program. And when coming to access, believe me, when 12 years back Abbott brought in per close, we realized it's just a concept to establish that where a patient gets free of cost manual compression, why should we use closure device? Today we understand the value of the closure devices when we do large bore procedures, and it's still evolving. Thanks once again, Dr. Dilip, and we are always there to help assist, train more and more people on the devices so that procedures become more easy and complexity free. Thank you.
Dhiman, and finally I will call two guys who were right from beginning were there, Anish and Visudeep. Without you it was not possible. Please come up, both of you, for a picture and small words and a few words. And Dhiman, tell me something.
Good evening to all of you. Dhiman from Teramo, representing Teramo. We already have been a long association with Sir for long time, and we discussed this concept for the 1 year back, and this time it is going to happen. And really, it's again, as everybody says, it's a unique thing. Almost first time I think in India, that you have think in such a way that yes, and Teramo also believe in this, that right access and right closure is one of a half job done. So if you choose wisely all the access things, either it's a large bore, definitely it's an evolving segment now for this time. And I think for that, the entire from Teramo and from our industry, it's a big bow down for you, sir. So that the way you have think and the way you represent this region as a national level, I think it's give a really big round of applause for you. And we are Teramo, as you know, that we are already been associated with and it's a commitment for us that we should continue this journey with our newer therapies and newer concept. And again, I must congratulate you for this successful event, sir. Thank you so much. Thank you.
Now here the men who started the concept, sir, do something and we will be the sole partner for you. We will not allow anyone else to be there. But gradually I invited device companies, and also I thought one slot to be given to English Run, which they have requested so much. So, but everything, the success goes to them. They have done huge work right from the beginning. So both of you.
Yeah. So thank you, Dilip sir. So as rightly mentioned by our leader, Mr. Palas Banerjee, that CIPLA is always into the academic programs. And as rightly mentioned by sir also, since last 6 months we have been requesting sir that sir please allow us to do some academic programs wherein CIPLA can participate. So thank you sir, and I congratulate you and the entire team. It was really a wonderful program. Though we have learnt a little, but I think all the participants have learnt a lot. And in future also sir, it's a promise from our side that in any conferences or any such programs, CIPLA will be participating with you sir. Thank you so much and congratulate. Anish, please.
First of all, thank you Dilip sir. I think yes, lot of discussions from our cluster head Mr. Santosh Jagtap to Palas sir, everyone has come, we have discussed, and yes, we being the only to bring, because every time when you go na sir, in northern part, western part, southern part of India, they are saying this large bore everything. So I think first time in eastern part of India and from the hands of Calcutta, and now we can proudly say that large border east shines from the sun shines from the east. Thank you, sir, and thank you everybody. And definitely, sir, it will be continued, just a start, sir. Thank you, sir.
Thank you.
I forgot him because I think he is a part of our journey or not. And the entire, so smoothly we did it. All the guests were taking care, and this is what you see, everything, Arnab and Sunil, they are phenomenal, I tell you. And he is not anymore a kind of a professional associate with me, he is like a family member. And I asked him to just say a few words, and then we'll proceed for a picture. Yeah.
No, I'll just say just one thing. Hopefully, we are able to match everyone's expectation, and everything was seamless for everyone. So, sir has been innovating since long, and we will be participating in all these events. So, thanks all for coming and making it happen.